Welcome, everyone, to WEDI's 2025 Spring Conference. I'm Michael McNutt, WEDI's VP of Education and Marketing. It's my pleasure to introduce our Executive Director, Rob Tennant.
Thank you, Michael, and let me add my welcome. This is going to be a wonderful conference, and we'd like to start off by just giving folks a little background on our organization, and just in case you're not familiar with WEDI and what we do. In fact, you could make an argument that all of health IT owes WEDI a bit of a nod, because really the launching pad for health information technology transformation was passage in 1996 of the Health Insurance Portability and Accountability Act. And you may ask yourself, where did HIPAA come from? Well, it goes back to the early 1990s when then Secretary of HHS, Dr. Lewis Sullivan, convened what he called the Working Group for Electronic Data Interchange. As a practicing physician, he knew firsthand some of the challenges that providers and payers face in trying to exchange health data. So he called in laterally to his office some of the leaders in healthcare representing health plans and providers, vendors, and standards groups, and talked about how the industry could make healthcare exchange more efficient and ultimately better for the patient. And so the Working Group for Electronic Data Interchange produced two reports, which were then folded into legislative language, which became, of course, HIPAA. So in the law, WEDI is designated as an advisor to the Secretary of HHS, and we perform that role ever since. And you can see here we have very strong relationships with a number of government agencies, including the Assistant Secretary of Technology Policy / Office of National Coordinator, the Centers for Medicare and Medicaid Services, and the Office for Civil Rights. In fact, ASTP and CMS both sit on the WEDI Board of Directors. So we are a multi-stakeholder organization. We represent health plans, providers, vendors, standards development organizations, operating rules, developers, state and federal government, and more recently, we've engaged with patient advocacy organizations. So we're very pleased about that. We have 18 work groups, sub-work groups, and task groups, and I'll talk about those in a minute. But overall, our role is simple. We convene, we collaborate, we educate, and we influence. And if we go to the next slide, we'll talk about our work groups. So we have 18, and you can see here they range from things like value-based care to attachments, property and casualty, provider information, genomics, privacy and security. Virtually all of the HIPAA transactions are covered. We also have emerging technology, and you heard some of the podcast about AI, and that's one of the areas that work group focuses on. We also have one focused on the No Surprises Act. That is a task group that was stood up once the act was passed, and it's a very vibrant group discussing the data exchange challenges associated with that law. And I'm very excited to talk about our latest work group. The WEDI Board of Directors just recently voted to stand up the Patient Experience Work Group. So we're naming the co-chairs, and we're developing the task list for that group. But if you're interested in things like digital health, in patient access APIs, telehealth, and other issues like that, I would encourage you to seek out this particular work group. Next slide. Oh, I will say, if you're interested in our work groups, we have a list of all of the work groups, the co-chairs, and how to get involved at wedi.org. For those that are app enabled, I would encourage you to download the Whova app. We've got a number of activities, contests, and things like that on the Whova app. I would strongly encourage you to engage your fellow attendees. It's a chance for you to reach out and message, just like you would at a face-to-face conference where you might see them at getting a snack. So use the Whova app and take full advantage of your networking opportunities.
And Rob, I'd like to just hop in here for a second. Bill put into comments a couple of really good points. WEDI membership applies to every employee of your organization. If your employer is already a member, you receive benefits. So email us at wedi.org if you need a hand getting involved, or contact Ariana Poole at apoole@wedi.org. And for the non-members in today's meeting, or if you're not sure about whether you're a member, contact Bill. His email is in the chat as well about learning more about membership.
Appreciate that, Marilee. And yeah, I think the one thing that we find is we have a very strong group of volunteers. That's really what makes WEDI unique in the industry. The amount of collaboration that occurs is phenomenal. We're a place where various organizations representing different groups can come together to talk about challenges and how to overcome them. So it's a very safe space for folks to get involved. And again, it's a chance to work collectively towards solutions that we're all looking for. This is not the only educational event WEDI is going to be offering over the next few weeks. I wanted to remind folks that you can go to the wedi.org site and click on education and events, and you'll see all of these. But I did want to highlight a couple in particular. As you all know, the new administration has put out a number of requests for information, or RFIs, and we're going to take advantage of, in particular, the one that was just released a few days ago called a Health Technology Ecosystem. So that is going to take place on the 28th of May. And again, an MPA, or member position advisory, is a unique opportunity where WEDI members can come together to talk about issues raised in an RFI or a proposed rule, and come up with a consensus-based set of recommendations to give to the WEDI Board of Directors, who then will finalize our letter or comments that go directly to the federal government. So again, May 28th, you'll hear a little bit more about this RFI later, but certainly put it on your calendar. And as well, we're very focused on the CMS 0057 final rule. And so you'll see here we have a number of events coming up focused specifically on that final rule. So next slide, Michael. We couldn't bring the type of educational content like you'll see over the next few days without the help of our sponsors. So a big thanks to our platinum sponsors, Edifex and MCG, our gold sponsor, Itility Health, and silver sponsor, Drummond Group. All of these folks are very wonderful partners with WEDI. And again, a big thanks to them. And I encourage all of you to check out their websites and see if they have solutions that will help your organization. To ask questions, to make comments, take advantage of the chat feature on your Zoom toolbar. And as a reminder, the slides and recordings will be emailed to all attendees after the event, but they'll also be available on the Hoover Spring Conference site in the community section. And with that, it's my pleasure to turn it over to Danny Brennan, who is the WEDI Board Chair-elect, to introduce our first speaker.
Thank you, Rob, and thank you for that introduction. It's my great pleasure to introduce Dr. Brian Anderson, who is the Chief Executive Officer, the Coalition for Health AI, or CHI. Dr. Anderson and CHI are focused on developing a set of consensus-driven guidelines and best practices for responsible AI, as well as supporting the ability to independently test and validate AI for safety and effectiveness. Prior to leading CHI, Dr. Anderson was the chief executive physician at MITRE, where he led research and developments in digital health alongside industry partners in the US government. Dr. Anderson was responsible for leading much of MITRE's work during the COVID-19 pandemic, closely working with the White House COVID Task Force, as well as Operation Warp Speed. He's led the largest MITRE R&D effort in oncology, focusing on the initial development of EMCODE and the use of AI in more efficient and inclusive clinical trial design. Dr. Anderson is an internationally recognized author and expert in digital health, is regularly engaged as a speaker on digital health transformation, health standards development, clinical decision support systems, and interoperability. With that, Dr. Anderson, welcome to the WEDI conference. I'm going to turn it over to you.
Thanks so much, Denny, for that very kind and warm welcome. Clearly, you got the notes that my mother sent along. I appreciate that.
I did. She and I were in constant contact over the last few days.
Well, I've been looking forward to our time together. And let me go ahead and share my screen, and we'll go ahead and dive right into it. Hopefully, folks will be able to, you can see my screen now, yes?
We see your talking notes screen from PowerPoint. So you may want to flip that around to the presentation version.
Thank you for that. All right. Hopefully, let's see here. Okay. Hopefully that works.
There we go. In good shape.
Fantastic. Okay. So real pleasure to be here. Really excited to dig into some of the work that the Coalition for Health AI, or CHI, like the spiced tea, that we've been engaged in over the past year. We spoke to you a couple of years ago, and so a lot has happened in this space since we launched CHI as a nonprofit in February of last year. The topic of my presentation is really going to be focused on, building off of that work and the grander vision that we have within CHI, which is, how do we take all of the work that we're doing, building these consensus frameworks around practice, best practices for a variety of use cases, taking into account the values in responsible AI, but the goal really being around human flourishing and exactly what that means. So I'm going to go ahead and dive right in. And I think what we're going to do is I'll be speaking for 20 minutes and reserving the last 10 minutes for questions. So certainly if you have any questions, please feel free to put them in the chat window or raise your hand at the end, and I'll try my best to get to all of them. So CHI started almost 5 years ago in the middle of the pandemic. It was during that time that I had been asked by the Trump and then subsequently the Biden administration to be helping to lead the response for Operation Warp Speed in the White House COVID Task Force as part of the monoclonal antibodies and the data analytics effort. Those were my areas of focus. It was during that space, though, that you had a lot of private sector companies working alongside the federal government solving this, or looking to try to solve this pandemic-related challenge we were all facing. We realized how much impact we were having, and a few of us began asking, a question: is there something more that we can be doing beyond the pandemic? We looked at AI, and we asked a very basic question: do we have consensus at a deeply technical level that would define what responsible AI looks like and inform a software developer developing it, a health system implementing it, or an AI governance committee managing it longitudinally over time? The answer we quickly came to is we do not have that kind of consensus. And that really was the birth of CHI, is bringing together a group of health systems, technology companies, patient community advocates, to begin building that technically detailed set of industry best practices on what responsible AI actually looks like, that can inform those developers, that can inform health system administrators and AI governance committees. I'm really excited that it grew really quickly from those 8 or 10 organizations that founded it, to quickly become a true public-private partnership. The US government very quickly joined all of our working groups and has been, continued to be engaged across the aisle. It is not just a Democrat or Republican issue. It's candidly something that we all should be involved in and concerned about. So that's a brief description about what CHI is. When we think about just by the numbers and really kind of where we're focused, CHI has at this point over 3,000 different member organizations. I think we're probably the largest health AI coalition on the planet. I never would have thought that it would have gotten so big. Clearly, AI is having a moment. We have over 200 health systems in the US, and so that's the vast majority of the health systems. We have a growing payer and health plan community. We have over 75% of our members come from the industry side. So these are like tech companies, and about 25% of those are startups, meaning they're with between 1 and 50 employees. One of the really important parts about CHI, as we build these consensus best practice frameworks or industry standards, is that we really ensure that we're putting the voice not only of the patient and the doctor and the nurse, but the startup central to whatever we do. We do not want to create the kinds of standards and frameworks that enable regulatory capture by just a few entrenched incumbents. And so CHI is, engaged in that. I'll candidly say probably very hard work of building consensus across competing organizations, but it's something that we've been successfully able to do. Just a brief slide of some of our founding members. Don't mean to focus too much on this, but broad swath in the digital health space. Okay, so let me really dig into some of kind of what we focused on. I'd mentioned earlier that it's about building these technically specific and detailed industry best practices. We really look at it from a model's life cycle and not just any one specific moment in time. When we think about an AI model and you step back and you kind of imagine what its life cycle will look like, you can, at a very high level, think, okay, well, there's a development phase where you're defining the problem, you're designing, you're engineering the system and the solution. There's the deployment phase where you're assessing it, where you're piloting it, and really you're hands-on using it in production environments. This could be, a use case for a payer engaging with the patients that are, or members that are part of their health plan, or it can be used by a health system and a doctor and a nurse looking to make clinical decisions, or back office administrative workflow support. And then the final stage, right after that deployment phase, is really the monitoring or the governance and management phase. One of the really important and unique things about AI, I'm sure everyone appreciates, is that it's dynamic, it changes. Unlike many tools that physicians and nurses use, these AI models can learn, they can improve, but they can also drift and degrade in their performance. And that's one of the really important features in an AI model's lifecycle, where we need to be paying very close attention in what we would call the post-deployment phase of a model, where we're monitoring and managing it. And in each one of those phases, there are important questions like, what does fairness mean in the design phase? Well, an example might be, you want to make sure that you have a set of data that you're training the model on that is diverse, that is robust, that is actually married to or matched closely to the kinds of patients in the intended use for that model. So the intended use and the patients that that model is being used in are actually represented in the kinds of patients that the model's trained in. In the deployment phase, one of the best practices might be, well, where do the recommendations, if we're talking about a clinical decision support model or a use case, where do those recommendations pop up in an electronic health record? I'm a physician, and I think, one of the, things that physicians are unfortunately, I think, very famous for when it comes to EHRs is if there's an annoying pop-up or something that comes on the screen with a recommendation and it comes at the wrong time, physicians are going to exit out and ignore it and not even listening to it. That's called human cognitive bias. That kind of bias can be worsened if, in this case, the CDS recommendation pops up at the wrong point in the cognitive decision-making of the provider. It could be the best recommendation since sliced bread, but because it came up at the wrong time in the clinical workflow and my cognitive decision-making, I'm going to ignore it. So what are the best practices on how we mitigate that kind of bias and that kind of risk? We tackle that in the deployment phase. Another example, as I mentioned in this monitoring or this post-deployment phase, one of the real challenges actually that we're focused on right now is what are the metrics that we're using that we need to focus on to monitor these models to make sure that they're safe and effective. Ambient listening. There's a lot of excitement, particularly in the physician space, about using these kinds of tools to free physicians from staring at their keyboards and their computer screens rather than engaging their patients in meaningful conversation where they're actually connecting and looking at each other. Well, in that case, what are the metrics that we're going to use to monitor accuracy and performance? Do they vary by specialty? Is there more than one metric? Are there multiple metrics? What kind of partnership needs to exist between the vendor, which may have some deeper level of insight into a model's performance, versus a health system or the payer where it's deployed? These are all examples where we really dig into at each one of those phases in a model's life cycle to build those consensus standards, and then also inform things like what are the metrics we're using to evaluate these models. Just as an example, so one of the working groups, we have about a dozen of them now. One of the working groups is a very broad working group tackling the whole generative AI space, which of course is a very big space. It includes all of the excitement around certain frontier models like Gemini or ChatGPT or Claude, et cetera. There's a whole bunch of them out there. But then taking the principles of responsible AI, and I've listed a few of them here. Usefulness, its usability. How readily able am I as a physician or a nurse or a patient able to understand the recommendations and use it in a way that impacts and improves clinical outcomes, clinical health of my patient? Safety and reliability. Is this model going to give safe and effective recommendations, or is there a risk? It may be a small risk, but is there a risk that it may give a very dangerous recommendation that could put a patient's life in jeopardy? And how frequent or often do those recommendations change? If I were to control the inputs, meaning if I'm talking about LLMs and generative AI, if I ask the same question of an AI agent in an LLM, if I ask the same question 5 times, is it going to give me the same answer those 5 times? Or is it going to give me different answers? Is it going to hallucinate one of those times? This is a concept of reliability. Security and privacy, obviously, this is a very important space in health. Our data is very sensitive. How do we make sure that the models being deployed on this data are not going to enable re-identification or somehow in some way take the privacy that is central to the use of this data and risk that with data exposure? Fairness and bias. So of course, models that are trained well on certain populations and demographics of people are more likely to perform really well on those kinds of people. Whereas if I use it on a different population, a different subpopulation, it might not perform well. How do we understand the intended use and make the appropriate disclosures about a model's performance on various subpopulations? This concept of indications and limitations really comes into play in this space. And then transparency. I think myself that this is perhaps probably the most important principle because it builds trust. What are the minimum thresholds for a developer to share about their model with a customer, be it a payer, a health plan, or a health system? What does that customer need to know about the kinds of data that the model was trained on? What does that customer need to know about the model's performance, as I mentioned, on different populations of people? CHI is bringing together the vendor community and the customer community to define what those minimum thresholds are, that minimum bar of transparency, to help inform the users and the vendors on models that are safe and effective. So I included here a snapshot of a video. I'm sure everyone has seen car crash test videos where you have a car that's rapidly accelerating, into a stationary object, and then the airbags deploy, and then scientists determine if the car crash dummy survived or not. This is an example of quality assurance labs in the automotive space. The Insurance Institutes for Highway Safety, the National Safety Transportation Board, there's a number of them. Independent organizations that have no conflict of interest, that test rigorously, in this case, cars or trucks, for their safety. And they might give it a 5-star rating or a 4-star rating. And there's examples of these across different sectors. One of the more recognizable ones is consumer electronic reports. Maybe there's been a point in your life where you wanted to do your due diligence and do research before a major purchase, be it a washer machine or a dryer or a refrigerator. You might find yourself going to consumer reports and understanding, what is the reliability? What do other people think about this? How is it tested? Is it going to clean my shirts and dry my pants? That's an example of a quality assurance lab. We don't have quality assurance labs in AI, and that's a major issue, particularly in a consequential space like health, where people's lives literally can be on the line. We need to enable this kind of independent entity or ecosystem of entities to be able to rigorously evaluate for all of us to help understand how these models perform. Now, remember what I said about health data being private and secure? That's really important. And you don't want data necessarily in the health space to be exposed, to be moving around. You want to limit that as much as possible for the safety and privacy of individuals. And with the right consent and disclosures, what CHI is developing is a nationwide network of quality assurance resource providers. Now, the exciting thing about these quality assurance resource providers is they're, for the most part, health systems, and there are tech platforms that are partnering with health systems. There's about 30 or so health systems that are part of this growing ecosystem of labs that we've launched. And we'll be sharing some exciting news about this next week, actually. So stay tuned on that. But what this network allows is, if you envision these labs, because they actually do match and follow kind of this map that you see on your screen, geographically diverse, different populations of people from coast to coast, the ability to evaluate models across multiple different subpopulations. Now, the other really exciting thing about these quality assurance resources is that they can not only help with model validation and testing and evaluations. Two additional things that are really important. These labs can accelerate access to the kinds of data that health systems, that vendors need to train models. If you were to ask any startup in the health AI space, what's the biggest challenge that they have? The biggest challenge is access to high quality data. That's what these labs enable, is access to that kind of high quality data. So you have on one side, accelerating innovation, accelerating model training and development. And on the other side, you have the ability to accelerate the kinds of evaluations and independent, rigorous testing to understand how these models perform. Now, the third thing that these models, and I'm really excited about this one. Remember, I'd mentioned this concept of post-deployment or post-market surveillance. If you look at the FDA, they regulate a lot of different things, from foods to all sorts of different drugs to devices. Nearly in every single one of those instances, from the food we eat to the medical devices that we have in our hospitals to the drugs and vaccines that we take, there are post-market surveillance networks to evaluate, to monitor how these things are actually working out in the real world once it gets through the regulatory decision-making. We don't have that in AI. The FDA does not have any insights into how these models are actually working once deployed. That is a huge blind spot. This network of quality assurance labs enables that kind of protection once a model is deployed, to be able to monitor how is it performing in different communities. Is there drift? Is there degradation? Where do we draw the line, and what's the concern, for any given model if the performance does degrade? These are some of the important questions that we candidly haven't answered yet, but we're on that journey together. Because remember, it's all about how do we build these kinds of frameworks and metrics And what are these thresholds for evaluation where we get concerned about a model's performance? These labs cover, importantly, different communities from, and I have snapshots here of where some of the labs are located, from inner city Chicago to rural America to tribal nations, people from all sorts of different walks of life. We want to build AI that's going to serve all of us. We need to be able to test AI on representative patient populations from all of us. Now, very quickly, before we get to questions, I know I want to leave some time for questions, is we're rolling out a model card. It's like a nutrition label that you see at the grocery store, but this speaks to that minimum threshold of transparency that we're getting to, so that a customer or a patient has the kinds of data in a nutrition label, an AI nutrition label, that can help inform them things like intended use, and what it shouldn't be used on, right? What are the inputs used to train the model? What are the metrics used for evaluating the model? These are things that go into that. And this is just a long form version snapshot of it. The other important thing I'd mentioned about the post-market surveillance is CHI is launching a nationwide registry where all of our health systems, the 200 plus, are going to be able to participate, sharing their model cards, and importantly, beginning to share real world evidence, grade data, that is being generated locally at their health system on how these models are performing. We believe in CHI, in transparency, in sharing this kind of information transparently with the public, with regulators, and importantly, with the vendors that we work with. And so that kind of transparency is going to be rolled out in the nationwide registry. Now, I'm going to close really briefly with a comment on Gen AI. If anyone tells you that, we have consensus on some of these principles yet, they'd be lying to you. As an example, we don't have consensus on how do you measure bias in ambient listening. We don't know yet. We don't have agreement. And so one of the really important things that we're focused on is building the kind of regulatory or evaluatory science in AI for generative AI particularly. This is a kind of intelligence AI that we've obviously never encountered before. And, different kinds of statistical methods have been developed in different periods of human history, from the ANOVA curves to the Kaplan-Meier estimators. These are all biostatistical milestones in our history. We need those kinds of tools and approaches and methodologies in generative AI rapidly, particularly because of the consequentiality in health AI. Now, I'll close with this one final thought. It's great that we're focused on doing this technically detailed level of work. And what are the metrics for bias? What are the metrics for transparency? What are the minimum thresholds for transparency that go into a model card? Ultimately, though, and I was really excited when President Trump signed his executive order earlier this year, and he called out three main policies for the US: economic competitiveness, national security, and human flourishing. When CHI thinks about human flourishing, we want to ensure that these models are able to advocate and support the patients and nurses and doctors that use them. One of the big challenges in AI is this concept called the alignment problem. Are we able to develop models in the Gen AI space that are aligned to our values? In the world of agentic AI and this road ahead that we have, where you have semi-autonomous and autonomous use of AI, it is going to be incredibly critical that we have frameworks for model development where these models are able to understand an individual patient or doctors, but let's focus on a patient's values and priorities for their health. If we aren't able to do that, an agentic AI future is going to be, candidly, very dangerous and probably not utilized much because people don't trust it. So how do we build trust through solving the alignment problem is one of the key areas of focus in CHI. So I'll wrap there. I'll stop there. Let's see. I'll stop sharing my screen and look for any questions that we can take in the time remaining.
Brian, we have several questions on the chat. One of which is addressing. And Phil asked this, is one way to help address model evaluation and trust in the field, like the ensemble spaghetti models that are used for hurricane forecasting, where you run multiple models, present the end user with their alignment or their misalignment so that, the end users build, trust in their interpretation of multiple perspectives rather than having a single perspective presented to them. Would you comment on that?
It's a great question. I've never had that one before. And coming from North Carolina, where I've had lots of family members live, I'm very familiar with the spaghetti model of the hurricane forecasts. Honestly, I mean, yes, it would be helpful, right? I think transparency as a bedrock principle in CHI is something that, would be always helpful to inform the end user, be it a doctor or a patient, on the variety of different recommendations, given, a controlled, input that you put in. If different models are giving different recommendations, different spaghetti tracks, it'd be helpful to inform a provider and a patient that variance. I think the reality is that these are very expensive models to procure. And so oftentimes ambient listening or a sepsis model, the health system is usually only going to make one purchase. And so, they're going to kind of go with that one versus procure 4 or 5 different ones. I would say where it's possible though, meaning if there's open source tooling that, organizations can use, or in the rare instance where they may have multiple models that could deliver a recommendation for a specific use case. Yes, I think that would be helpful. I would support that kind of idea.
Thank you. Tim asks, can you share more information about the membership about payer membership in your organization, and whether or not they are as actively involved as, for example, the providers?
This is a great question, Tim. So CHI is 1 year old, right? We started back in February of last year. When we started CHI, I would say many of us that were part of, the beginning launch of this, and this is really because of the work we were doing in Operation Warp Speed and the COVID task force. It was a lot of health systems, and it was a lot of technology companies. And I think because of that, there was less engagement on the payer side. And I agree with you. I think, one of the areas that I'm very interested in is how do we bring to the table the payer and health plan community in a way that the health system community, healthcare delivery space has come to the table. I would love to follow up with you and, share more about this. But, right now we have some of the fairly large payers that are founding members of CHI. You have United, you have Aetna, you have Cigna, you have a number of regional blues, but it's not all of them, right? Humana and several others aren't part of CHI. CHI is a big tent, and we welcome them. I think, we can only do this kind of consensus building that would be relevant and adopted if it's done in partnership with other groups. So we are working on it, but open to any advice and recommendations anyone has on how we can bring more in the health payer and health plan side to the table.
And Chris asks, are the AI model cards that you referenced generated by the platform service provider, or are they published by CHI? Are they meant to replace or supplement more granular AI fact sheets?
So great question. So I guess I'll share a story. A health system that launched a procurement RFP asked the vendors that were responding to it to share their model card, because they believed, and this is what they told each of the vendors, that if you don't, you're not going to be able to be part of this procurement because it's just going to slow you down too much. It's going to, the sharing of a model card is going to accelerate the procurement process by at least 6 months. That was their number. And so, currently these model cards are self-attestation, meaning the vendors provide the information themselves. Now, if you remember, there was a section on there about the evaluation report. That is an example of one section where we are asking vendors, if you are going to share a model card, and if you have taken that model through one of these quality assurance resource providers, please share the report card that comes from that. So that's an example where it's not self-attestation. But for the most part, Chris, this is a self-attestation. And so it's really, trusting that the vendor is going to share transparently. But on CHI's end, to your second question, we are publishing these model cards on that registry. And we are offering a lightweight validation service to the vendors and the health system or the customer community, payers and health systems, to understand if we, CHI, have taken a what I'll call a lightweight look, not really digging into, exactly show us the data sets you used, but going over it in detail with the vendors to add a greater level of trust beyond the self-attestation that the model cards are currently.
Dr. Brian Anderson is the Chief Executive Officer of CHI, the Coalition for Health AI. Brian, thank you so much for spending some time with you. If we collect additional questions, post your presentation, we will forward those to you. And thank you again for lending your insights, expertise, and this powerful collaboration that you're charged with managing with the WEDI community. Thank you.
Well, it's been a great pleasure. Thank you so much for your time, Denny. Yeah, thank you again.
Thank you, Denny, and thank you, Dr. Anderson. It's my pleasure to hand it off to my colleague at WEDI, Nancy Spector. There she is. Nancy, you're on.
Thank you. Thank you, Michael. Kept saying it that I couldn't unmute myself. So I was thinking maybe that was a trick you were playing. Good morning, everybody. Welcome again to the first day of our full conference. And I'm happy to kick off our next session by introducing Jolie Rizzo. Jolie comes to us to be a moderator of our panel on addressing national issues at the state level. And Jolie has over 15 years of experience. Previously was responsible for communications and marketing, government relations and advocacy, event strategy and strategic planning. She previously served as the Vice President of Strategy and Network Engagement for Civitas. And she is welcoming to the session a panel of speakers. We have Melissa Kotris, Chief Executive Officer from Contexture, and Phil Beckett, Chief Executive Officer from Texas Health Services Authority, and Stephanie Brown, Executive Director from CRISP DC. So Jolie, I will turn it over to you. Thank you.
All right, thanks, Nancy, and thank you to Michael and Robert and others at WEDI for hosting us. Excited to be here today, and apologize, I'm getting a little bit of a funny background noise because my hotel is right next to train tracks. But anyway, we are going to dive in and we're going to talk about solving some of healthcare's toughest issues at the state level. And so to do that, I've invited 3 Civitas members. And for everyone who's maybe not as familiar with Civitas Networks for Health, we are a national nonprofit member organization. We represent members all over the country in pretty much every state. And our members are health information exchanges, all-payer claims databases, quality improvement organizations. We have health collaboratives, community information exchanges, 211s. But really the premise is our members are either sort of moving or using data. So we like to talk about ourselves as being the bridge between data and doing. And with that, I'm going to dive right into conversation with Melissa and Phil and Stephanie. Thank you all for joining today. I think it'd be great if you wanted to take just a moment to, we've done your introductions, but if you wanted to just highlight a little bit more about your organization so people understand where you're situated in the country and the type of work that you do. So I'll ask Melissa to come off mute first and then pass to Phil and over to Stephanie.
Wonderful. Thank you, Jolie. Pleasure to be here today for this presentation. As was noted, my name is Melissa Kotris. I am the CEO at Contexture. We are the health information exchange and in the new model of health data utilities, the emerging health data utility in Arizona and Colorado. We serve statewide in both of those organizations, and Contexture is really a combination of what was previously 3 different HIEs, Health Current in Arizona, Coreo in Colorado, and Quality Health Network in Colorado. So we've been Contexture for about 4 years now. In addition to standard health information exchange services, we do work in the areas of quality improvement, data analytics, social determinants of health and community information exchange, and advanced directives. And we'll talk more today about how we support our states, especially public health and Medicaid. Thanks.
Thanks, Melissa.
Hey,
Phil?
good. Thank you, Jolie. Good morning, everyone. It's great to be here. Phil Baggett, Texas Health Services Authority is a quasi-governmental organization in Texas, which I've figured out being quasi-governmental is not the best place to be. You either want to be government or not government. In between is like gives you the worst of both worlds. But there you are. We're in Chapter 182 of the Health and Safety Code in Texas to enable, implement, and promote interoperability across the state. We're a big state. Like California, New York has multiple health information systems. We have data silos today. We're really around promoting that interoperability, but really more than just the pipes, but the impact of this data, which really aligns with what Jolie's saying about Civitas and from data to doing. So it's we really try to standardize, get communities working together to have usable data that has impact locally, and then of course statewide. Thank you.
Thanks, Phil. Stephanie?
Hi, everyone. I'm so happy to be here. My name is Stephanie Brown. I am the president and executive director of CRISP DC. We are a standalone 501c3 nonprofit here in the district, and we are the designated health information exchange. But similar to what Melissa said, we are also the emerging HDU serving the district. So we do focus on sharing traditional health data, but we also share a lot of social needs data, advanced care planning data, and other data types through the HIE, like lead registry, for example. We are also an affiliate in CRIS Shared Services. So you may have heard this name before. CRIS Shared Services is an infrastructure vendor that provides HIE infrastructure to a few other states. And so regionally, we are able to share data amongst some neighboring states for the continuity of care, because a lot of people in the district, in Maryland and West Virginia, do cross borders for care. That's a little bit about DC.
Thanks, Stephanie. And hopefully we can come back to why it's so important to not only serve the set geography you're in, but also start to sort of make those connections beyond your set geography for continuity of care. So we'll come back to that. And just so everyone knows, I was intentional about selecting this panel because I think it's important that we do bring together folks who have that unique perspective for the geographies that they serve, and their markets do look different. There are different sort of political drivers, and yet we are here still trying to solve, again, some of healthcare's toughest issues by having more robust, ready data. And so before we talk about I think we should need to set the stage as to what are some of the most pressing issues. So I'd love to hear from the three of you and just, kind of, again, have you all just rotate through what you think are some of the most pressing issues we're facing right now. And Stephanie, you want to jump in on that?
Sure. So in the district, we are anticipating some changes to people falling off and moving back onto Medicaid. And since we do have a high percentage of people who are on Medicaid in the district, and in DC, we are designated by Department of Healthcare Finance, which is actually DC Medicaid. And we have the management of health in DC, which is managed by 3 different agencies. And so we work closely with Medicaid, and the majority of our funding and the majority of our initiatives are to serve the Medicaid population. So focusing on that, a lot of what we do is to support the care for the Medicaid population in the district. So what we have been doing in anticipation for some of these changes is planning on helping with redetermination. So we have many reports, many alerts to help the health centers and healthcare providers support their patients through redetermination and other things that may be coming down the pipeline for Medicaid in the future.
All right. Yes. I feel like there isn't a day that goes by without talking about Medicaid right now. But yeah, that's critically important work, and we can talk more specifically in a minute about sort of what that's looking like and how you really are helping. Melissa, did you want to jump in? So again, what are some of the most pressing issues in healthcare right now?
Sure, I certainly agree with Stephanie's point about the changing landscape around Medicaid. I think that healthcare financing in general is something that everyone's keeping an eye on. Certainly changes in Medicaid, whether it's redetermination, whether it's work requirements in the future, whether it's other changes to financing mechanisms. I think everyone is bracing for what those changes will be and how it will impact our communities. In light of that, I think everyone's looking for efficiencies and how infrastructure and the systems can be supported in the changing environment and what that's going to look like in the evolving landscape over time. The last thing I would say is I think we're seeing continued changes in the public health environment. So we're, right about 5 years from the beginning of COVID. That obviously changed our public health landscape. And as we, exited the pandemic and look ahead, I think there's still a lot of open questions about public health infrastructure and what that should look like, both in the technology space as well as in the general, oversight surveillance space as well. So those are just a few things, but we're just in a lot of change in healthcare.
Just a few things. Bill.
There's plenty to go at. A similar theme, but I feel like, we, even in the Medicaid population, which is, I look at the numbers in Texas, where our per capita spends about 16,000. For nationally, the per capita spends about 14,000. It's just too expensive, our healthcare, and there's so many opportunities through care coordination, removing data silos, getting to reduce those costs and make it a much better experience for each of us individually as patients. So I'm really trying to move the needle in Texas because that's there's some winners in that spend, but there's a lot the communities don't necessarily benefit from. How do we change the model to more community finance models that empower individuals and reduce the cost of healthcare and improve the outcomes? And we'll talk about kind of what we're doing to try and do that. But I think, and then narrowing it down is really a focus on, and in Texas, Medicaid is mostly kids and pregnant women. And how do we help them in community models drive down or improve their coordination and drive down those costs?
Well, I'm glad that you brought up care coordination, because I do think that is, it kind of touches everything, whether we're continuing to further support public health, if we're working to support the Medicaid population. But I think, we talk about this idea of whole person care, addressing non-medical drivers of health, and looking for opportunities to improve care, to improve outcomes, and, to reduce costs. So let's talk more specifically about how, just, one example, if each one of you wanted to share a specific project you're working on, either within the district or within the states that you serve, the geographies you serve. And Melissa, I'll jump in and lead out on this.
Sure. I assume there might be some focus on Medicaid, so I'll choose the public health angle, although we do work in both of these spaces. From a public health perspective, we serve 2 different states with 2 different environments and 2 different strategies when it comes to public health. So one of the things we have to do is be pretty flexible. We have always served in different cases for public health reporting as an intermediary. So we're getting so much data and information shared from the healthcare sector. It makes sense to utilize those data feeds for multiple purposes, not just for sharing information and having a clinical data repository of information at the patient level and medical clinical histories, but also for being able to share information for purposes of public health reporting. So we've served as an intermediary for purposes of immunization reporting, syndromic surveillance, newborn screening, different solutions in different states based on the needs of the state. And also we've started to do work around identity management. So public health a lot of times has multiple silos of data, and now public health agencies, a lot of them are evolving in this data modernization era. But we've have a master person index that's been in place for, across our three, legacy systems, close to 20 years, if not over 20 years. And so we manage identities really well, and we can help public health to link those systems together. We also do reporting for public health when they're doing case investigations. Public health in Colorado is one of the highest users of our portal for being able to access the appropriate clinical information at the right time for case investigations. So the list can go on and on. We do reporting for opioid overdoses and other things, but really the purpose here is that one connection to an HIE or a health data utility can serve multiple purposes. And that is the intent of a health data utility, that you're not just doing clinical data exchange for purposes of care coordination and treatment, you're serving multiple purposes with multiple different types of data. We even do work with public health on social determinants of health and social needs. So it's just that data trustee role that we play can serve a lot of different constituencies and a lot of different entities. And we've had a growing opportunity to support public health infrastructure as they work on data modernization initiatives.
Thanks, Melissa. Stephanie, you want to jump in and talk about, again, what you're doing more specifically?
Sure. I love to highlight two unique use cases here in DC. So Jolie has heard me talk about them before, but we have unique data sharing connections with DC public schools. So we do receive absenteeism data for people who opt in with guardian consent here in the district. And what that allows for is us to create alerts to care providers if someone has reached a certain threshold that was determined with one of our local hospitals and the DC public school program that we're working with. If they've reached a certain threshold for absenteeism data, they will receive outreach. And what that has done has allowed care managers to do outreach to students and their families who may have social needs, may have health needs, and had some truly amazing outcomes. In a non-traditional way that we can look at public health and also partnering with other agencies like public schools outside of the traditional HIE and moving into that HDU framework that CRISP DC is. And then next we have our lead registry. So that's with our Department of Energy and Environment. So we do receive lead registry data. So here in the Northeast, a lot of the older cities, over 80, close to 90% of our buildings were built before lead paint was illegal. And so that means there's a high rate of exposure to that, also in the pipes. And so that being said, we help with reports for hotspotting. We help with reports for management of people being tested twice by the age of 2. And this is also similar to what Melissa was saying, a public health framework in which someone is then using the HIE for care as well. And just to kind of tie all of this together to what Phil and Melissa were saying is now, especially with the renewed focus on reducing waste in healthcare, through providing this care coordination, HIEs have also reduced the amount of duplicative tests for years. And so these use cases, the lead one specifically highlights that, but if you think of more traditional care coordination, you can think about imaging and lab tests and what have you. And so they've really allowed health systems to use one connection as well through the HIE rather than many individual connections in order to share this data and reduce those duplicative tests and those costs. So at the same time we're doing this care coordination, we're also able to reduce waste, and that's really kind of the foundation of our value, is to be able to do multiple things at one time for the different interested parties and stakeholders who may have different goals. And so we bring all of that together.
Thank you so much for sharing those specific use cases. And I think, it's really interesting to think about how we can get to a place of using data, using information to start to do true prevention, which is really the goal, is to get out in front of it. And so to hear about the absentee data and how that's making an impact for these children and their families is really incredible. Phil, I'll have you jump in.
Yeah, no, thanks. And maybe I'd like to give two baby examples as well. One we did was a newborn naming convention that's been adopted by AHIMA and NAHAN too. But you know, when babies are in the hospital, they're not given, they don't know their name at that point, so they name baby girl Rizzo or baby boy Beckett or whatever, you know, baby Beckett. And as those babies move between facilities, if there's something wrong, and we've got real examples of this, then the names don't match up, and so you know can't find the records. And then, and for babies, some things like thyroid or you know metabolic impacts are really time critical and can start destroying brain cells. So time to care is critical. So we have a baby naming standard that's been published. It's out there. I don't want to get in the weeds because I want to be careful of time here, but that's one thing, just as a data usability and coordination entity, trying to get the whole state and hopefully the whole country all name our babies in a standard convention. The second one, and again, I think at this point in my career, this would be solved, but this is in Tarrant County, Fort Worth, working with a group there. There's hospital delivering babies. Then there's a durable medical equipment provider who provides both breast pumps and blood pressure cuffs to monitor for eclampsia. And then we're an MHMR group, so we're looking at behavioral health for these moms too. There is so much data isolated in these, so they all want to coordinate and make it easy, but you've got people in clipboards, you know, photographing face sheets and then typing in demographics. And we're trying to pull this whole group together. How has this become seamless without duplicity of just administrative duplicity? Make it easier, and again, make that experience just great for that mom. Looks like we all know what we're doing.
These are all incredible examples and just kind of scratching the surface of what HIEs and HDUs can really do to begin to solve, again, some of these pressing issues that we are facing. There's a question in the chat from Danny Brennan about the current administration leading towards supporting state and regional HIEs. I think there's a real interest in real-time data sharing and the potential. And then, you know, he's wondering about the national networks, which kind of dovetails nicely into the next question I'm going to ask. So be thinking about that question as well as we sort of pivot our discussion. One of you said, I think it was Stephanie, about the sort of need to be, or actually it might have been Melissa, but anyway, data trustees, data stewards. And I think it's really important that we take the time in this conversation to talk about the critical nature of local networks, doing this work locally, you know, building partnerships, being collaborative, all of the examples that you shared. Those do not just happen. Those take time to sort of really be curious, to go deeper into what are the actual barriers, to start to look at, you know, how you can change a workflow. So I'd love for you to comment on why you think local networks are so important within a set geography, but then how can we also use that to think about how we are going to solve some of these issues nationally? And also, what does it mean for other sort of national networks in participating and deepening connections as we think about interoperability? Big question.
Not a small question.
Go for it, Melissa.
Well, I'll start off, and that is that, you know, our organizations are governed by the communities we serve, and healthcare happens locally. We all participate in national networks and support national interoperability initiatives. However, there's always going to be things that are different state by state. Our board at Contexture is you know, comprised of half Arizona and half Colorado stakeholders, healthcare stakeholders, and we serve the needs of our states. We have multiple programs that are state specific. So what we're doing in Arizona is different than what we're doing in Colorado. There's different alternative payment models, there's different incentive programs. And so that's what's unique about organizations like ours, that we have standard infrastructure and we meet national standards and we can exchange through national networks, but we can serve the needs of our communities, which is going to be different across states. It just is. So I think there's a place for both national networks as well as state-based and regional initiatives that are governed by the community, because we do different things. We just serve a lot of different initiatives. And we also connect the last mile. A lot of the national networks are able to connect a lot of big systems. There's a lot of interoperability that's happening between big systems. But I had a board meeting in the last week, and one of the board members who serves as the CIO of a large system said, I am depending on Contexture to connect the last mile. I need that data, my providers need that data, and we need all of that community information to be shared in order to be able to best serve our patients and our communities. And sometimes we debate that in the interoperability space. And I think it's critical. We serve behavioral health organizations. We send and share Part 2 data. That is very difficult to do across national networks, if not impossible today. And so we're just able to do different things that serves the needs of the communities.
Thank you. I'm glad you said that. I think that the last mile can't be overlooked. Like when we think about why we are doing this, why we are looking to really sort of serve those who may be overlooked. If we overlook the last mile, those on the fringe, we're going to miss a real opportunity. So that's super important. Phil, I saw you came off mute. Do you want to jump in?
Yeah, just to add to that, and I'm a big supporter of these national networks, but they are, I mean, to give a simple example, they're really query based. You don't know that the patient went to this other facility. The only way you know that is through local HIE. And we've shown in reducing potentially preventable visits by sharing these event notifications with our participants so that they can intervene and say, you don't need to go to the ED for that. We're saving the state today somewhat above $5 million a year. So, and we could, of course, do more, but I think knowing what's going on and having that as push actionable data is only going to come through local and why they're critical.
It's also a great point. Stephanie.
Sure. I wanted to expand a little bit on what Melissa said, and also what you said, Jolie, is making sure that we are getting data and all of the data on all of the patients. So that 42 CFR Part 2 covered substance use disorder data, needing the consent to have that data flow through the HIE. CRISP DC has a consent tool that allows that data with our direct connections to flow at the point of care for some of the most vulnerable patients. That is the essence of why it is so essential to have a local HIE. This tool was developed in partnership with our Department of Behavioral Health, with Medicaid, with stakeholders, and we've gotten a lot of trust from patients, from the providers, in order to have so much success with that tool and that explicit patient consent, because otherwise we are opt-out. But also here in the district, we have had this success since 2017 with being completely voluntary. All participation in HIE is completely voluntary. So we have pretty much plateaued in our connectivity in the district. We have a few stragglers, but majority of that has been people who are choosing to participate in the HIE because they know how valuable it is to share their data, but also the data that they are receiving. And I think that really highlights the importance of the local models. But I do agree with Phil and Melissa, there is certainly a place for the national networks, and they do fill gaps for us as well. We do have some neighboring states that do not have robust HIEs, and we are able to query them for people, again, who do cross state lines for care. And that is essential for us, especially, again, here in the Northeast, where we're all so compact, and that is extremely, extremely common. The last thing I do want to highlight is it gives some autonomy to those states to have a local HIE. So local laws can be enacted to protect health data at a state level based on what the state has decided and the state leadership has decided, or the district leadership has decided they would like to block. And so an HDU can facilitate that data being blocked and those consents to make sure all of their patients' wishes are honored and that they're really honoring their constituents. So that is something additional that can be done with this model that we have with local HIEs interacting with those national networks.
Thank you. And I think you all helped in answering the question. So I think it's really important that we not think about the national networks or TEFCA as an either or type situation, but rather be thinking about how the HIEs and HDUs are complementary and potentially bring about the different capabilities. And so I think, in working together, potentially we can go further. And I appreciate that you all sort of helped to articulate that. We have some good questions in the chat, so I think we'll just pivot for a moment. So Dan is asking, what support are your organizations providing or planning to provide for individuals' access to their longitudinal records? Anybody want to jump in on that?
Go first, Phil. I can answer, but you can go first. Okay. We actually we have a state law in Arizona that gives patients and individuals access to certain information about their medical records through the Health Information Exchange. So we certainly support all of those patient rights. We are currently going through a technology migration and consolidation. We have 3 different legacy systems coming from 3 different HIEs historically. So on the other side of that technology integration, we will be looking for more efficient and effective ways to make that patient access to their information more electronic, more seamless. And actually Quality Health Network in Western Colorado, which is part of our organization now, has done a unique pilot, might be similar to what other HIEs have done, with a technology vendor who is able to pilot out individuals going through authentication and verification processes and then querying the HIE for their information and getting a copy of the record. So we have some team members who've gone through that pilot and really think it's been quite seamless. So we'll be looking at that opportunity to expand that further once our systems are consolidated later this year.
Melissa, Phil?
Yeah, no, thanks for that. And but we're love this, want it to happen, and really still exploring some of the safety, how you do this. One is working with direct trust and patients having their own direct address, just like providers have a direct address which has been verified, so that they can use that technology to more easily share with anyone as they want to. Digital identities, where they're coming into this against, because you want that identity to be accurate. And then also working with others around, the previous presentation was great on artificial intelligence. A lot of this data in your medical record is written by physicians. It's not understandable to most of us mere mortals. How do you make that useful? And also, one of the places I'm just personally trying to go is, how do we empower each of us to have data to make decisions in our own lifestyle decisions, ourselves, based on our data and the impact that it has. So not only having access, but making that access have an impact on your health.
Stephanie, did you want to add something?
Sure. I'd go
Thanks,
really
Phil.
quickly to say, and this ties back to our last question, we partner with the national networks actually as the on-ramp for patient access for our users. And so we share data through the national networks, and the patient access and the identity validation goes through that. And so we're currently working on that with one of our partners. So I'll yield the rest of that.
And then so we'll pivot, but thank you for sharing those examples and speaking to that. So we have another question about how HIEs and payers are working together. And just curious if you have any, if you want to talk more specifically about use cases you have, or just in more sort of common terms. But certainly this is a relationship that is really important and does exist. So Melissa?
Yeah, we've had payers engaged in our organizations since the very beginning. They were actually part of the organizations that founded the HIE initiatives in Arizona. And so we really have a variety of use cases that payers utilize. Certainly standard access to the portals, standard access to admission, discharge, and transfer alerts on the members that they treat, so they can do necessary care coordination and follow-up. But there are a number of additional standard reports. So some of the unique things that I think we've done, for instance, different payers have different bundled payment models. So if you've got a bundled payment model for, let's say, labor and delivery, you're just paying for a whole series of events, and you don't know necessarily if that mom is going in for postpartum care. And so how do you actually figure out if individuals, or let's say different cancer screenings, how do you know if, how do you fill gaps in care and identify patients in a certain segment of a population that maybe have gotten appropriate screening and haven't, so that you can do appropriate outreach and follow up on that. So we've done a number of gaps in care and other different standard reports for populations. These are all, covered members under a health plan. And those are some of the unique things that we've done with payers in our region.
And I can say, having previously worked for a payer, hoping to have access to this data, and in Maine, when Health InfoNet came on scene and starting to work with them, again, this is like 10 plus years ago, but it was life-changing to go from only having access to claims data, and though that sort of risk analysis was useful, we needed to go further. And so having that information again, and looking at the actual sort of gaps in care, and thinking about bundled payments and how we could provide that information and work to support care coordination, super important. So thank you for that. Phil, Stephanie, do you want to share anything else about the relationships with payers? And I agree. I mean, I think, many of the Civitas members that are nonprofit HIEs have payers on their boards. That's like sort of embedded in their structure. But if there's anything else you want to say.
Yeah, no, thanks. I mean, you're right, critical to our survival. So, but that aside, one example, we're working with a health plan and the homeless information network systems, and we as the HIE are mashing up those populations, and then we're sending out notifications both to the health plan, hey, your client, your life is experiencing homelessness, and on the coordinating entity side, that your client has benefits and can get healthcare. So again, in that care coordination piece, with aligning the payer, the HMIS, the IT, clinicians, just doing some of that. That's one story we have.
Sure, and just to piggyback off of that, everything that Melissa and Phil said, it's very similar. And the structure here in the district, and one of our founding members and our former chair, again, is a payer, and that is written into our bylaws. So it has always been a part of what we do. The only thing additional I would say is there's a focus on sharing clinical data for those gaps in their HEDIS reporting is something that we are supporting our payers with here. And also a lot of focus on maternal health. So some of the maternal health outcomes in the district are generally, we have high rates of maternal mortality and morbidity in comparison to some of the other states in the country. And so there's a lot of focus on that. And so when it comes to Medicaid programs and redetermination, a lot of what we do, we send alerts to the MCO so that they can support pregnant persons through their entire journey, and then postpartum as well. And so that's a big use case here in the district.
Well, those were all great examples. I think so. We're going to start to wrap up, but I'm going to ask you each just one more question about either, something new that you're aiming to tackle in the year ahead, something, new that you've learned of, that your state partners need assistance with, or, you could also explain how you're going to take something that you've already shared about and go further with that. Phil.
Yeah, I was hoping you're going to pick on me last. I think that probably where we am in Texas, and this comes back to what you were saying about it's been a little bit unique here as well, as we do there's a lot of parallels between the three of us, but also there's some uniqueness. And today in Texas, we've got multiple regional health information exchanges, and they don't share data with each other. Of course, patients move around. So I feel like, what imperative that I'm working on is to break all of that down and get to single pipes of data so that you as a hospital, a payer, a clinician, a community-based organization can be confident and also have the contracts in place, make the data use agreements and the contracts like a mini Texas TEFCA. But that you can have all of this stuff in one place. You can be confident about that, and you can do as you need. You don't have to go connect to multiple places, all the expenses and hassles and data quality, yada, yada, that goes with that. So I think really my dream in Texas, it's a very basic one, but is to have single pipes of data for care coordination.
It's basic, but that is not easy, so.
I would
That's
piggyback
it's
on what Phil said, because we're actually, as I mentioned, consolidating all of our legacy systems into one central infrastructure. We're calling it our One Platform initiative across Arizona and Colorado. That will bring all data. We're rebuilding interfaces that have been in place for a long time against a new gold standard that will ensure higher quality data, more consistent data. And really that's going to have a clinical data repository across both states. And we're building a modern data platform that allows for the flexibility to meet the needs of the state as they evolve. So whether or not that's continuing our work on a crisis bed registry for Medicaid in Arizona and expanding that into more data analytics, more trending, more tracking of crisis episodes for individuals in crisis, or if it is, continuing to evolve as state programs evolve, and the vision of continuing to serve as a robust intermediary for public health purposes. Really, our ideal is to have that infrastructure be as flexible as possible so we can meet states where they are as they continue to evolve.
I've decided that going last is so difficult because Phil and Melissa always say exactly what I was thinking, which is reuse of technology as systems are consolidating. And sustainability is not only something as a nonprofit we're thinking about, but it's also something that all of our district agencies are considering now that funding for public health initiatives and Medicaid are changing. And so what we're really focusing on, especially as I shared in the beginning, and it is a little bit unique, but I know some states also have this where the management of health is across multiple agencies. And so what we're trying to do is just not reinvent the wheel, utilize the pipes that already exist. As I shared, we have a vast participation in data sharing across the district. And so making sure that our agency partners and the 3 different leaders of those agencies know that they can rely on us as they may be rebuilding or rethinking their infrastructure. As a nonprofit in the district, they govern us. And the payers, and so they are able, and the hospitals and the FQHCs, they are able to work together through the HIE to create common shared infrastructure that everyone is comfortable with and voluntarily participating in to meet the needs of the Public Health Authority and Medicaid and Department of Behavioral Health. And so right now we're really focusing on that consolidation in order to support all of the needs as they are rapidly changing here in the district in our unique position that we are in. And so I would say that right now we're focusing on reuse and replicating workflows for different use cases and how we can support people as budgets are changing, as needs are changing with the tools and the data that already exist and the infrastructure that is already there.
Well said. So I think that, and that is just a really important point that all 3 of you just made around use the existing infrastructure. How can we reuse data systems that are already in place? How can we use it for multiple use cases at the same time, continuing to make sure that you're, meeting your state's, your partners' needs, and really, again, paying close attention, listening, learning what they need, and then showing that you have the ability to do that. So we are going to start to wrap up. I do want to just acknowledge that, if you're listening in today and you haven't been as familiar with Civitas and the amazing work that our members are doing, please take opportunity to visit the Civitas website. There's lots of information there on health data utilities, on health information exchanges, and the important work that our members are doing to bridge data and doing. And then we, like WEDI, also host other events, and we have our annual conference in September. So you're welcome to join us there. Melissa, Phil, Stephanie, anything else you want to say before we close out? Melissa?
Actually, I really just think this is a great opportunity to spotlight, like you mentioned, 3 different models. So you can hear the alignment between our comments. We should have let Stephanie go earlier. But they're all different use cases, and they can all happen in states as needed. So I think it's just a good combination of perspectives. And I personally always take notes when my colleagues are commenting on all the things they're doing. So I'll be following up with Phil and Stephanie on some of their cool use cases.
And I would say I'm really glad that we got to highlight how national networks and the local HIEs fit together and the roles that they both serve and the gaps that they both fill and how they can both be thriving together and working together, and how from 3 different areas in the country and 3 different levels of maturity and time that they've been serving their states or their state or their region, we all see that and we are all in agreement with that, and we see kind of the bigger picture of how the system could work together. So
Yeah.
Ditto.
No, and thanks for the opportunity. I would say, we primarily move data around. This Texas Health Services that doesn't do anything. It's partnerships, it's collaboration with others that turn that data into actionable, useful things. So I think, everybody who's in this WEDI group here is, I hope you see opportunities to work with all of us as well to drive healthcare change. Thank you.
Absolutely. And if you've been listening today and you have additional questions, you want to reach out, feel free to direct those to me. I'm happy to connect you with Melissa, Stephanie, Phil. And again, Michael, thank you for all the hard work you've put into organizing the WEDI Spring Conference. It's been a pleasure to be able to join you, and look forward to hearing how the rest of the event goes. And thanks again.
Thank you.
And I just want to say another thank you to Jolie, Stephanie, Phil, and Melissa. But now I'm going to turn us over to Rob.
Great. Thank you, Nancy. And yeah, let me add my thanks to an excellent panel. Well, as we know all too well, the administrative burden in healthcare is fueled by outdated data collection methods. It continues to hinder efficiency, drive up costs, and strain both providers and patients. We're delighted to have Ryan Howells of Lab Partners present insights from their Kill the Clipboard white paper, where he'll outline a strategic roadmap to accelerate innovation and reduce administrative waste in healthcare. Ryan was not able to join us live, but we're really pleased to have both David Lee and Mark Roberts from Lab Partners join us at the end in case there are any questions based on the presentation. So, Michael, please fire it up. Thanks so much.
Hello, everyone.
You're just letting it buffer.
Hello, everyone.
Okay. Technical difficulty. Give me 1 second.
Hello, everyone, and welcome to our session called Kill the Clipboard, a federal policy and industry roadmap, excuse me, to accelerate innovation and cut administrative waste. My name is Ryan Howells. I'm a principal at Levitt Partners. Levitt Partners is a healthcare policy and strategic consulting firm that's headquartered in Washington, D.C. We are a subsidiary of Health Management Associates, or what's called HMA. And our organization is focused on developing effective federal policy around multi-sector stakeholder collaboratives, where we can get payers, providers, patients, healthcare technology companies, developing consensus federal policy that will work for the most organizations and individuals across the country. So some of my background is on the screen. We have spent a lot of time, as I mentioned, in these multi-stakeholder collaboratives to try to find ways where we could be able to advance effective federal policy across the country, and have had some successes in that. You've probably seen some of our successes with the Karen Alliance, which is on the screen there, where it's been named in multiple federal regulations and also has become the default data standard for FHIR-based interoperability with claims data. We recently wrote a paper, which is the title of this talk, called Kill the Clipboard. The URL is there if you'd like to snapshot it and be able to be able to see that paper, so you can see it in more detail. I've just learned recently you can Google it, and it's, I think, on the first page of Google if it's the same across the board. So we're super excited about it. I want to be clear that the paper itself wasn't written just by Levitt Partners. It was written by more than a dozen organizations, payers, providers, QHINs, healthcare technology companies, and others, that really we amalgamated all of not all, but a lot of the best ideas out there in terms of what does the next decade of healthcare technology actually look like? Where do we need to go? Think about policy, federal policy, in terms of decades. First, kind of decade of healthcare federal policy to some degree was getting EHRs actually up and running and across the board. And we made incredible traction on that, and now have 90+% of health systems and providers on these EHRs. And then the next decade now is going to be FHIR and APIs and AI, and where this is going to go in the future. So that's what this paper is all about, not just the next administration, but the next decade. So we're going to talk about potentially some antiquated interoperability policy. We'll talk about what we think are the modern kind of open healthcare data ecosystem components of it, consumer use cases, and other various topics. So first of all, I think folks would primarily agree that we may have over-regulated in a lot of different areas. One of those areas is the fact, or we've regulated for too long in certain areas. For example, one of those areas is EHR-related policy with ONC, which we'll talk about here in a second. We've also noticed that since CMS is actually now in the interoperability game, so to speak, the policy game, there's a need to make sure that ONC and CMS policies are in sync. Dates, deadlines, standards, all of those things. We recognize they work together, which is great. Our hope is they can even work more closely together so we can get a lot of these things in sync. The second thing is, how do we build on the great work that the EHR vendors are doing and build upon that to be able to say, how do we upgrade how we handle certified electronic health record technology in the future? What does that look like in a modern 21st century computing infrastructure? So some of the ideas we wrote in the paper, and this is probably the biggest that we talked about, is we think our group that got together thinks that we need to find a way where we can change the definition of certified health record technology. We call it API cert. They could call it whatever they want. But the idea that instead of certifying the functionality inside the EHR, we actually instead start to certify the actual APIs or the extracts from the EHR itself. Why do we need to do that? Well, one of the reasons we need to do that is to allow the EHRs to better innovate. They've been told for quite some time by the federal government what to build inside of their black box from a functionality perspective. that may have been needed when EHRs were actually just starting to be built and starting to receive federal funding. But now that a lot of the EHRs are built out, the most important thing we can do is certify the interfaces between the systems, because we no longer just have EHRs. We have all kinds of healthcare technology that's been built, from pop health products to all types of things that are out there in the ecosystem today. And so how do we make sure that those interfaces are certified? And when we look back at the HITECH Act, it was really interesting that the HITECH Act, from a statutory perspective, allows for more of this broader definition of what cert could mean. And that was pretty exciting, because then we said to ourselves, well, if I'm a value-based care provider and I'm taking on risk, and I need top health and value and a whole series of panels of patients in order for me to actually manage that risk, that's a much different way of thinking about it than in terms of just a transactional system that handles provider workflow and billing. What does that look like? And so how do I have some of that freedom and flexibility to be able to use potentially both my EHR and other services too? What does that look like? And ultimately, CMS is going to have to point to this new definition, and we hope that on the employer side, specifically with ERISA plans, that also, payers could actually also have a similar experience as well. We have this thing that is the most underutilized resource, I think, out there today for understanding how to ensure the consistency of the APIs across systems. ONC built it. It's called Inferno. You can see it at inferno.healthit.gov. And they have a ton of APIs and API supportive technologies that are available for organizations to use to determine whether or not they are compliant with the standard and compliant with the regulation. That could make certification a lot easier. It's free for anybody to use. There's a bunch of test kits there, and you could actually install it in any FHIR server in the country, which is really exciting. Some of these are not quite ready for prime time yet. There's still some work to be done to actually get them to scale, but this gives you a list of some of the things that can be implemented now and certified, as well as things that potentially could get certified in the future. And if we could make the certification program flexible so that we can be able to have this certification layer leveraging Inferno for now and in the future, it becomes really valuable, because then we can start to say, let's put this in place. Let's provide a time frame for when the EHRs can get this in place, and also when the plans can get this in place too. Keep in mind that there are plan APIs that are in Inferno as well. I don't want to get into necessarily whether we certify the plans or not, but as we move to 2027 and the 0057 rule, we're going to move to a stage where we're going to need to find ways where both the payers and the providers are certified on the same set of standards, because thanks to CMS, we need to make sure that that actually can scale across the country. So what do we think we need for a modern healthcare data ecosystem to actually work? Well, there's a few things. Number one, first and foremost, is we need these open APIs available in a FHIR endpoint directory that's publicly available. We don't have that today. We have it sometimes we have it in various places. There's a few folks that are out there, but we need it in a very centralized location. TEFCA needs to do this to ensure that the FHIR version of TEFCA can get up and running. And so that's a great place to be able to start. The other thing is, even though the APIs are in place, it doesn't mean necessarily that the data quality is effective. In fact, what many health systems and payers are telling us today is that the data quality isn't really good. And some of these health systems or payers don't know that their data isn't very good until they actually have to send it and have the receiving party say, your data is not really good. And so one of the things that we're doing is creating, and we announced this at the ONC national meetings as well as at HIMSS, is we're working with clinical architecture, Charlie Harp and his team, Carol McCumber and others, to develop what's called the PICI framework.org. The PICI framework is an open scorecard approach to measuring the quality of the data associated with sending the information between health systems and payers and others. We're excited about it because it is an open standard. We're going to run it through HL7 over the course of the next few months. We're beta testing it right now. And we have a really good opportunity where we could objectively and transparently measure the quality of the data that's being extracted and sent between these systems. You can look more of that up on Picky Framework. The third thing that's really exciting is is developing a semantically interoperable cloud-based data model that allows for this information to be sent back and forth to these various entities in a coherent and standardized and semantically interoperable way. Graphite Health, or the S2 Health Data Standard, has done some really amazing work on that, and they're going to also open source a lot of the things that they're doing as well. Could be a really great place to be able to look in terms of how we think about data over the next 10 years. Digital identity is a big deal as well. Digital identity federation isn't patient matching. Digital identity means, are you who you say you are across systems? Who do you represent, either yourself or your organization? And what data are you authorized to receive? Folks that have heard me talk before have heard me speak about the IL2, AL2 digital identity credentialing standards. For us to make FHIR scale across the country, we're going to have digital identity standards, not just for consumers, but providers and for payers as well. That's the foundation of trust, are those answers to those three questions. We believe that digital identity federation standards using leading edge providers like login.gov or ID.me or Clear or OneCosmos or others that are out there in the marketplace today will dramatically improve the trust across the healthcare data ecosystem through using OpenID Connect to be able to make that happen. And then finally, robust information blocking enforcement. We're fully aware that this administration wants to move to more deregulatory approaches. But one of the challenges I think we're all seeing is that information blocking is still happening. And as a result, and part of that reason is the fact that ONC is doing their job, but we haven't heard much from OIG at all. It's been very quiet. So if we can figure out ways where both providers and payers and patients, all of the above, can be able to get access to the data that they need for their various use cases, we may need a little bit of push from the federal government to make sure that those things are being done. It actually worked in terms of price transparency. CMS actually created a list and folks started paying attention. This is just more of a prod, and we should pay attention to this and make sure that the data can be used at scale. So how do we see these things kind of stacking up? Well, it's interesting. We see it stacking up in terms of kind of from top to bottom. ONC is focusing on that core legacy EHR functionality today. If health systems and payers had an API gateway, we can start to have these APIs and use Inferno to make that happen. It would be really amazing. Once we have Inferno there and we can certify these APIs against it, we could use the Picky framework, that open scorecard approach, to measure the quality of the data that's actually being sent very objectively, very transparently, to whether that's sent to CMS or NCQA or payers or providers or patients, whoever that data may be sent to. We can start measuring the quality of the data so the organization knows that they're sending good quality data and they're receiving good quality data from their trading partners. And then we can have these semantically interoperable open data models, and then we start to realize all of the benefits of all of the things that we keep talking about in these conversations at WEDI and other places of, hey, let's use apps. Let's do new UI or UX. Let's figure out clinical decision support, remote patient monitoring, engaging the patient, and of course, AI. I will tell you, and I know a lot of folks know this today, the AI models are going to be very difficult to actually work at scale, especially for clinical decision support, if we can't get some of these other things in place first. And folks will tell you that. The cloud folks will tell you that from an AI perspective, and others will tell you that. It's really important that we can start to clean up this information so we don't have to spend all our time and money in training these models for months or years, but we can get to a stage where we can still train them, make them openly available, make them transparent, and also make them structured in a way that allows for consistent results to be able to augment the clinician's decisions. It also opens up this powerful new set of consumer use cases, which we're really super excited about, both in terms of current policy as well as future APIs. Individuals can actually select a plan based on their health history as they consent in and want to be able to do that. That is going to be super exciting because I don't know about you, I can't stand open enrollment. It drives me bananas because I'm looking at these things being in healthcare for 25 plus years. I don't even understand some of the plan dynamics of this. Can I just load my data into a plan selection tool and allow me to then be able to select which plans would be the least out-of-pocket cost for me and provide the best coverage? What does that start to look like? It helps everybody at the end of the day. You can do better on provider directory. We think that the foundation of a good provider directory in the future is going to be identity, back to the digital identity credentials. If providers could really tell you that they are who they say they are, then all this other metadata can actually start to be linked to the provider over time, which is kind of exciting. I know it's not that simple. Provider directory is a very complicated problem, but can we start to rethink this provider directory issue based on some of the things we have? How do we better estimate costs? How do we check in and truly kill the clipboard? We do this every day, and I still go to my local physician and I'm still filling out clipboards. If we could stop doing that, it would be phenomenal. And then how do I access the data using these digital endpoints? Really exciting things as we move forward. All right, I'm going to go quickly here for the back end of this, but let's talk about B2B data exchange. Again, this was a whole set of opportunities in terms of how we think about this, but with B2B data exchange, we want to make sure that we're finding opportunities where we are connecting to the FHIR endpoints. We think that publishing the FHIR endpoints immediately is going to help us get to FHIR faster because many of the organizations we've talked to have said, what if we could actually potentially use the same data use agreements we have just to get up and running in our little region? And then as we expand it to other regions, other states, and ultimately expand it nationally, we can do that as TEFCA FHIR gets in place and all the other things that are happening gets in place and starts to scale. So we think that that's really very, very important. The other thing that we think that is important is making sure that TEFCA is an option, not the only option. We recognize that that is the case today, but there's opportunities where we can think about this in terms of, can we make sure that folks know of all the available options that are out there to be able to connect to different endpoints? Because what we have found is we're probably going to need them all. And we're going to need them all in a way that allows for this to scale, not just nationally, but also regionally, locally, and especially to those most at need and at risk type providers and populations. We had talked about information blocking before. Interestingly enough, so this idea of a complaint clearinghouse, the Caring Alliance actually, in one of the information blocking rules that were out there, actually made some recommendations on what we call, and it's on our website too if you want to read it, but what we call a complaint clearinghouse, where we said, we had asked the payers and providers, are you guys experiencing information blocking between your organizations? The answer was really a resounding yes. And we said, well, what could we do to improve that? And one of the ideas we came up with was, what if we had this complaint clearinghouse where a third party, maybe like an industry organization like AHEP or AHA or others out there, could actually be able to aggregate complaints on behalf of a specific organization, submit them on behalf of them, and just say, and keep that information private, but this allows for an investigation to occur and to make sure that an organization, especially that has multiple organizations saying they're information blocking, could come together anonymously to do that. Because these organizations still need to work together. They're still trading partners. Saying tit for tat and you're blocking things and you're blocking things, it just is not a good way to do it. But we do need to figure out a way to get the data to move. Everyone's got to share it. 21st Century Cures made it non-optional and optional now. We have to share data between each other for us to be able to scale. And that's really the idea behind that opportunity. All right, so let's talk about TEFCA. We are the current version of TEFCA, that's what's live and what's being transitioned to in 2025, is really a newer version of care quality. It's kind of care quality 2.0, where the CCDA information is being transmitted for specifically provider treatment related purposes today. But we haven't necessarily expanded the number of use cases that are needed for us to get nationwide data exchange for all types of other reasons, whether it's research or public health or treatment, payment, and operations or others. And that's a problem because we have multiple other reasons why we need the data. So we think that there's a need to be able to expand, obviously, those use cases. We also think that it's important that we don't have asymmetry issues in terms of information exchange on the network. We don't believe that really anybody should be charged for sending data across the TEFCA network. We do believe that the QHINs, which there are multiple now, should charge for the work that they are doing to connect to the other QHINs and get access to the data on behalf of organizations. We just want to make sure that's really clear in the standard operating procedures, is that folks that are trading on TEFCA, there's not one side that's paying and one side that's not paying, but that everyone, it's free for everybody on the network, but that in order for them to get on the network, they need to join a QHIN, and the QHINs would actually charge for their services, which makes a lot more sense to us. That'll hopefully reduce some of the asymmetry issues that are out there. Early adopter programs. There's been a lot of discussion about 10 by 10s or 10 1x1s, meaning could we get payers and providers to start exchanging data using FHIR? The answer is yes, we do. But let me tell you what we've learned with that. And we've learned that with our what's called our One Utah digital health pilot that we're doing, which is the largest state-based FHIR pilot in the country right now, which we can share with you as part of this effort. But what we're learning is let's take prior authorization. Let's take the 0057 rule, clinical data exchange, prior authorization, everything that's required there. What our providers are telling us is we don't need another portal to do this work. We don't want to have another one-off payer solution. That doesn't seem to make sense. We'd love a payer agnostic solution that uses a single user interface with a dropdown that uses these open standards to then say, I want to be able to go into one user interface, select my payer, then be able to send that to the payer, have them give me a real-time response back, including from the state, by the way, the state Medicaid agency who may require it, have them give them a real-time response back to say, provider auth is required or not required. If it is required, I'll send them the clinical information in a minimum necessary way, and they would send back the business logic associated with their decision. All that can happen with these APIs, with the CMS 0057 rule. Super exciting. But we need to do that on a regional basis, a state-based or regional basis, so we have enough providers and enough payers participating in that open standards approach to make sense. We're doing some amazing work with eHealth Exchange in the state of Utah to make that happen. We've been working for 2 years on this project. We're actively testing now, and we're going in production this year on the 0057 rule 2 years in advance of when it's due. We're learning a lot about that. We're excited to be able to provide some of that lessons learned in the future. So what are some of the proposals? Some of them I just mentioned, but the eliminating of the fee on TEFCA-related data exchange. Again, that's actually on TEFCA, not necessarily ramping onto TEFCA through the QHINs, but it's just the actual TEFCA-based exchange itself. Allowing providers and health plans a choice, potentially selecting more than one QHIN. What they've told us is we actually need this QHIN for this, but we need this QHIN for doing this because they offer different things. Could we potentially select more than one? And making sure we reduce the conflicts of interest. We don't think that there's enough representation from payers, providers, healthcare technology companies, but also people that don't necessarily have a financial skin in the game, that understand the market. How do we broaden that perspective? We can look to care quality as one example of actually from a governance perspective, from a multi-sector governance perspective, they've done a pretty good job of having a whole range of voices around the table to actually govern some of this data exchange to avoid some of the conflict of interest problems that may exist. Certainly, we want to have a stronger governance process within TEFCA. One of the things that's not on here, but we've had a lot of discussion recently with a few folks is just because things are moving from, for example, care quality to TEFCA doesn't necessarily mean that the oversight is going to improve. it means that we're going to have someone in the room that can break the ties. For example, a government representative that's going to say, nope, this is the way we're going to do it after hearing everybody's perspectives. And it also allows us the ability or the opportunity to be able to say, can we actually go out and get third-party organizations to audit the transactions on TEFCA? One of the challenges we have today is that we're not doing that at scale on the current national networks, at least to my knowledge. What we're trying to figure out ways to do is to actually audit those transactions using independent organizations to do that auditing so that we can have a very transparent way to say, this doesn't look right. This type of behavior or transactions don't look like. Let's figure out ways to be able to investigate that. That's what we mean by governance, is that that'll help build trust in the overall opportunities that we have as organizations. Quality measurement reporting, really important topic. Folks are burdened by this today because it's mainly manual. The way CMS does it versus the way that NCQA does it is different. There's all kinds of acronyms, ECQMs and QRDA and digital DQMs. I won't bore you with all those details today. Here's what I would say. I would say, number one, we've got to figure out a way to be able to ensure that bulk FHIR functionality works, and specifically how we actually get it to scale in the United States. And the reason for that is because we have all kinds of use cases that require bulk FHIR functionality. Bulk FHIR, for those who don't know, is making one query and getting a panel or population of patients back. We need to have that work for public health. We need to have that work for quality measurement. We need to have that work for value-based care use cases. We could list all of the things where we need help with that, but we've got to make that work. And the EHRs by design are transactional systems. They weren't actually built to actually extract a population of patients, which is causing strain on the ecosystem. So could we potentially find ways where we could leverage cloud-based solutions or databases that are used to being able to provide that set of population of patients? Could there be a partnership there that could work over time? That's kind of a big problem that we need to try to fix. We're hoping CMS starts to accept FHIR APIs to do ECQMs. We're working with them right now on some projects that we hopefully later this year are going to see some real movement on that. If you're interested in talking about that, we'd love to discuss more about that with you. We're also working on making sure that these digital quality measurement reporting can be done using the FHIR APIs. We've been working on this thing called the Digital Quality Implementers Community for a few years now with both NCQA and CMS. We've matured the CQL standard that requires this to happen. And so as a result, that's actually now saying, how do we actually get bulk FHIR and specifically quality measurement reporting done? There's going to be another number of vendors and a number of payers and providers this year that are going to go live with NCQA on getting digital quality measurements to work with the NCQA's digital content services solution. And as I mentioned, bulk FHIR, what are all the options we have in addition to the EHRs and trying to find ways where we can improve that? Are there other options that are out there where we can ensure that bulk FHIR could work at scale? All right, identity, one of my favorite topics, as this group knows. We have one of the things in 21st Century Cures, which was super interesting that I totally missed, but recognized this just recently, is in the 21st Century Cures Act, there is a comment in there that said that it requires a common method for authenticating trusted health information network participants. We have not done that yet. And we haven't really focused on that yet, other than for individual access services, which is something the Karen Alliance was promoting very strongly in terms of identity proofing the patient so that we know that the patient is who they say they are and that they can use a single sign-on credential to get access from their data from any payer or provider in the country. We should find ways to focus in on that. We need to figure out a way for both CMS and ONC to work together on how do we do identity credentials for everyone in the ecosystem. Cybersecurity is a huge threat. We're hearing crazy, scary stories of nation-state actors and other nefarious folks calling up health system call centers and saying, we are Dr. Howells, and giving them the information that they've stolen from the internet and then doing things like ransomware and other stuff. That is completely unacceptable. And we're trying to find ways to prevent that. This same thing happened during COVID when the CARES Act money was being delivered to through the states, where the fraud was off the charts because people were calling their unemployment official, they were calling the states, I should say, and impersonating people, and billions of dollars of fraud that's outstanding. When these digital identity solutions were put in place, the fraud literally went to almost zero. We can do the same thing in healthcare, and that's a really powerful way to think about that. In addition, as we've mentioned before, this NIST 863-3 digital identity credential for IL2 and AL2, it's going to need to be for everyone, not just patients, but for providers and payers. Why? Because when we start to exchange data via FHIR for 2027, it's really going to be app-to-app based data exchange. One's going to have an app over here, one's going to have an app over there. We're going to exchange it there. We're going to have to authenticate into the apps, payers and providers will, and then they're going to have to send the data using the FHIR API technology. So we're going to need to know who the person is on the other end of that transaction. Do they really represent the organization that they're intending to represent? And are they authorized to receive the data? Those three key questions. We have Kintera that has certified these vendors. These vendors have gone through more scrutiny than anything we have in healthcare. They've been scrutinized by the federal government, multiple agencies inside the federal government, including IRS, Treasury, TSA. You go through the list. FedRAMP certified. They're high trust, HIPAA, obviously, following the HIPAA security and privacy regulations. You go through the whole list of things that they are doing today, and they're more scrutinized. Financial services, know your customer, they're more scrutinized than anything else we have in healthcare today. So we have to put our trust in something. Let's put our trust in something that healthcare alone doesn't have to oversee, which we haven't historically done a good job of that. We need to get everybody as well to accept OpenID Connect. That's really important, not just the Smart on FHIR versions of OpenID Connect, but all of OpenID Connect. Currently, TEFCA in the QTF actually requires OpenID Connect to be leveraged as part of the TEFCA framework. We need to get everybody, payers, providers, folks on TEFCA, off TEFCA, to do that. And then we can have a true single sign-on option for payers, providers, and patients that leverages the benefits of OpenID Connect at scale. And there's more things in here. The federation protocols, I know we're still working through some of those things. We've got implementation guides around digital insurance card and smart health cards that allow you to have your data to be portable, and making sure that we can kill the clipboard without the need to show your insurance card every time you show up. What if it just, once you make the appointment with the provider, what if it's just automatically sent from the payer to the provider because you, as the patient, make a determination to actually send that information to them? That would be wonderful. All right, so a few next steps and some conclusions here. We hope that you see that there is an opportunity here for literally billions of dollars of administrative waste taken out of the system. The amount of money that I have heard on even just one of these ideas, quality measurement reporting, digital identity, if you just take any one of these ideas, it's literally in the hundreds of millions, if not billions of dollars in just one of these specific ideas. We hope that as many of these as possible, the current administration and hopefully future administrations will build off of, and to be able to say, yes, these are good ideas. We should do this. We could measurably advance federal policy and innovation if we go down this route. That's what's really exciting about this, is how do we prepare for the next 10 years? What does that actually start to look like? And how can we work together? We need everybody at the table for this. And I'm not a big fan of, it's these person's fault or this organization or this sector. It's really all of us working together in a way that is collaborative and a way that allows for us to solve all the problems we want to solve together. Governor Leavitt is fond of saying the private sector can't do this on their own, solve any of these problems in healthcare on their own. The public sector can't do this on their own. We actually have to figure out a way to work together collaboratively as multiple stakeholders to be able to solve these different issues in US healthcare. So with that, this is the contact information of how you can reach out to me. I'm unfortunately not live today. I apologize for that. But my colleagues, Dave Lee and Mark Roberts, are live with you today, who helped write this paper. And they're going to be more than happy to answer your questions as part of this engagement in this webinar. But thank you all for participating today, and we look forward to being able to talk to you soon.
Well, that was great. Really appreciated Ryan taking the time to walk us through the Kill the Clipboard white paper. We don't really have too much time left for Q&A, but I did want to ask David and Mark, I'm going to consolidate several of the questions into one, and that is change is challenging for healthcare. And a lot of folks are interested in some of the perspectives included in the white paper. The question is, how do we get there? Yeah, obviously we have a infrastructure in place now. Who will pay for this change, and how can we make change happen in healthcare?
Yeah, so I think a lot of this change is going to be a public-private partnership, as Ryan noted, and a lot of emphasis on working together, as Governor Levitt said, or as Ryan quoted Governor Levitt there at the end, right? And it's going to be incremental change, right? I think a lot of it is, look, CMS through their RFI, and I know there's a session coming up on that soon, and CMS is talking about it later today. They're wanting to move really quickly. We see this as a 10-year change that's going to really focus on the interoperability components rather than some of the internal functionality components. So we feel like there's a lot of opportunity here. And yes, there will be some investment that's required and some change in how the regulatory bodies look at specific functions and do specific things. But the innovation that we believe can come out of the back of that is going to more than be worth the effort and the time and the pain of going through that change, and being able to have better access to data for patients, for providers, for managed care organizations, for ACOs, for all sectors, we feel is really worth the change and the effort.
Yeah, I appreciate that.
Yeah, just building on that really quickly, I would just share that I posted the link to the RFI there. Just noting many of the ideas in this Kill the Clipboard are in that RFI. So if you do want your suggestions heard by CMS, I would highly recommend that you get those in by I think it's the June 15th or June 16th deadline.
Excellent. Well, thank you so much, Mark and David, and please pass on our thanks as well to your colleague. And your chat link couldn't be more timely, because I'm going to turn it over to my colleague Nancy Spector to talk about our member position advisory on exactly that RFI. It's a huge potential shift in how we look at healthcare data. So Nancy, if you want to walk folks through what we expect to do at the MPA.
Sure, happy to do that. Michael, are you pulling up my slides? If not, I can share them.
Yeah, I didn't recall seeing the slides. I can pull them up though.
So while Michael's pulling that, I'll just start by saying, I'm sure that for all of you who follow healthcare policy and activities that are going on, you've noticed that there are quite a number of RFIs actually that are out right now. We are looking right now, and WEDI just did an MPA last week on the CMS Medicare deregulation RFI. I know FDA has they announced last week and put out an RFI that's, I believe, in tandem with HHS and again more around deregulation. Haven't had a chance to really go through and look at that. Let me pull up the slides. Sorry about whatever happened there. Let me just get it into slideshow format. Okay, whoops. That's not gonna work. Sorry. Let me just share the slides and then
If it's easier for you to email them to me while you talk, I can pull them up eventually.
I had emailed them to you. I'll just share my screen here. I've got too many things open, so it's not pulling it in as one of the items. Okay, can everybody see that?
Yep, perfect.
Okay. So I was saying that, we've been seeing quite a number of RFIs coming out, and this is another one that came out, and you were just hearing about it from Ryan and Mark. This is CMS and ASTP ONC Health Technology Ecosystem RFI, and there's the link there, but you also got the link in the chat. So you can, I'm sure, Google it. You'll find it in several different ways. This was published in the Federal Register on Friday, and the comment deadline, it's a 30-day turnaround. So it is a quick turnaround, and the deadline is June 16th. So overarching, what it's looking at is the market currently with digital health products, and again, sort of focusing on Medicare beneficiaries, state of data interoperability and broader health technology infrastructure. And then they make the point of saying that, the responses that they get back are going to lead to infrastructure progress, increased digital capabilities needed for informing health decisions, and increasing data availability. I'm actually having trouble, whoops, seeing the bottom of my screen here. But increasing the oh, I'm sorry, I'm having technical.
I found them, Nancy. I'll pull them up.
Oh, I mean, I've got it now, so. Or if it's just easier to read. Well, they're on full screen with me right now, and so that's why I'm having trouble seeing all the corners because of the Zoom pop-up boxes. Do you want me to stop sharing? I'll stop sharing.
Actually, oddly enough, what you sent me wasn't the slides. It was the actual Federal Register.
Oh, well, that's.
I don't have the slides either.
I'm sorry about this. I don't know how that happened because okay. So now I just closed. I don't know why. Apologize. I am full screen. Okay, here we go. Let me get back to. Okay. Okay, let's try this again. So the let me move on. There we go. Okay, and this was meant to just be a quick overview of the RFI and the topics that are in it. If you've looked at it, you know that there is an extensive list of questions within each of the overarching sections, and so I'm clearly not going to go through all of the questions with you right now, but there are different sections geared towards different stakeholder groups. The first is patients and caregivers. And then within that, there are these subheadings. So there's questions about patient needs, and it talks about navigation, care navigation apps, digital health products, what would be helpful for patients and caregivers, ask questions about access to health information. And so some of it is about what is working, what would be helpful if it was to be brought forward. And then there are questions in the section of data access and integration, again, about readily available and the value of the data. Talks about data sources to include in APIs, talks about the role of TEFCA, or questions about the role of TEFCA and HIEs, and then talks about the information blocking, digital identity. We just heard quite a bit about digital identity. There's a provider section that has an overarching group of questions around digital health apps, leveraging digital health products for patients, obstacles for the physician workflow, again, accessibility of data, this in the context of EHRs for exchange and for third-party apps that patients are using. There's questions around data exchange, using FHIR APIs, the role of TEFCA again. So some of these are common themes: digital identity, information blocking, TEFCA HIEs. They are common throughout many of the stakeholder question groups. Payers, again, asking questions about the technical limitations of TEFCA, implementation and use of APIs, digital identities, nationwide provider directory with FHIR endpoints, and then more on information blocking. And then there's a section for technology vendors, data providers, and networks. So here there are questions around, again, digital identity, the role of TEFCA, the role of US CDI in interoperability. Another section here where they're asking about the nationwide provider directory, certification criteria, networks use of FHIR APIs for data exchange, and then again about information blocking, and it brings in the price transparency topic here. And then value-based care organizations, there's a specific section just for them, talking about digital health adoption. So how to leverage digital health care navigation products for patients, integrating technologies into advanced payment model requirements, health IT capabilities for value-based care arrangements. Again, questions around compliance and certification, technical standards, so questions around interoperability challenges, improvements to support the value-based care capabilities, reduce provider burden, and digital identity again. So you can see it's a broad collection of topics that they're hoping to get input, feedback, and the questions are very specific in terms of how those questions are being framed, the context of what is being asked in the response. This is an event that WEDI will be doing next week, our member position advisory event. And this gives you an overview of what the MPA process is that WEDI does. So this is a process that WEDI has developed to solicit WEDI member input on proposed regulations, RFIs, any other types of private public sector proposals, or any other topical issues. And the MPA process gathers members' perspectives, and we do this through surveys, interviews, or live member events. On something like this, where there's such a quick turnaround time, we really don't have time to do any kind of surveys or go out and do any type of targeted interviews. But we are doing the live event, which is the MPA, and that event is really facilitated discussions where we'll talk about the different topics that are part of the RFI. And these are members only events. So if you're not a member and you're interested in participating in something like this, hopefully it would be a reason to join WEDI so that we can really gather the perspectives, the input, the feedback from our members. And then all of this is designed to capture, again, all of that feedback, that expertise, and be able to use that to then advise the WEDI board on developing its comments and what the official WEDI response will be for, in this case, to the RFI. That MPA event is going to be held on Wednesday next week from 12:30 to 3:30 Eastern. And I believe there is the registration link in the on the WEDI website in the calendar. So with that, I will I know that we're bumping into the break time hours or break time. So I don't know if anybody has any particular questions that they would like to ask at this point, or any particular comments that you'd like to make about the RFI. Happy to, and if you put anything into the chat question wise, I can always answer that in the chat if you want to enter it there. So not seeing anything. So Rob, I'll hand it back to you or to Michael just to give an update on our schedule for this afternoon.
Yeah,
Sure thing.
Yeah, we're getting started again at 12:30. So very quickly we'll transition to our next session. But again, just to reemphasize, the MPA is a unique opportunity to provide your organization's perspectives on what could be one of the more important RFIs we've seen over the last few years. So with that, we'll allow you a few minutes break, and then we'll get going again right at 12:30. Thanks so much.
Welcome back, everyone. Hope you had a quick, nice stretch there. Stretch the back, the hips, the neck. Got yourself a quick cup of coffee. Our next session, the Cyber Resilience Playbook, Strengthening Health IT Against Attacks. We have Lisa Bisterfeld, Program Manager, Cyber Resiliency at St. Luke's Health System, and Sola Adesida, Executive Director, Enterprise IT Resiliency with Kaiser Permanente. The moderator is Nate Couture, Associate Vice President, Information Security, and CISO with University of Vermont Health Network.
Thanks for that introduction, Mike. Here's my video is not wanting to start for the moment, so we'll get going with the important faces are on the screen for you with Lisa and Sola. So getting started right off, Lisa and Sola, you both have the word resilience in your job title. What in the world does that actually mean in the context of healthcare? Maybe Sola, you want to start us off with kind of what resilience means to you?
Yeah, I hope everyone can hear me. I've also been having technological issues or technical issues. Okay, cool. All right. So for me, resilience, particularly in the context of healthcare, really refers to a healthcare organization's ability to prepare for, withstand, respond to, and recover from threats, whether it be, quite frankly, cyber threats or even a physical disaster that disrupts their operations, with the lens of continuing to deliver essential patient care. And that's all encompassing, right? It's not just delivering the patient care, it's making sure that they can protect sensitive patient data. It's making sure that they can maintain the integrity of the medical devices that they use on patients and ensuring that operational uptime, even under that duress, whether it be physical or cyber, is maintained.
That's great. And Lisa, when we think about those things, how do we then keep that in balance with what we're trying to do from a patient care perspective? And how do we balance that? What are we doing on a day-to-day to keep our patients cared for with making sure that we can handle that security and providing that resilience?
Yeah, I think it's a great point, Nate. And I think it's something within cybersecurity that we have to balance amongst all of our cybersecurity teams. Different than maybe, our protection team or our defense team, really from our resiliency team at St. Luke's, it's better understanding our threat landscape. Really, what are we potentially a victim of, or what technologies are we using that makes us more vulnerable? And from our perspective of the resiliency program at St. Luke's is for us to be able to better understand this is important so that we can balance the technology that's coming in and ensuring that we have continuity processes in place or downtime solutions for all of those as they come into our environment. I think a huge piece of that as well from a resiliency perspective is when we're working with our clinical stakeholders, being able to explain the why behind all of this preparation, all of this work that we're doing, because the reality is our teams are tired and they're overworked, even with just keeping everything up day to day, whether that's a technical team or a clinical team. So I think the why within resiliency is extremely important. And we've tried to integrate it into all of the things that we're doing, not only to get better buy-in, but to make sure that what we're doing is more meaningful, not only to our technical colleagues, but also the end users that might be the potential people that are implementing our solutions as well.
And Nate, to add a little bit from Kaiser Permanente, in addition to all Lisa said, for us, we adopt a risk-based approach, right? Making sure that we can prioritize our assets based on how critical they are to patient care. So that's important. The other thing that we're starting to do is ensuring security by design, meaning that we're embedding security measures even into our clinical workflows, not on top of it, right? And so making sure that our IT systems are not adding that unnecessary, to Lisa's point, complexity, because clinicians are clinicians. They want to focus on patient care. They don't want something in addition to what they do, right? I think also we are really focused on segmentation and redundancy. We want to make sure that we're isolating our critical systems, whether at the network layer or at the application layer. And we're starting to think about how we might be able to implement those redundancies or failover technologies that will help to continue operations. Again, focusing on our true north that we have to maintain that uptime regardless of the duress that we're under.
Great input, Zola. Lisa, you talked about needing to understand the threats that are coming as you're trying to balance these things. What are those most pressing threats from a cyber perspective that are facing healthcare organizations today that you're really thinking about in your program?
Yeah, it's a great question, Nate. And I think one that unfortunately continues to evolve as the industry continues to evolve. I'm sure, Sola's agreeing. I think they're probably dealing with this at Kaiser as well. I think the whole industry is dealing with this. It almost feels like we have all these resources and we're always about a step behind, just trying to keep up with it. I think historically, over the last 5 years, a huge focus has been on healthcare being a victim of a ransomware or a large-scale cybersecurity incident. And unfortunately, that isn't the only thing that we need to have on our radar going forward. We continue to see, I guess I should say, the times of a single extortion attack are really behind us. And what we're seeing are, if we're just focusing on ransomware or extortion, what we have to be prepared for is the potential for a multiple extortion attack, whether that be to unencrypt systems. An additional extortion might be due to data exfiltration and really someone holding your data but at ransom. But additionally, we're starting to see some huge reputational impacts, and even these bad actors then with the data they have, leveraging it to even extort those that are in the data set. aside from kind of you being the victim of a cybersecurity incident, I think a huge thing from healthcare that we have to start focusing on is we are extremely reliant on vendors and partners every single day to deliver the technology to ensure that our patient care is safe. That reliance we have found with incidents across, over the last year or two when we aren't able to rely on those vendors, it's extremely impactful to our ability to continue care. So from a resiliency perspective, it's extremely important for us to understand what vendors we rely on and the potential impact that if that vendor was a victim of a cybersecurity incident, what would it look like for us to not have their services, not be able to have open network connections to them for an extended period of time. So really, from our perspective, while ransomware is extremely impactful, kind of if you look at that risk tolerance, like Solo was talking about, ransomware is extremely impactful, but the probability is potentially lower. But if we look at third-party risk, we're seeing that it can be equally as impactful when a third-party partner is hit with an attack, and the probability that is really high. So I would say, looking into the landscape, that's something that we're really looking to increase our maturity around, knowing that it can be just impactful to our ability to continue to provide care. I don't know, Sol, if you had anything additional that you would add to that as well.
No, you're spot on. I think third-party vulnerabilities and risk is huge. Healthcare organizations everywhere, yours and mine, we rely on third parties a lot. And really, and we've seen over the last couple of years how third parties have impacted other healthcare organizations. And so making sure that yes, this is pressing, but then what do we do to mitigate? I know maybe Nate will take us through what that looks like. But in addition to ransomware, we have to talk about phishing and social engineering, because that is the gateway, and we see a lot of that, particularly in healthcare organizations, because clinicians are clinicians. They're not technologists, and if those threat actors can get in through social engineering, through phishing, then it opens up systems to vulnerabilities. Another one that, Lisa, I wouldn't want to overlook is legacy systems and outdated software. In healthcare, there's no shying away from it, that we do have legacy systems that are highly vulnerable. And in some cases, I dare to say outdated software as well. We're not up to date with our patching. So those, again, are vulnerable to exploit. And it's important that we continue to look at those. Again, medical device vulnerabilities. Those ones are exploitables at the endpoints, and they're connected to our networks. Again, that's another gateway. So from in addition to the data breaches, the data encryption, exfiltration, ransomware type attacks, we're also really looking at those because they're really pressing.
Great. And so as we think about that, there's all these different threats that you all just talked through that are coming at us, and it's constantly changing. Wouldn't it have been great if the only thing we had to worry about was just ransomware, right? As awful as that is, but it keeps changing and it keeps coming. Sola, how do you think about what are some things that other people could think about in developing their programs how do we try and anticipate some of these things that are coming? Because we don't have a lot of time to respond, right? We can't put a big roadmap in place to deal with each one of these things. So how do you try and anticipate what's coming so you can get ahead of it? And kind of what do you do in your program to be as responsive as you can be, and how you mitigate these things and respond to them in the short time frames that you're provided?
So Nate, we're gasping for air, right? Because the threat actors continue to evolve, and we are oftentimes playing catch up. But I think the most important thing is threat intelligence sharing. And so being able to participate in sector-specific information sharing where we're learning from what is happening in the industry. And Nate, I recall a couple of years ago, we got with you to understand your organization as well as the threat that you faced and what those challenges were and how you recovered and might I say very swiftly from it. So that is key, and that's one of the things that is really important to my organization to make sure that we're anticipating this. Of course, continuous monitoring and anomaly detection, leveraging AI. We do know that threat actors use AI, but AI and machine learning to be able to see behavioral patterns and analysis is key in helping with our monitoring. Supply chain vetting or even third-party vetting. I know Lisa talked about that being one of the big threats, right, that we have to really anticipate and pay attention to is making sure that we have that oversight and performing our due diligence, making sure that we're not only requiring their security attestations from a questionnaire perspective at Kaiser Permanente, we're going a step further, which is we're doing joint exercises to truly validate what they're putting in those attestations. Again, because we do know that that is a huge gateway into vulnerability into our system. What we are big on at Kaiser Permanente is really doing threat emulation and really, doing exercises beyond tabletops. And we've really evolved our scenario-based planning that and making sure that we can truly pressure test all of this response processes and even technologies that we've put in place. Lisa, I don't know if you have things from your organization that you might want to add.
Oh, I completely agree. I think we have to take it beyond the tabletop. I think the whole industry is looking to that as well. And I love that we're hearing of different organizations that are bringing in vendors, right, to be part of that exercise. At St. Luke's, we work really closely with our executive team, and we have amazing support because we've provided them the education along the way of what the impact could be. And I think one of our chief physician executive put it the best, that we had done, a series of educational based kind of workshops and tabletops. And he compared it to when they do a simulation to get their code certification. And he said, this has all been really great, but next time I want us to run a mega code. And he said, what I mean by that is I want the same heart palpitations, I want the same stress, and I want that same feeling that I have when I'm running a code in the hospital. And so that has really, he said that early on in the start of our program, and it's really become the backbone for when we put an exercise out there, right? We want enough of that nervous energy to make it real life. And like you said, at the end of our code simulations, we have an evaluation and someone will tell us like, this didn't go well, so the patient outcome wasn't really great, and so he goes, we need that same exact evaluation while we're going into these to help us improve and help us evaluate and continue to mature. And so I couldn't echo it more that it's really that pressure test. And I just love the way that our physician put it, is because it resonates with our clinical users as well, right? To be able to go in and take an example and be able to relate it to them, just like they do just-in-time simulations on their unit, or they'll do it in the simulation lab. And so we've tried to integrate a lot of our processes into that same methodology because it's what they know, it's what they're used to doing, but it just brings a different layer and a different scenario that they might not used to be simming as well.
Lisa, I really like that you said that, because at Kaiser Permanente, we actually call it a code doc. And we've just, I think last 2 years ago was when we implemented it. And it was for the very same reason that your physician said, right? In the clinical space, when they call a code blue, everybody knows exactly what to do. And so you don't need a book, you don't, and so that's the same thing that we're doing with our code doc. And for us, a code doc is all technology is out, whether it be because of a cyber event Or, you know, in the last year, late last year, at the end, we had the CrowdStrike incident where IT was out as a result of that. So when we call a code doc and we continue to exercise our code doc for that same reason, we want to make sure that every employee knows exactly what to do, not just the immediate steps, but all of those strategies that will help us to continue operations in the middle of that.
That's great. I love that the two of you obviously swim in resilience every day, because I ask you about problems and you're immediately going into how do we respond to those problems, which is great, which is really how we all need to start thinking. But let's lean a little more into that now. If we think about how we respond to these problems, what are, Lisa, what are the key components of an incident response to one of these threats being realized?
Yeah, I think there's a few different factors that you have to take into play in order for your response to be efficient. The first being your technical response and being able to ensure that you have solid processes or a major incident process that hopefully you exercise all the time. And so it's just like Sola said, it's just a normal process. I know here at St. Luke's, we have a good solid process that we're proud of. Not to say it's perfect by any means, but at least a solid process that we can build upon. I think that second, piece of incident response that's important is having the opportunity for your clinical team to dock in and be able to act as a partner. I think historically, if there's something going wrong technically, the clinical team would look to IT and say, what should we do? And it's like, we don't know. Like, we don't provide patient care. And so I think establishing a framework that allows, whether it's incident command, whether it's a command structure, whether all of it is, but how it's organized. And Nate, you provided some really great feedback kind of after your response on this too, that we've implemented at St. Luke's, is the importance of having IT and cybersecurity at the table as part of that command structure, so that they're not necessarily the incident commander driving it all, but they're part of the collaborative response, really aligning those tasks and objectives so that you have a good, solid process. And I think, CrowdStrike's a great example, Sola, like, thank goodness that it was not what we thought it was, maybe in the middle of the night. But we were able to implement those same processes. And while we had our technical teams really looking at, doing failovers and re-images and those kinds of things, by having our IT leadership docked into that command structure, it was really valuable to be able to identify the critical areas, the restoration sequencing and that kind of thing. I'll say the third piece beyond that is really ensuring that you have processes, whether it's playbooks or checklists, processes, forms, documentation that's written for the bedside to be able to continue those operations until you're able to restore them. In reality, we put a lot of time and effort into ensuring that those downtime processes are solid, because it's the lifeline for our IT and our cybersecurity departments to have the time they need to be able to recover efficiently. One thing that we found to be really successful is, as we're building this, we're building it with the bedside for the bedside. And I think it's been extremely critical for us. And while it takes a lot of time and it's not ideal, we're like Sola, we're a multiple hospital system that covers the whole state of Idaho. And so a lot of travel time, but being able to sit with those end users and those clinical experts in a conference room and develop downtime processes for them is so validating that at the end of the day, when something happens, it's a document or a playbook or a form that's been vetted by the bedside and will be a helpful resource to give them that confidence that we're all striving for them to be able to continue patient care and continue to do their job in a way that's safe and makes them feel good at the end of the day.
One thing that I will say about downtime processes, and Nate, quite frankly, we learned this from your experience, I believe in 22, and I may be getting the years crossed now, or 23, is a lot of us feel like we have downtime procedures, and we do. But the downtime procedures that we have are intended for short term and planned for the most part planned outages, in some instances unplanned. But the downtime procedures, Lisa, that I'm sure your references are intended for longer or prolonged outages. And learning, doing that information sharing with Nate helped us at Kaiser Permanente make that mindset shift to say, we need something else that is going to be able to sustain us in a much longer outage versus the short-term downtime procedures that we have. One thing that I'd like to add, Lisa, is a communication plan. I think I dare say that's one of the most critical, is the ability to get in front of the information sharing, whether it be externally to our regulators, our patients, media, vendors, other partners and associates, or internally with our employees. So because as you know, misinformation spreads even faster, right? And it's in the best interest. And you talked about it earlier, right? One of the, I think, goals for the most part of this threat actors is to spread that misinformation because they know it impacts the reputation and the brand of the healthcare organization, thereby forcing them to pay ransom, right? Because nobody wants to be in the media saying that you're going through a cyber event. So getting ahead, having the crisp talking points, being transparent is critical as part of planning for a response.
Sounds like, a lot of what you're talking about goes beyond just having a plan, just having processes. It sounds like there's a lot of relationship building involved here and really establishing an entire culture in your organization around cyber resilience. I wonder if we maybe dive in on that topic a little bit more. How do you really establish that culture? What are things that you can do from your seat? What are the things you need out of your leadership to really establish that culture throughout the organization of awareness and resilience?
I think for us, it's education, to be totally honest. When we'll talk to different leaders or different clinical departments, and when we share what the reality would be, in a cybersecurity incident, it's almost like they can't believe it. It's really hard for them to wrap their brain around it. I think as we know in tech, what the network means and how everything's integrated into the network. And so trying to explain a network downtime to those individuals is really challenging. But I think that information is powerful. And so being able to really put the what behind the why is really critical, not only for building processes, but also for building support and being able to develop and implement those. I think also we have an amazing team at St. Luke's that does, threat review and threat hunting. And so I think being able to provide the reality of the landscape. And so really being able to validate, why we're doing this work, because the reality is it's happening every day. And so for us, how we build that culture is by, sharing information, educating our staff, but also being able to use their power or their interest in this. Because I can guarantee if you start talking about this in any industry that you're in, to be totally honest, if you talk to a group of 10, you're going to have at least one person that's going to really latch onto this and really understand the potential implications of a cybersecurity incident. And then that one person becomes one of your champions or one of your super users. And so I think being able to continue that conversation is really critical in building that culture of cyber resiliency all the way across the board.
You're spot on, Lisa. But I would add that also integrating cyber into governance, making sure that is a standing item in strategic planning. Identifying executive champions, that is key. That will help champion all of those cyber initiatives and making them the champions that will also go in and help influence their colleagues. I think that's critical for us. Having those joint committees where you have, to your point, you talked about it, IT, clinical, risk, all sitting at the table. One thing that I say when we do our workshops similar to yours is that resiliency is everybody's job. Traditionally, it was IT's job. But today, because it directly impacts patient care, it directly impacts patient safety, it has become everybody's job. And then helping shift the thinking from that traditional approach to what it is today, I think helps. I think another thing that helps is having those shared goals, shared KPIs, right? When you have some performance tied to it and aligning cyber resiliency with clinical outcomes, I think that also helps with the culture shift, and helping folks look at it not as change, because change traditionally is often looked in the negative, is often perceived negatively, because then you think it's something else and there's always resistance to it. But making that culture shift an evolution, changing the language of how we present it to them, that this is an evolution. This is now how we do business. We're shifting the way we operate. Um, Simulation exercises is key. I keep going to that because, to your point, Lisa, that is what gets that heart really pumping, where you do that threat emulation and you pressure test, and people really feel. Now, it's not just talking about it, it is experiencing it and going, this is what you mean. This is what we might go through in a prolonged manner. I think that is also helpful with that culture shift.
Great. We talk about leadership engagement and these exercises. I know in our real world scenario, when this happened for us, there was a lot of questions that came from leaders, right? From the CFO, how are we going to make payroll? What's going to be the cash flow? From the CEO, who do we need to talk to? How are we going to talk to them? Maybe talk to me a little bit about, like, how do these conversations kind of come out in the exercises that you've had? How do you field those leadership questions and manage that interaction with the leadership team through one of those?
So I think, like I said, it's the aha moment. So the question around how do we make payroll is huge. Well, when we started to look at this and we started our exercises, the focus was more on how do we continue uh, patient care, which is the true north. But how do we make payroll uh, came up rarely in one of our last exercises last year, and it was a huge thing. Kaiser Permanente, we have over 300,000 employees, and we want to make sure that we lessen that burden on the employee population, because a lot of folks live paycheck to paycheck. And it's important that we start to think through what is our plan. And that didn't come up until last year for us to say, we need a broader plan. How do we manage this? So that's one. And then the second part is, we know that it's not going to be perfect. What is our plan, our true up plan, so that we're not putting that burden on our employees? So having those conversations, what I see is that the executives, it becomes very clear what we're dealing with when we start to bring this real life issues. But what we are showing them, using that, we're not just talking about it sort of like in abstract or conceptually. It is becoming clear as a result of an exercise or a simulation that we did. So that makes it more real, and it helps land the fact that we need a plan, and that plan could also mean having that alternate technology or alternate pathway outside of our regular process, outside of our network, that will continue to make payroll, because to your point, it's critical.
That's a great thing. So, Lisa, as we think about some of those leadership questions that come up, are there resources that are available that are out there that might help folks as they talk to leaders, with kind of prime the pump of what those questions might be and address them ahead of the event so we're not doing it in the moment?
Yeah, definitely. I think one of the big things I always like to put out from a cybersecurity lens is we're not in this alone, whether it's cybersecurity. And the reality is, from a healthcare perspective, we're definitely not in it alone. I'd be hard pressed to say that there's any hospital across the country that has open beds that they have to spare. I don't think. And if they have open beds, I bet they don't have nurses to fill them. So I think healthcare as a whole is being challenged right now. And so the reality is we need all of us to have a level of cyber maturity, because we're really in this together. And if one of our main healthcare organizations is impacted, we're all impacted as part of this. I've been fortunate enough to be an active member in the Health Sector Coordinating Council for about 5 years now. It's a phenomenal organization. It's part of the cyber working group through the federal government, but a free organization that really helps to not only bring awareness, but also education and resources on healthcare cybersecurity, which is fantastic. As part of it, not only is it an opportunity to network with peers across the country that are dealing with a lot of times the same issues that you're dealing with, but additionally, the Health Sector Coordinating Council, Cyber Working Group, really does a great job in putting out resources. Nate and I have been able to collaborate on a few of them, whether it's we partnered with the emergency management sector early on to develop the I can't remember the acronym for it now. You'll have to remind me, Nate, but it is literally job action sheets ready to go in the case of a cybersecurity incident. So really partnering with emergency management. So we're not reinventing the wheel by any means, but developing those resources that can easily slide right into their emergency operations plan and be activated during a cybersecurity incident. Additionally, we worked closely with Nate and his team to develop a template for a cybersecurity incident response plan. While we're really lucky here at St. Luke's to have a strong cybersecurity team, and SOLA is as well, I think the reality is we're the minority, and that there's tons of healthcare out there that don't have a concentrated cybersecurity team. And so really this tool, which I think the acronym is CHIRP for this one, was meant to be a template that you could leverage to start those conversations with your leaders and your IT teams to start building out a cyber incident response plan. Most recently, though, we did develop, we had identified that we had response tools. We identified that we had a great technical tool, but exactly like Nate was talking about, the gap that we were missing was the executive level. And I think that what our executives need to be thinking about is different than our response teams and our technical teams. And so about a year ago, we put out a white paper. It's nice and short because we know executives only want short. And so it's about a page and a half, but I think it's called From Panic to Plan, the things that executives need to know about cybersecurity. And it really focuses on exactly what Sol is talking about. What are those executive considerations that they need to have going into an incident, whether it's incident response, whether it's reputation and communication plans, or business continuity. And so really, I can put a link to the website in this chat, but some really great resources and the opportunity to really grab and go resources that can be helpful for you and your team, whether it's response, technical, or executive, to help start those conversations and really help moving towards more of a mature environment as well.
That's great. And Lisa's far too humble, because if you look at any of those 3 documents that she talks about, she wrote probably 80% of each one. So we're really lucky to have her in the industry. Rounding out our conversation here, I think I'm going to take it all the way back around to something that was brought up early on in the talk, which is third parties. Traditionally, we kind of worried about third parties just from a data breach perspective, right? We signed BAAs, we maybe had indemnity clauses. If some data goes, it's not great, but that was what we dealt with. we've had some events in the past year or so that have shown us that third parties can become a real resilience issue as well, not just a data breach issue. So how has that kind of changed your approach, or what is your approach as an organization to really, how do you both assess and improve the security of your third parties partners that you work with?
Thanks, Nate. And you're absolutely right. We've shifted our thinking and we continue to evolve how we manage third party or vendor risks. We do risk assessments, which includes security questionnaires, audits, certifications. But like I said earlier, we're moving away from just the questionnaires. We want to do that additional layer of validation by doing that joint vendor and Kaiser Permanente exercises so that we can truly pressure test the same way that we pressure test ourselves. It's also tightening our contractual controls. Making sure that, and we're working that with our attorneys now, making sure that we're tightening those security requirements, those breach notification timelines, and the liability clauses. It's doing that continuous monitoring, watching for those third-party anomalies and data flows in our network. So from a risk assessment that we do a business impact assessment. We want to make sure that we know how third-party failures will affect our operations. We do make sure that we're doing proper, consistent security practices when we're onboarding and offboarding our third parties. We have our security scorecards and ratings to evaluate those external risks. We are also tightening our business continuity plan requirements. That's one of at least my goals this year, is to look at all of our critical vendors and tighten those business continuity. We want to truly understand and assess and pressure test those business continuity plans to make sure that it is sufficient to sustain our operations. And if it's not, then we need that redundancy to make sure that if that third party is impacted, we know what we need to do to continue operations.
I think I would really follow up with kind of what Sol is saying there. I think risk assessments are great. And I think simulations are great, but the reality that all of us are facing is you can have gold standard cybersecurity tools and you're not immune from an attack. And so I think from a resiliency perspective, we partner really close with our GRC and our risk team within cybersecurity. But the reality is it's not if, it's when, is what we hear all the time. And so from a resiliency perspective, it's taking that next step to assume that we would be without that vendor for an extended period of time. One of the things that we're doing at St. Luke's is we're really taking a look at our business impact analysis that we completed. And historically, those have been targeted towards applications and internal processes, really targeted towards short-term. I think even our old BIA said 4 hours or less, which to me is just not even realistic with today's threat landscape. And so a huge project that we're undertaking is revamping our business impact analysis to be more of a recovery framework, really going service line by service line to better understand what are the dependencies with each of our vendors, what are the dependencies on our applications, what are the dependencies on open network connections, but then also a huge one is what's the dependency on the med device or the IoT for us to continue that service. And through that, being able to do a new assessment, not necessarily a business impact analysis, but one that helps us identify, what are the pieces within the services that we deliver that are essential? And if we were to lose them for an extended period of time, what would the impact on that service be? I've been kind of telling people it's like the game Jenga, right? Like if you take this piece out, is it going to wobble, but it stays up? Or if you take this piece out, does the whole thing fall down? And so I think, well, it's a silly metaphor. It's easy to understand of what are those things that are our Jenga piece? Like, what are those things that if we were to lose the connection to them, we would have critical barriers to continuing patient care or operational impacts of not being able to get paid or continue operations. And so to Sola's point, I think that's the direction we have to be going from a resiliency perspective. Is it's bigger than us, it's bigger than ransomware, it's bigger than just what's within the applications or the things that we can control. Because the reality with these third-party pieces, is it's not our attack, but at the end of the day, it's our problem, and it's something that we have to then work through. So I think for us in a resiliency perspective, we're really looking towards what it looks like to operate without one of those key vendors, and doing assessments to not only identify them, but then build redundancy and build process improvement within our own current processes there as well.
I think that's great. I really appreciate how both of you have kind of talked about how you come about that third-party problem, and that yes, we want to make sure our partners are as secure as they can be and they're as reliable as they can be. But we also have to understand hope isn't a plan, right? And so still knowing that no matter how good of a job you've done on that risk assessment of that third party, no matter how much scrutiny or extra review has gone in, it could still happen, right? And understanding the impact on your business of that loss of that partner and how are you going to work through it, I think is really critical. And I think that theme has kind of gone throughout all of your answers today, and I appreciate that. And I think that's really where I hope people take that away as one of the main takeaways from this talk, is that way of thinking about how are we best prepared, but how are we also prepared for the things that we hoped didn't go the way we hoped they would, right? And that resilience, both as an organization and as people, is really what we need to have. Really appreciate your insights and input today. I hope everyone got a lot out of this. I'm going to pass it back to Michael at this point to wrap us up. And I think they have further talks coming up in this break room that I hope is great for everyone else. Back to you, Michael.
Thank you. Indeed, we do. Thank you, Nate, Lisa, Sola. Fantastic, informative session. Great to have you. And yes, this is a bit of our cyber resilience, cybersecurity track here at the spring conference. It's my pleasure, speaking of cybersecurity, privacy and security and the like, to introduce Tantian Nguyen with Kaiser Permanente. Tantian is the co-chair for WEDI's Privacy and Security Workgroup and the moderator for our next session.
All right. Good afternoon, good morning, everyone across the nation here joining us on this WEDI Spring Conference. It is my pleasure to introduce our next presenter, Mr. Rick Dolan, who is VP of Information Security, Centene Corporation, also CISO for Caroline Complete Health. The topic that Mr. Rick Dolan will present is AI-powered cybersecurity, leveraging machine learning to detect and prevent threats. Sounds like a very exciting topic and of high interest to most of us. Rick, please take it away. The floor is yours.
Thank you very much. Real excited to talk to you. The AI is a topic that we all wonder about. There is a lot of great information. There's a lot of great uses for it. There's also a lot of great misinformation. But as an information security person, I like to focus on solving problems. And I will share my screen for a presentation that I do. And it's interesting because this particular presentation I have done a number of times in the last 3 months. And as it evolves, our technology has evolved, and you'll see that, and I'll bring it up in a minute. So this particular focus is on automated remediation, because while the topic is kind of like detection and preventing threats, we have more than enough tools, and I'm going to show them to you, that identify what our problems are. Our challenge is in fixing problems. And so I'm focusing on configuration management and vulnerability management. These are foundational to cybersecurity. I can't protect what I don't know, and I can't, and usually particularly in ransomware, they're not using zero-day threats that are like exceptional capabilities. They're using basic things like they're rattling doorknobs and looking for an open door. And so just keeping your systems up to date and remediating vulnerabilities in a reasonable time will make you exponentially more secure than those who don't. So, as I said, my theme is we have more problem fixing things and finding things. And the other thing is that structurally, security teams don't remediate. Security teams find problems. We don't actually fix the problems. And so that's a thing that's going to come into play a little bit later about this. And I'm going to go through how this will work. We also are not giving the proper severity level to the impact. When we were just the previous discussion talking about, incident response, it's like when you need to triage something, and same thing, triage comes from healthcare, right? It's like, who's bleeding the most, who needs to be put in first, and right now we're relying on tools that have the CVE ratings or some other things that they think that, oh yeah, this would be better for this box, without knowing what does this box actually do, what data is being used on it, is it public, is it inside, is it development, is it at network externally facing, et cetera. And then finally, it's, do we have the right people fixing do we have the right information to the people who need to fix the problem? This was something early, even 5 years ago when I'm talking to the first posture management tools, and so we're finding all these flaws in the containers and cloud. As I said, depending on how that flaw got there, it could have been through development or could have been through in infrastructure. And infrastructure uses ServiceNow to manage tickets, and the developers use Jira to manage tickets. And you need to know which way to go. Otherwise, you're going to add more time or inconvenience to them to be able to fix it. So we want to get them where they are. So here's the reality of today. And so I kind of have a biased position because thankfully I'm in a healthcare summit, so I don't need to explain who Centene is. Everywhere else where I talk, I need to kind of go, we're the biggest company you've never heard of. Let me tell you what we do. So being in just generally a well-funded, well-resourced organization, we have a very different viewpoint than providers and hospitals and everybody else does. And even unless you're very, very big and also well-funded. But in my peer group, and I'm based here in Charlotte, and I'm like the social coordinator for my CISO community. So we're very tight, and we have everyone from the biggest banks to Lowe's Home Improvement down to Krispy Kreme and National Gypsum and Honeywell and Haywood, and so we have a very diverse group, and so we talk about this all the time. And so across all industries, we have all of these tools that are telling us what's wrong, and we have all these tools that are helping us quote prioritize and saying, well, this is what you need to fix because it's more critical. But because we may be stacking these tools, whether it's the containers, as I mentioned, the data posture management, the identity posture management, the API security, all these things, all of them are also like looking in the same way, because how these work is they have access into all the telemetry. So your cloud systems, your asset management tool, your endpoint detection, your firewalls, your network detection, your web gateway, your email gateway. So they have API, the automatic kind of connections to it, and they're pulling things directly from it to do this crowdsourcing of what's there. And most of them are pulling to the same things. So there's this huge duplication of findings coming from all of these that's just going into this mesh. And then this is what it feels like, right? We all seen this great video from Lucille Ball in the 50s where the chocolate keeps coming and they just can't put it in the box fast enough and they're struck. We're getting tens of thousands of vulnerabilities in my company a week that humans need to fix because we've automated the finding, but we haven't automated the remediation because we're afraid of it, because we don't trust machines fixing things. And I'm going to talk through this about how we can, and we should, and we have to, because we're right now. We're not getting, we are not fixing things, and the adversaries are using AI the same way that those tools are to be able to find problems and exploit them. So from a security standpoint, are we contributing to the problem? Are we sending it to the right workflow? Like I mentioned, are we giving them enough information to know what the problem is and the full scope? And are we giving them realistic timelines? Because in some regulations, right, it's like, hey, critical vulnerability needs fixed in 72 hours, and it's like, okay, fine. But it may not be as simple as that, because what people don't realize is that when me as a security person throws over the fence this big report to say fix all this stuff, or even if I'm so bold as to put it into their tracking system and now make tickets for them to make it easy and put all the information in the ticket, they still need to go through these 7 gated steps. And it's not as simple as like, oh, they need to figure out, like, is this real? Or is this a false positive? What's the root cause? Because it could be an application thing, could be a database thing, could be an operating system thing, could be a network thing. What is the impact and the priority? And this could be a whole presentation in itself about something that is externally facing, it's a vulnerability with a known exploit, and it has critical data, is different than something that is like a critical vulnerability on a development system with dummy data and it's deep in the network that no one can access. Like, fine, but security just sees what comes out of the tools, right? They need to figure out how to fix it. And will that fix change the scope? So if I patch it, then do I now need to patch these other things? Or do I need to upgrade the operating system to put in the patch? Or do I need to, is there going to be incompatibilities? They need to figure that out, and what these dependencies are, or if it's going to impact performance. And so we need to test it. And so we test it and we apply the patch or we apply the fix and we say, oh, well, it's really degrading performance. And when we do that, because, for whatever reason, we can't really do that. And then let's say it all works out and it works fine and the patch is good and it doesn't impact performance. They need to schedule when it's going to be deployed, some green zone or how I'm going to push it out. And I'm telling them do this in 72 hours or sometimes 24 hours. It was like, well, I still need to do all these things. So when humans doing it, we really can't keep up to date. So how can AI help? And so it can automate the collection. It can help in determining real risk rating by pulling in things from the business impact assessment was mentioned. Love those things. They're really a pain in the butt to do, but they're really, really valuable once you've done them to say, okay, well, this can't be down for more than, an hour. So this becomes very critical, regardless of if it's a medium or some vulnerability to it. We need to assign it to the right department, determine the root cause, and determine what the potential impacts are. And so all of these things, there are tools today, which I'll show you, that can do all this. Great. What we didn't have up until recently was the testing piece. And this is where the trust comes in. I was on a podcast last year talking about this topic before I made this presentation. And I said, we're all still have PTSD from the early 2000s when we went from intrusion detection system to intrusion prevention systems on our networks to say, instead of saying, hey, here's some malicious traffic, it's, oh, here's malicious traffic, I'm going to block it. And everybody had these experiences where whole network segments get blocked or some things happen or businesses, are offline for a period of time because it magically thought it was protecting you, but it was actually not. And it just took things down. And that's what we think about with automated remediation. But that's not the case now, which I'll tell you and I'll show you. And that's because now we can test it. And so there are tools now that will spin up something, it'll test it, it'll pull all the data and it'll put it in the ticket and saying, hey, this is what we do to fix it. We tested it. It doesn't impact performance. All of the metrics are right there. All you need to do is push this button and I'll magically fix it for you. Because whatever the human would have done, AI can do it as well. Because what our robot friends do is, something that I'm now becoming infamous for saying, is that AI, and particularly agentic AI, which I'll explain to you in a minute, is really just an unlimited number of interns with an unlimited amount of time. And I trust them equally, meaning that, like, okay, you go get this information and give it back to me. You three, go get this information, give this other person to correlate it in this format, and then give it to me. It's like you can give a task, but if I have an unlimited number of them who have nothing but time on their hands, then I can do a lot of great things in very simple basis. I'm not just like take over my job, but I'm having it do specific. So let me just spend 2 slides, which would be a whole presentation of itself, just talking about agentic AI architecture. Most when people talk about AI nowadays, it is large language models like ChatGPT and Gemini, and and Claude, and these are pretty much a capturing of all the knowledge in human that came from the internet, and then they train it on how to interact with a human and being some customer service, and what guardrails don't tell them about this or tell them about that. I'm not going to give them illegal information, et cetera, et cetera. And so that's a large language model, and that's what people think, and that really kind of just popped up in the end of 2022. I mean, we've been using them for a while, but then it really became public. We and those of us in healthcare know we've been doing predictive AI for 10 years, determining, the likelihood of readmission to hospitals or the likelihood of high risk pregnancies. I mean, but now we get into generative AI, which is, what an LLM is, which is it's predicting the next word to be able to say, oh, you want this, and I will go research and I will give it back to you. Okay. So you see the little brain on the right there. That's where LLMs fit into this. Agentic AI is having autonomous agents that can be those little interns that can access an LLM to get information. It can be fed from different sources, what its tasks are. It can interact with applications. It can, query people. It can do all kinds of cool little things. And it's just like, okay, intern, I want you to go through every single file in this in my database, and I want you to find how many people that are blue-eyed, that may have a blue eye in their left eye because they're heterochromic or whatever, And it would be very tedious for a human to do that, but an agent is nothing but times on its hand, and it can do it very quickly. And so it can remember things. It's like, oh, and just like when you're talking to ChatGPT. Now, the other cool thing is we can stack these and we can make this whole system and an ecosystem that they work in. And so some can be like project managers, and it can be hierarchical. As you do this task, feed it to this group who organize it and feed it into this, and then you create it and put it into a report and give it to the human. We can have, RAG is where it kind of goes back and asks for more information to like the large language model. We can have things that are planning and timing. I want you to do this only during these hours of the day. I want you to do this for this period of time, just because we don't want to burden the system. You can do all kinds of cool things, and putting them all together like this, this is what a multi-agent agentic system looks like. And this is what I'm talking about, that can be that thing that helps in fixing all the problems that all that other stuff is solving. And so how does it kind of work through this into the workflow? Is like, this is now what this network workflow. So we have all those things that are finding all the problems, right? And then it goes into an area that then normalizes the data, deduplicates it, categorizes it, and prioritizes it, groups it, and then it'll send it to the appropriate workflow, right? These go to the developers, these go to the security team, these go to the infrastructure team, whatever. Simultaneously, they could also determine what's the root cause of this, develop the remediation steps, and then identify the impacts, based on those things. And a lot, and then, a lot of, a lot of tools, which I'm going to show on the very last slide, is like, there are ones that do different pieces of this, right? A lot of them do up to that point where they identify the impacts. But then now we have regression testing, as I described before. Now that I have what it's going to be, I can spin up something and I can test it and make sure that it works. And then put it into change control process, put it into ServiceNow, Jira, wherever it is that they're doing it, to the right person, to the human, to say, here's all the data. I informed all these things, and now I want your approval. It's like, do you agree with this? Because it could be a steering committee that needs to approve it. It could be a manager. It could be a technologician, whatever it might be. Whatever the process is, it will feed into it. It is just doing the heavy lifting and the tedious work that you would send a bunch of interns to do, to be able to get out information and give it to me. And then it can also actually fix it and say, great, human, if you like this, press this button and I'll fix it for you across all these environments. And then if you don't like it, hit this button and I'll back it out, right? So the thing that I didn't mention, and I usually mention at the beginning, but this is not about security operations. The previous talk was about incident response, and incident response. There's a lot of great capabilities that this can do as well, and that's a whole other presentation. But this little red box, I just want to acknowledge that in incident response, that is about operationally, it's what happened, how did it happen, and make it stop. That's really what we want. And this concept that I describe can do that too. There's whole teams of programs that do, tier one SOC analysis and run books and all these things and data collection and isolation and all these cool things, so that can be done. But when we get to okay, I made it stop. Now let's make sure it doesn't happen again. Then it feeds into this workflow to say, oh, well, to make sure it doesn't happen again, let's patch the system, change this configuration, update this architecture, remove these permissions, change these permissions, etc. So I just want to acknowledge that, in security operations and incident response, this has a play in it, but that's not the topic of this. I'm talking about just the basic blocking and tackling of configuration management updates and vulnerability remediation. So to close out on this, because I just wanted, I want to, open up to a discussion, and happily go back to certain slides about this so we have all the stuff feeding into it. Now, who are the players in this workflow? I didn't mention at the beginning that I talk to a lot of startups. I'm up early at least once a week, to talk to some Israeli stealth company or startup that's doing all these things. And I've talked to everybody, most of the people on the left-hand side and everybody on the right-hand side. And some of these are companies that are just coming out of stealth. These are not big names you've heard of, but this is where the innovation happens. I'm not saying the big names of, your Palo Altos, your CrowdStrike, all these big names over here. Is like they don't innovate as much as they buy innovation from small groups in different parts of the world who do this innovation. And so that's who I talk to. And that's why I kind of have this perspective as I've talked to everybody. And so when we look at the top there, and I break it into three pieces, right? And going back to this workflow, like the first three steps is like, automate collection, correlate, normalize, deduplicate, and prioritize and send it to the right workflow. And these companies, Silk and Gem and Vulcan and Simplicity, and there's like 5 more that do this. I just had a limited space, and these are the ones that I know that do this. And then the next level is, okay, now let me determine the root cause, remediation steps, and then what are the impacts of dependencies, and then maybe come up with the fix. And these tools, Zafran does a lot of compensating controls. Daz does a lot of like creating code to fix things in applications. Gitpol does it on endpoints and being able to determine either compensating controls or create fixes to be able to fix things. All the other ones do similar things. And to be fair, some of the ones at the top bleed down to the bottom, and some of the ones at the bottom bleed down to the top. And frankly, some of them on the left-hand side, like like Codem, for instance, will automate the collection, prioritize, deduplicate, and then find the fix to you. But then we get into the regression testing. Now I need to test it to make sure it didn't break anything, it didn't impact performance, everything's going to work fine. And these two, Backline being the first one to come out of stealth that do this. D-Trail is more of just an agentic AI platform. You can make it do anything. So that's there for that reason. And frankly, Backline can also determine the root cause and deduplicate and all those kind of things as well. But some people like to have the handoff, and in big companies like mine, we like single-use tools, and we like things to bounce off each other. And if something goes out, then I can like replace it instead of like relying on this whole process for one. And the final thing I'm going to say about this is that notice the little Wiz. Wiz just got bought by Google like a month and a half ago for an obscene amount of money. They were a posture management tool. They identified vulnerabilities in thousands and millions of containers and help you in defining that. And they were one of the first to do that. Gem, which is a company that does the first layer thing. And then they bought Daz, which does the second layer of things, right? Of that I'm talking about, because they see this true as while we're like helping, but we're also contributing to the problem of like sending tens of thousands of things for humans to fix. How do we help those humans? And so I think that this is the future of how we're going to be able to solve for all the findings that we're going to have from all these tools that are now automating the vulnerability management and be able to catch up. Because all of my peers, the CISO peers I talk to, their IT department is struggling, just like Lucille Ball in trying to get all the candies in the box and get ahead of it. And they're trying to prioritize because like I can only fix 100 things I have a 10 I need to do. What am I going to do about it? And this is kind of how we solve with this problem. Because to me, we have plenty of things to find what's wrong. Our challenge is in fixing and automating the fixing of it at scale. And then we can start getting ahead of ourselves. So that's all I have from a slideware standpoint. Happy to go back to any slides. I'll kind of, if anyone has any questions and about specific things, so two things, and I'll answer a couple questions that usually come up when I do this. One, staff displacement. Okay, great. If you now automated all this stuff, all my little robots are replacing people, right? I was like, no, not necessarily unless there's another reason for it. Because if I had 10 developers and I can now make them, and they're using AI and they are now 30% more productive, why won't I just want 30% more productivity out of them? Because I'm sure they're behind and everything is late already, than saying, oh, great, I can cut 3 of you because to keep the same poor level service I have. So again, AI is not displacing at this point because of it's a productivity advantage. Unless your ethic and your sentiment of your company is different, then that may change. Secondly, is we may really change how security and IT do their jobs. Because like I said, my job is to find problems that IT either left in or that come up that are new, that had nothing to do with what IT did, but new vulnerabilities come out or new exploits come out, that they need to fix. Or when it's an application, the application developers encoded something and then they need to go fix it. If I can have these robots fix things, that opens them up to not spend 30% of their time in development and fixing problems. It is now they can just add more features and test more things and try to gamify it so they don't have these robots find different things. So that's like another kind of advantage to kind of having that. But again, it remains to be seen. It all depends on the culture of the organization. I think there's more opportunity in AI than there is threat from like a staff augmentation standpoint, because we all want everyone to be more efficient. So this could be a very, very big boon for it. And particularly in vulnerabilities where we're sitting on top of thousands of them coming from the stuff on the left, we need the help. So with that, I'll pause. I'll kind of, I guess I'll close I'll close this out to answer some questions if anyone wants to come off of mute and answer questions. Also anything related to AI, ironically, literally before I moved over to this call, I'm part of the Cyber Ed Board, AI Safety and Security Committee, and we were coming up with policies, for standards. I'm also on the Cloud Security Alliance, Privacy and Security Board, and helping and defining the new certification for AI safety for the Cloud Security Alliance. So I'm embedded in all of this stuff. So I see a broad view of how my peers are using AI, how AI is being used in what we're doing from a big payer standpoint, and then my peers on the healthcare on the provider side and what they're doing. So,
well, Rick, I certainly have a question that I would like to pose to you, and hopefully it's not too banal, but I think we definitely see that there is a lot of power in using AI technology to process and expedite the analysis of, umpteen volumes of information as you want to detect anomalies from the data or from the processes within your infrastructure, but also consuming, I would assume, known or the CVE, the common vulnerability and exposure, things that CISA put out and update almost regularly. So processing that, I think there are perhaps two things that might be barrier that needs to overcome, and please correct me if I'm wrong. Number one would be the trust factor. How do I have some reliance on that these AI algorithm will run correctly? Obviously, there's regression testing, et cetera. But number two is the cost of
Yep.
bringing AI into your infrastructure?
Yeah. And so, no, those are good questions. And the question, I always kind of come back with like, the short answer is like, well, what kind of AI, right? And so there's things that are public LLMs, there are things that are private LLMs, there are things that are, agentic, there are things like Copilot that's already embedded into Microsoft platforms. There's things that are embedded into Salesforce and some other software as a service. It's one of those things that it's embedded in everywhere to kind of as a human helper. So going back to specific your question, it's like, I think that of all of the like innovations, the cost is not in like, oh, I need to build this implementation and pay these licensing and all these things as much as the figuring out what you want to do and program and figuring out how to do it. So it's the brain power. And I was on an interview about, staff displacement, and they said, well, what do you tell young people who feel like there's no entry level jobs because all they're doing with AI? And I'm like, figure out how to do your job, figure out how to use AI to do your job more efficiently. Otherwise, somebody else is going to do that for you. And so that being an element to it. The trust factor really is, something that we talk about. I have a paper I'm doing with a couple academics that we should be releasing the next couple of weeks about AI ethics models. And we had a hypothesis that was wrong, but then we found the right one, and we did the thing about like, how do we impose ethics onto this system that has no, theory of mind and has no consciousness and have no thing. It's just kind of a neutral, it just does what it's asked like a robot, right? And so it's like, so how do I apply ethics to it to keep it in the guardrails of what I want to do? And that's a whole weighty discussion, and it's a 22-page paper about that. But I bring that up because one of the things we talked about is that, particularly with agentic AI and having these all robot interns, is we're putting so much scrutiny on the accuracy, completeness, and quality that they're doing that we have not been applying to the humans who are doing it today. Humans are slow, messy, and prone to mistakes. All of us had fat-fingered things and made mistakes. And everyone who's been in IT for decades knows like somebody had done some fat-fingered something and took out an application or a network or dropped something online and stuff like that. What do you think the percentage of accuracy for humans and the quality for humans is at a basis? And we're expecting like, 3 nines of accuracy for robots to do it, right? So I think just keep about that parity is that, we fearing the unknown because we're not sure. The second thing that I guess that is on that lines is, particularly for regulated entities like we are, is the transparency of what it's doing. Is the implementation can't be a black box. If it magically comes out in a black box, then regulators not going to trust it, auditors not going to trust it, we're not going to trust it. I want to be consistent. I want to show the math, right? So that implementation is important, which may kind of increase the cost to be more transparent in how you do it. But that's where, when we get into prompt engineering, I wrote a paper with one of my co-writers last year on neurodiversity and AI prompt engineering. I teach courses on neurodiversity and talk about how, hey, we question a lot of things, we can interact with it well because we can like, well, give me this, but not with that, and make sure that, and if you're not sure, ask me more questions. And unless you have, cited sources, don't say it, and give me those sources when you do say it, your confidence level of the accuracy and the likelihood of this. It's like, your prompt should be 200 words long, not like it's not a Google search, to make sure you kind of isolate it down to a certain point. And that's kind of how you get trust. But it's just going to take time for people to do that in this sense. So I see we have a couple of questions here in the chat.
We do. And let me read that to you. The first one is, what do you say is a realistic early win for small healthcare organizations in using agentic AI?
Yeah, I think automating the simple things. So even just like gathering data to do reports. And this is part of like even just as simple as what may be automatically part of Copilot that you have in your Microsoft platform if you use Microsoft, or if you're on Google, then your Gemini platform that's maybe embedded into the word processor or into the chat application. It can go look and just say, hey, create me a thing to go get this data and put it in this format. Or even do QA. It's like, look at this report and see if there's anything that stands out that may be inaccurate or misled or something like that. You know, again, think of it as an intern. What is a basic task that you would have an intern do? And then just tell it to do that. I'm not having it like, go, do prior auth, but it may be consort and say, hey, show me all the policies that refer to this prior authorization that the physician can then make a determination based on that. So it's like, how can you use something to do some tedious? Okay, hey, I have all this data in here. Can you put these 3 emails, put it into a format, put it in and create a spreadsheet that has them listed in this way and put all this data in that so I don't have to do that, or figure out how to make a pivot table to get this answer. So those are kind of the short wins, is just think of it as it's not much different than when calculators came out in the 60s and when spreadsheets came out in the late, right? Helping you like do the math for you. Realistic early win for some. Okay. And then the other one, can AI be leveraged in the deployment and contingency recovery plans? Yes. And that's a really good use of it. Because the other thing about agentic AI, for mature technical companies, we implemented SOAR tools. We had people who did script writing, right? The script writers like automated stuff. So, hey, I'm going to do collection of this information, or in talking about instant response like we did in the previous discussion, it was like, hey, I'm going to automate collection. So when I have this incident, I need to get the logs from these 3 things. I want to go check the configuration of this. I want to go query this other thing, and I'm going to do all that as a human. Well, now I can script that out, and I can just put in a script and do all that. SOAR tools helped you scale the scripting and also bring in change control and accuracy and hygiene and stacking them so that instead of them just directories and they could be wrong, you have like a more organized way, kind of like GitHub is for development, right? A configuration management and a version control kind of thing to make sure I'm using the right one and the latest one. And so the reason why I think about SOAR tools is that agentic AI is the next evolution of that. I don't need detection engineers to create detections and create scripts to do things. I can now talk to it in natural human language, like, when I see this issue happen, I want you to spin up a thing to launch this thing and do this thing. I want you to cut off this thing. I want you to do all these things, which again are very scary because we're having computers doing it. But again, we can test that, we can validate it, we can have it in our exercises to be able to run it in, as we go into our testing our DR plan to pull the lever and see, does it all switch over? We've been trusting that in our mirror, hot, warm sites, et cetera, so it can execute all those things. And we're like, in a much more rapid, accurate way. So yes, it can be leveraged for that. But again, start small, and work your way up. But just it's not introducing any new evolutionary capability other than just the way you can interact with it in a simple manner without having to know how to code. Most organizations are using it to get 80% of their code written, to make them more efficient, or come up with answers that they may not know how to do, or be able to do research. But it's not going to change knowledge. It's not going to replace knowledge workers, because while it is a great research tool, it needs to have papers to research, and who's writing those? And going back to, these AI, it doesn't have a consciousness. It's not going to wake up one morning with a bright idea and say, hey, I think about putting, marshmallow butter sandwich is going to be really tasty. They're not just going to come up with that out of the blue. You need to prompt them for it. And those humans are very, very valuable in using this tool to make them very effective. Again, going back to spreadsheets, instead of spending 3 hours of your day as an accountant adding up all the columns and the rows and making sure they're accurate, spreadsheets do this magically. And after decades, we trust that it's accurate. And we can prove that it's accurate because it's really easy to verify that. So what other things can I do? Well, let me look at the data this way, and let me ask it this way. So the last thing I'll say on that is kind of like, we're moving to a time, and some of the tools that I'm talking to are getting rid of their user interface. It's not these charts and these funnels and these diagrams and all this stuff. Is like, here's all the dashboard of all the things. It's just a prompt. What do you want to know? And just like, well, I want to know how many of my users are not using MFA to access this SaaS Go collect all that information and give it to you. It's like, great. Can you put that in a chart and then make it in a report? And I want you to give that to me every single week. Great, it can do that. I don't, it's just interacting it with natural human language and have it do the things that you want it to do that you may not have the skills to write a script to or an algorithm to be able to do. That's the entry point.
Great. I don't see any other question in the chat here.
All right. Well, I appreciate everyone's attention for letting me ramble about that. And I know it's like everyone's in a different place. And I think most people are still looking at AI as, ChatGPT and Gemini and Claude and, hey, and upload a document, say, please summarize, or can you take this and give me bullet points for it? And that's a great starting point. Get used to that. But then start thinking about other things that you can ask it to do and moving up. And then because in my peer group, we're beyond the, people to upload stuff to ChatGPT to summarize it because there's sensitive data in it. It's like, well, we should have figured that out 2 years ago. There are LLM firewalls that do that. It's a data loss prevention issue. It's really no different than you posting it on, Box or Dropbox. But we're talking about now it's embedded in everything, and we need to be able to understand like how we're going to be using it, knowing that this tide is coming in. You don't have a choice. But there are some great capabilities. So, but again, well, thank you so much for your attention and the opportunity to speak to you all.
Really, thank you very much, Rick, for an enlightening presentation. And I am going to turn the floor back to Michael.
Thank you, Tantian, and thank you, Rick. Fantastic presentation. Folks, we're going to take a break right now, afternoon break, and we will return, both rooms will return to regular programming and our fantastic content at 2:15 p.m. Eastern Time. It's currently 1:53. We will start back up at 2:15 p.m. Eastern. Take a break, take a load off, check your email, grab some lunch, and we'll see you in a little bit. Welcome back, everyone, to day 2 of the WEDI 2025 Spring Conference. It's my pleasure for the next session to introduce WEDI board member from Edifex, Mike Patwell.
Hello, everyone. My name is Mike Patwell. I'm a principal business advisor at Edifex, now Cotiviti. A bit more on the name change during the session. For those of you that do not know me, I've dedicated my 40-year career to software development, with the past 30 years focused on healthcare. I'm truly honored to volunteer my time to WEDI and to be a member of the WEDI Board of Directors, in addition to chair the WEDI Value-Based Care Workgroup. I also volunteer my time at other amazing organizations like CAQH, HL7 Da Vinci Project. But today, on this session, I'd like to introduce the WEDI membership to one of my over 10,000 new colleagues at Cotiviti, Katie Devlin. Katie is the Vice President of Interoperability at Cotiviti. Katie is responsible for creating an enterprise-wide health data exchange strategy to address our clients' unique business needs while reducing provider abrasion, maintaining regulatory compliance, and optimizing value. The topic for this session is building an extensible interoperability infrastructure. Katie?
Thank you so much. I'm really glad to be here with everybody. All right, so let's dive in. Some of you, as Mike just said, some of you may have already known that Cotiviti completed the acquisition of Edifex the past few months. And if you're not familiar with either of these organizations, Cotiviti works with both payers and providers, and we're really well known for our data, analytics, and services. And of course, Edifex is an industry leader in technology, particularly when it comes to healthcare interoperability. So this acquisition really solidifies Cotiviti's vision for enabling a high quality and viable healthcare system. So now as one company, Cotiviti really has this amazing ability to expand and accelerate the development of new solutions that can enable advanced analytics, drive interoperability, further improve value-based care, and then just ultimately have a significant impact on care delivery and patient outcomes. So today I'm going to focus the discussion really on creating value through interoperability. So we'll talk about, sort of what the market looks like, some of the challenges that I'm seeing, as, having led Cotiviti's interoperability strategy for the past few years now, lessons learned. And then, I've got some really tangible recommendations that can help both payers and providers see a meaningful return on their investment in interoperability solutions. Okay, so I think we all have our own idea of what interoperability is based on our particular organizations and needs. But just to level set for the purposes of this presentation, interoperability is really a broad term for exchanging information. And in healthcare, it's not just good enough to send the data somewhere, right? The data needs to go to the right person at the right time, in the right workflow, and then lastly, in the right format. Otherwise, it just doesn't work properly, right? We've got a lot of abrasion and we're introducing more issues than we had in the first place. So I think with all the CMS mandates and the relatively newer regulatory changes, the industry tends to think, FHIR, which is Fast Healthcare Interoperability Resources. There's sort of this tendency to think that FHIR is synonymous with interoperability. But really, we should be thinking about FHIR as sort of one protocol or one standard that is used to help achieve interoperability. And having a great strategy is really about developing a multi-pronged approach where you can leverage various standards and protocols across a number of different use cases, whether that's for acquiring clinical data or CMS compliance or closing care gaps, right? So for example, if I'm a payer and I'm trying to get data from a particular hospital or health system for quality reporting, that organization may prefer to leverage IHE-based profiles to share continuity of care documents, which is sort of the old school approach for sharing data. And honestly, that's okay for right now, right? So in this instance, you just don't want to leave data on the table, for this particular use case. So you have to think about how you can meet your stakeholders where they are from a technical and resource perspective. So kind of having this mindset, of having multiple ways to achieve interoperability based on your provider use cases becomes really key to success. So this visual is from healthit.gov, which is for those of you who aren't familiar with it, it's the official website of the now called Assistant Secretary for Technology Policy, and formerly the Office of the National Coordinator, ONC. You'll see here that as of 2021, nearly 4 in 5 office-based physicians, about a little bit under 80% there, and almost all non-federal healthcare acute care hospitals adopted a certified EHR. It marks substantial 10-year progress since 2011, when only about 30% of hospitals and providers had adopted an EHR and were actively using it the way it was meant to be used. And this is important because we are now seeing an influx of structured data across the industry that can be shared electronically, and whether that's via FHIR or other mechanisms. So we sort of see this sentiment echoed through the development of TEFCA, which is the Trust Exchange Framework and Common Agreement, which really sets the stage for nationwide clinical data exchange. It says, okay, well, now we've got all of this data. We've got a lot of adoption using EHRs. How can we meaningfully share it to make a difference? This data is also the driver for the CMS interoperability and prior authorization rule, right? Which mandates the use of FHIR APIs for specific purposes, like patient access, payer-to-payer data sharing, and of course, electronic prior authorization. So with all of that said, I think really the key takeaway from this slide is that in today's world, we have a ton of data that's available across different use cases, including treatment, payment, and healthcare operations. So now is really sort of the right time to create a strategy for optimizing how we share this data with other stakeholders, to both, one, make things better for patients, right? That's the primary reason. That's why we're all here. But then also, two, a close second, to make a positive financial impact on our organizations. So in the last slide, I mentioned that there's just a ton of data now available for treatment, payment, and healthcare operations, also referred to as TPO. And while that is a true statement, it is important that we understand that these are separate interoperability, what's called exchange purposes, or really use cases for the data. So you can see with this sort of inverted triangle here that treatment and individual access are really widely adopted across the industry, meaning data is very frequently shared electronically for these purposes. So some examples of specific activities that fall into these categories include care coordination, like referring a patient to a specialist or sharing a patient's allergy, or current med list, maybe with a pharmacy. It also includes the requirement to allow patients to access a complete copy of their medical record digitally. And that's exactly what the patient access API is used for. But it gets a little bit more challenging, right? If your use cases fall into the pure payment and healthcare operations category, because data is only sometimes electronically shared for things like risk adjustment coding or HEDIS reporting, though that's not where the industry wants to go. So it really throws a curveball, right? When you're trying to develop an interoperability strategy that can have an impact on your business. So you're saying, okay, all right, like, so then what do we do, right? We'll just go ask our stakeholders to share the data with us electronically. It'll be fine. But the reality is it's not always that easy, right? There's a lot of challenges out there that can interfere. So for the purposes of this slide, there's challenges and opportunities that are presented with different use cases. For the purposes of this slide, I'm focusing on those that relate to clinical data acquisition, because that seems to be a real common pain point for a lot of payers that I've talked to recently. And yes, there are solutions that you can buy, like the Epic Payer platform, that allows you to request data electronically. But even then, there are still struggles that I think it's important to really understand. So first, providers are not required to share data electronically with payers yet. They may opt to use the Epic Payer platform or Athena or Veradigm, or they may not opt to use it. They might say, no, I have a relationship with this copy service vendor, and you just have to go get the data from them, which could be seriously cost prohibitive. And then the information ends up coming in an imaged PDF type of document. So it's not structured data. It can't power your advanced analytics. And it's really, the opposite of what we're trying to accomplish here. Secondly, whether you create a point-to-point integration with a provider or a hospital, or you use an aggregator, each EHR system on the other end is configured differently when it comes to patient matching. And this doesn't mean that, Epic has one way of doing it and Cerner has a different way, et cetera. It means that how queries or requests for the data that you're sending over are matched to, how they are matched to the right patient is really all configurable by the organization itself. So for example, if I'm a payer and I'm looking to query an organization that has information on Katie Devlin, I'm going to send a request that has my name, address, and some other personal and demographic identifiers. But one hospital might take a more deterministic approach, right, where they look for an exact match to particular identifiers like a social security number. Whereas another hospital might be more probabilistic in their strategy and leverage different algorithms to figure out, assess the similarities between Kathleen Devlin and Katie Devlin, right, to see if that actually is the same person. And maybe maybe we see that Kathleen has the same phone number or email as requested in that query. So it would return a match based on that threshold that's set at that particular EHR level. So lastly, let's say you match on Katie Devlin and you get the data from an organization, right? There is still that challenge then of whether or not the data contains information that you need for your specific use case. And this can vary. For example, if you're looking for an encounter from 2021, but the data only goes back a year, it's a problem. Likewise, if you're a medical coder and you don't see the diagnoses or procedures that you're looking for, you're not going to be able to use that data. And remember, if we go back to how we define interoperability at the beginning here, it includes getting the right information, right? So now, I know I've really sort of put a damper on things, and maybe you're thinking, well, why even bother to do this, right? Like these are just insurmountable challenges. They're really not, okay? So first, I think we try and think about how can we grow provider participation, and I think it's really important that you simplify how you work with them. From a technology perspective, you have to meet these organizations where they are. If they are focused on public health reporting, or if they're doing maybe an EHR upgrade or a complete new cutover and implementation, they're not going to have the resources to put into an integration with a payer right now. So that's okay, right? That's, again, not insurmountable, because you have options beyond just doing a FHIR connection. Maybe it means for right now setting up an SFTP so that they can drop continuity of care documents or CCDAs on there until they get through this upgrade. Maybe it's not connecting to them at all and going through their regional health information exchange to get the data. or working with a vendor partner who is connected. So you really have to think outside the box, but there are ways to get the information that you need. Now, from a governance perspective, you might need a data use agreement or terms that can be baked into your master provider contracts. So it helps to work closely with your legal and compliance team to develop a pretty straightforward template that's able to be used over and over again, but also outlines how you want to work with this provider now and then in the future, right? So you want to make sure that you're describing every potential use case that you can think of and address any potential privacy or security concerns and really try and get ahead of those so that they don't delay you further down the road. That way, you don't have to keep going back and redoing these contracts if everything is outlined in here. So with that said, what do we do about the patient matching stuff? The biggest thing you can do here is make sure you have the most complete, comprehensive data set to query in the first place. So for example, I found that zip code and email addresses can play a huge part in matching. If you think about how long you've had your personal email address, it's been a while. I know, like my own mother-in-law still has a Hotmail address. So it's a pretty powerful identifier when you're looking at patient matching. And if you continue to have pervasive matching issues with a data partner, you have to work with them very closely to troubleshoot that. And they may just need to do something as simple as adjusting their threshold or including an additional identifier for matching. My team has had a lot of success with that. We had one particular data partner that was matching at less than a 20% match rate, which was extremely low. And we're at about a 60% match rate with them now. So we're seeing a lot of incremental improvement just doing that kind of thing. Lastly, how do we make sure that the content that we need is there? It's not really just enough to test a connection and monitor things at the transaction level, right? We want to make sure that, if a record, we all want to know that a record wasn't returned because, there wasn't behavioral health, there were behavioral health notes or there was something else going on. But you also have to know if these records are usable for your end users, right? Your stakeholders. So you can consider having a team that's comprised of informaticists who really understand this data. Maybe they have a clinical or nursing background, or maybe they just have informatics degrees and have really understood these workflows and the context of the information over the course of time. You want to use those folks to audit these records regularly. This could mean, creating scorecards on a monthly or quarterly basis. Maybe they formalize their findings, in some other way. It kind of just is up to you how you do it, but you do have to have somebody reviewing this information. Either way, they should be working closely with your stakeholders and data sources to make sure that all of the data is there for your specific use cases. And that's something that my team, I know right now at Cotiviti, is hyper focused on. And we're actually looking at doing a data study across all of our data partners to try and identify patterns. So trying to get, there's constant ways to improve how you look at the depth of content in these records. Okay, so if we put this all together, how can interoperability help create value for your organization? That's what we're here to talk about. So first, it can help you maintain compliance with mandates like the CMS interoperability and prior authorization rule. You'll have the infrastructure in place because you're considering how to scale this, right? You're considering multiple protocols. You will have that infrastructure in place to handle all of these FHIR-based workflows and maintain compliance as time goes on. Secondly, having this solid interoperability strategy is going to help you acquire the data that you need for your organization, whether that's claims, clinical, doesn't matter. It's important, I think, that we emphasize that there is no silver bullet here. And data can come in various formats from various disparate sources. So again, we don't want to leave data on the table. Getting this information electronically is so important because it can reduce retrieval time. It minimizes provider abrasion. If you think about the more traditional methods of getting this data, it's a strain on the HIM departments in these organizations having to manually download records and fax them over or mail them over. So it really streamlines those administrative processes. And then this leads us into the next item really of data quality, right? Because efficient data acquisition facilitates consistent formatting, and it can reduce manual errors and inconsistencies. We're also seeing that the industry drives greater standardization of the data through the adoption of things like the US CDI, which is really a standardized data set, of elements and classes, right? That includes allergies, problems, medications, all of those elements and components that are super important to your stakeholders, right? And all of these certified health IT systems have to be able to support the US CDI. So this is a move in the right direction when it comes to data content. So this combined with FHIR really becomes the preferred standard, combined with FHIR becoming the preferred standard really helps contribute to having higher quality data overall. Still not perfect, but we're getting there, right? So thinking along those lines, right? Higher quality data drives the implementation of advanced analytics and then AI-driven programs, right? So we can generate deeper insights and empower ourselves and our stakeholders to elevate risk adjustment and quality programs, as long as other initiatives that you might have. So it can really drive, also this holistic view of members, and help further population health strategies for both payers and providers. So it is, data quality is really the foundation of driving all of these insights and advanced analytics as you're thinking about the future of your organization. So now that we've really talked about how it can drive value, how do you actually get started? And I think that no matter what type of organization you are, there are some solid things that you can do to help guide your vision. So first, expertise, right? I think it's important to set up an internal task force that includes different leaders across your organization. For example, earlier in my career, I worked for 2 different large teaching hospitals. And we used to always see interoperability sit in the IT organization because it was more transactional, it was more behind the scenes. But now there's just it's such a larger impact on workflows and business operations. So, yes, you still need the data architects and analysts, but it's also important to gain insight from IT, legal, compliance, and then clinical leadership to figure out what their requirements are, how this impacts their day-to-day, and then, what the impact on, operations is. So that, that's one key part, right? It's also imperative to monitor regulatory trends and figure out how they impact your organization. So whether it's somebody else or you use, your existing task force of clinical folks, use them for insight on this and help them help you contribute to your strategy. I'd say outside of your organization, you can think about joining external working groups where you can really test and learn about all of the new regulatory changes and maybe new requirements that are coming down the road. These usually don't cost anything, and they give you fantastic insight as to how other organizations are thinking about things. So one example is the Da Vinci Project recently established a work group to validate and test payer-driven use cases and called the Trebuchet Pilot. So this group brings payers, providers, and technology vendors together to test scenarios like e-prior auth and think about how FHIR can scale across the TEPCA ecosystem to really make sure that these technical requirements make sense for real-world scenarios. So we're not just throwing a bunch of regulations out there and not having them work in production. Moving on to the next one here, we've talked about meeting stakeholders where they are from a technical perspective. So it's important to implement a scalable infrastructure that leverages different protocols and standards that we've talked about, right, to integrate with different stakeholders. And this is a foundational component. So once that's in place, you can start to really establish a diversified range of connections based on your particular needs. This might include implementing the FHIR APIs needed for CMS compliance. It might include connecting to data sources like national networks or HIEs, or working directly with key health systems within your provider network, or all of the above, right? Probably some flavor of all of these things. Lastly, as you bring in all of this data from various disparate sources, it is so important to establish a strong data management practice. This means making sure that you have an intelligent way to store and enable this data for downstream use cases. So for example, this might mean that if you're going to map it to a common data model like FHIR to prepare for your digital quality reporting, right, that you have that foundation in place. Payers should also be thinking about semantic standardization of clinical ontologies. So that maps the data from different sources as it comes in from various EHR sources or claims or what have you. It maps them to standardized, really universally understood codes and concepts. like ICD-10, SNOMED, LOINC, et cetera. That way, they mean the same thing no matter where they come from or where they go. So one example that I think is an easy one for folks to understand is if you look at Tylenol 500 milligrams, the EHR might give you data and it might display Tylenol extra strength 500 milligram tablet. But then the pharmacy system might share that same data with you and it's just the NDC code. And then the claims data comes in and it has recorded as acetaminophen 500 milligrams. So having semantic normalization capabilities really helps standardize this information, right? And in this case, it would be standardized to the RX norm name of acetaminophen 500 milligrams oral tablet with the correct RX norm code that's associated to that. So again, we're comparing apples to apples, and it really allows your organization to advance these analytics, right? And think about how this can drive their AI strategy. So with all that said, do we have any questions?
Thank you so much, Katie. There's one thing when I first spoke to you, one thing that really impressed me was your career experience. Can you tell us more about your experience in provider engagement and now that you're working for a large vendor that is across both payers and providers, but your experience in the background and what you're doing now to help our clients is really impressive.
Sure. Yeah, no, thank you. So yes, I did work for a few large teaching hospitals, and I worked for health information exchanges as well. One in particular where I used to drive their data solutions arm. But at Cotiviti, my team, we have specifically focused on provider engagement. So we actually have a dedicated team that is focused on our retrieval operations side. We have obviously very high value, high volume sites that are, generating a lot of data for us. Our traditional side of the house works with, copy service vendors. We have retrieval agents. We have folks going boots on the ground. So my team they're more interoperability strategy experts. They partner with the retrieval operations team to identify where are some of the high value, high volume sites that we can go after and get an integration in place. They are dedicated to that. They've done a phenomenal job. We've grown our network from 110,000 unique provider NPIs to now over 1.1 million unique provider NPIs in the past 3.5 years. So they are just a phenomenal group of individuals. They have also worked with our legal team and compliance folks to create a standard data use agreement template so that it's very easy, sort of, cookie cutter now as we go to these organizations. Here's how we'd like to work with you. Let's talk about things. We have a very complex, not complex, but very detailed deck that we present to them. We will then bring in our architects to the conversation if there are any technical conversations that need to be had. So really just partnering very closely across all these different players, right? It's the outreach folks that, that have more of a business development background. It's partnering with our IT and legal teams to do this. And then it's, identifying the right ways to get this data. And sometimes we haven't had success, right? Where the providers say, no, I don't want to work with you, or it's, something that's not a priority for this year. And then it's taking it a little bit further and figuring out, okay, well, where do they contribute data? Do they participate in eHealth Exchange? Because that's, one of the national networks we're connected to, or the Kanza network, or do they share it through a, data aggregator that we can work with? Sometimes we bring our payer clients into the conversation where they're saying, we really need help getting this data. And we have a three-way conversation, and we've had a lot of success with that.
That's amazing. And when I first heard about Cotiviti acquiring EdFX, and just everybody, EdFX has been a great supporter of WEDI. And again, when I mentioned earlier, I'm very humbled and honored to sit on the WEDI board of directors and volunteer my time with these great organizations. When I first heard Cotiviti, the first thing I thought of was DXCG, right? The risk score. that, predicts how much a patient's healthcare costs are going to cover over the next year. That was the magic I saw. But could you maybe lead us into maybe some of the key business metrics that you focus on?
Yeah, no, of course. So for right now, we're focused on, from a clinical data acquisition standpoint, how are we driving adoption across our network? How many records are we getting back? What is the turnaround time? How does that impact cost across the organization? So it has resulted in significant cost savings for us over the past few years, and it's growing every year. So how much does it cost us to get a record manually versus digitally, right? Figuring out what that blended record cost is for you across all of your data partners versus that blended rate across all of your sort of more traditional retrieval partners. How many resources can that save in the future? How does that allow us then, if we can accelerate getting 40% of our data digitally, if we can, how does that impact things downstream for coding? How does that also impact the coder's efficiency? So measuring the number of pages that they're getting, the completeness of the data is a really big one. I mentioned that we're doing a data partner study that we'll be presenting part of that at our client conference this year. And we're going to, just build on that over the course of the next 6 months to see what the outcomes are of digital data when it's used for risk adjustment to start, and then what the outcomes of that coding activity was. So those kind of things right now. In the future, I imagine that it would expand further to how this powers analytics in different lines of business across the organization.
Great. Thank you. And we have an excellent question from Richard Popper. He's from SS&C Health, a great partner of EDIFX. So I'll read it off to you, Katie. Given your hospital system experience, what's your take on whether hospital systems will use their EHRs to implement the Provider Access API under the 2027 prior auth interop rule 0057F?
That's a good question, because when it comes to these mandates, right, the EHR vendors are not, at least at this time, sort of mandated to, they're not held to the same standards that the payers are. I do think that there is buy-in with the large EHR vendors. I do think Epic is doing some stuff to get ready for that, as is Cerner. I don't know if we'll see a mandate at any point, but I also think, you have TEFCA out there, provided that things don't change with this administration and it continues, to get funded and we continue along that journey. I think that's an area where that can help as well, especially with the e-prior auth initiative too. It's well positioned to support that with the network of networks approach. But I do see the bigger vendors building out capabilities and recognizing that they have to support it. I just don't know what the time, how quickly that's going to, come to fruition. But I would imagine in the next, year and a half, you'll see more traction with that.
If anybody knows me here at WEDI, I'm the guy saying it's going to take a bit longer. We need a bigger boat. But we have a follow-up question on that, Katie, from the new commander of WEDI, Robert Tennant. So he wants to build upon Richard Popper's question. How best can both payers and providers leverage these APIs to create successful value-based care contracts and arrangements, right? Risk arrangements. As you know, EDIFX has that type of a solution where, forced out, we're serving a number of states with 25 million in value-based contracts, with Cotivity's depth of data analysis, with data curation and the connections that a larger organization has. How do you see the new APIs, the new mandates, and how are they marrying with existing technology? I guess that's I added a lot. I definitely sorry.
Well, that's fine. I think honestly, we're going to see a lot more. Yes, it is really about that marriage of it, right? I think we're going to see a lot more focus on closing gaps in care. You can, these FHIR APIs, yes, you have them for compliance, but you can use the same type of approach to do things like care gap closure, build bidirectional interfaces to work, to build that, connection between payers and providers, to push data back into them, right? So if you have claims information or you have an alert that you want to push back into the EHR, whether that's via a Smart on FHIR app or to the Epic best practices list or BPA alerts, whatever it's called. Yeah, I think we're going to see more of that happen over time. I know that's something that Cotiviti is very focused on right now. So yeah.
Yeah, I know EdFX is, and when I first joined EdFX 9 years ago, it was because we tried to acquire them in my current company. So, and they were not acquirable. They were a silent vendor that really supported their clients, traditionally, faithfully. And since I've been part of Cotiviti for about a month and a half now, I see the same culture. So I'm really excited about the future. I'm really excited about an EdFX Cotiviti marriage and what can happen with the combination of both corporations. I don't see overlap. I see continuity. I see front door, middle of the road, back door connectivity, which is what is going to be needed to help this country move forward with healthcare. So not to get too sentimental there, but any other questions in chat? Otherwise, we can possibly move on. I don't see any questions. Thank you, Robert. Thank you, Richard, for your question. And thank you, Katie, for this very great introduction to Cotiviti and the value that this partnership, this merger, this combination of two companies is going to bring to our community. And we look forward to seeing you in many more WEDI sessions moving forward. So thank you. Michael?
Thank you.
Thank you, Mike. Thank you, Katie. Appreciate the presentation. Looking forward once again to seeing you at future WEDI events. We have a little bit of a break. We start back up at 3 o'clock. So let's take a 10-minute stretch break. And when we come back, cyber resilience and healthcare, federal perspective from CISA. See you in about 10 minutes. All right, welcome back, everyone. It's my pleasure for the next session to introduce the moderator. She is co-chair for the Privacy and Security Workgroup here at WEDI from Direct Trust, Leslie Berkeheiser.
Thank you so much, Michael. Good afternoon, everybody. Good morning to those who may be on the West Coast. It is my pleasure, as Michael announced, as the Privacy Security Co-Chair, to moderate today's CISA Fireside Chat. Our Cyber Resilience in Healthcare from the Federal Perspective is the title today. And I'm very pleased to see that Dr. Charles Sweat, Jr. has just joined us as well, and you may have heard him in the previous presentation. He is the Healthcare and Public Health Sector Liaison for CISA, the Cybersecurity and Infrastructure Security Agency. Welcome this afternoon, Dr. Sweat.
Yeah, thank you.
We also will be joined at some point, possibly soon, from Charlie Hess. She is the Director of Cybersecurity Division, Critical Infrastructure Protection with the U.S. Department of Health and Human Services. We're hoping that she's not just having some quick technical difficulties, and we'll go ahead and add her as we go. But if you don't mind right now, Dr. Sweat, it's just going to be a nice conversation between us, if that works for you.
Sure, sounds good.
Would you like to go ahead and just kind of quickly introduce what you do and how your agency oversees us before we get into the questions, please?
Sure. So as the healthcare and public health sector liaison, most of what I do is I help to coordinate between CISA, other government agencies, and the private sector when it comes to like outreach and response during cybersecurity and infrastructure security issues. To give you a little bit more background with CISA, so CISA is a component of Department of Homeland Security, and the different critical infrastructures are broken down into 16 separate sectors. And there are 8 of those sectors CISA is responsible for, and the other 8, there is a sector risk management agency, which is a government agency that is responsible for responding to cyber issues and providing response and recovery efforts for that. And for the healthcare and public health sector, that agency is the Department of Health and Human Services. Additionally, CISA also is responsible for the cybersecurity for the federal civilian executive branch. So we essentially are responsible for the cybersecurity for the government, just in general. So we do that too.
Wow, just that little thing also, huh? All right, let's just go ahead and get started. You know, when we think about everything that's happening today in our healthcare industry space and cybersecurity, we've seen so many cybersecurity bills. We had the most recent NPRM to modify the HIPAA security rule and kind of bring in cybersecurity issues related to that. We saw all kinds of wide-ranging comments about it. We know there's this need across the board for our requirements, if you will, to be aligned and kind of coalesced all the way around, and at the same time not be duplicative or redundant or conflicting. How is CISA working towards that to help us figure out how to align across the industry?
Sure. So I can talk a little bit about that. So in today's interconnected world, the importance of harmonizing regulatory cybersecurity efforts cannot be overstated. And as you're aware, the digital threat landscape is constantly evolving and becoming increasingly complex. But by harmonizing regulations, we can streamline processes, reduce duplication, and ensure consistency in the requirements. The harmonization of regulatory efforts with respect to both cybersecurity requirements and cyber incident reporting not only benefits organizations and businesses by simplifying compliance efforts, but it also enhances our collective resilience against cyber incidents. In addition, the harmonization of these frameworks would allow for greater collaboration between government, businesses, and other stakeholders, promoting the sharing of best practices and cyber threat intelligence, allowing for our nation to strengthen our cyber defenses and making it harder for cyber criminals to exploit gaps. And there's also the Cyber Incident Reporting of Critical Infrastructure Act, or CIRCIA, from 2022. We are still reviewing all of the private sector feedback to make sure that it is incorporated into updates and policies that would be put into statute that we'll need to have discussions on later on. So it's serving us well. We have many years of experience and we can use it to improve our systems and our communications, but the framework has been discussed for years and now it's time to take action. So.
Yeah. If you don't mind, I'm just going to add something as you were talking that makes sense. One of the things I've often struggled with is the basic HIPAA security in the healthcare space and how many components of that have been built upon and kind of morphed into cybersecurity. That's a real tricky one. I often have people say, well, I do cybersecurity, here's my security stuff. Do you see the two as being distinctly different? Do you see the two, basic HIPAA security and cybersecurity, as being very different, just from your personal perspective?
I know that, like, generally speaking, like, when I think about HIPAA, like, I think more about, like, straight up, like, patient medical records and things.
Mm-hmm.
And you see a lot more of that with, like, you know, HHS as the SRMA for that. And so they do a lot more direct outreach as far as medical issues are concerned. So that's usually my experience with seeing kind of that going on.
Mm-hmm. Well, and that makes sense, though, as to why we've got OCR with security and privacy, and we've got CISA, and we're watching as well NIST and a number of other authorities, and trying to figure out how they coalesce. So we appreciate your perspective and the opportunity to keep working publicly and privately together to kind of pursue that alliance. So thank you. One of the things we also do in the privacy security work group is we often obviously have OCR come in and speak to us, and we monitor corrective action plans and things that occur with respect to breaches. So as we do that, typically at the end of every year, OCR will provide us with a really nice report of all the bells and whistles and statistics on which issues were the top threats. The problem, of course, with that is it's typically historical. It's giving us a year or so behind, or even in some cases, multiple years. Obviously, with cybersecurity, it's moving so fast. What do you see as the biggest risks associated to our healthcare industry and ways we can work to mitigate? And after you're done, then I'll go back and introduce, I see Charlie Hess is here as well, so I'll bring her in after you. Go ahead and answer that, please.
Sure. So a lot of what we see in the sector is ransomware, and I'll give you some statistics on that. So according to the FBI Internet Crime Complaint Center, or IC3's annual report, in 2024, we had about 859,532 complaints with a total loss of $16.6 billion. This represents a 33% increase from 2023. And of those complaints, 256,256 reported actual losses, with the average loss being about $19,372. And so when these ransomware attacks happen, that leads to disruption of service, extended recovery times, and reputational impacts for the different entities, both large and small. But there are some ransomware mitigation efforts that CISA takes a prolonged approach to doing. One of those is the pre-ransomware notification initiative, and that's where we get like anonymous feedback from entities. And they say, hey, like we see like some weird things going on, they'll let us know. And so then we'll contact the organization like, hey, like, got reports of some strange things happening. Like you may want to look, at this and kind of give them a heads up before something already happens. And that kind of serves as like the before boom things that are happening. And on the back end, there's the ransomware vulnerability warning pilot. And that's essentially functions kind of like an after action report where we talk to entities that have had things happen and kind of pull that together and then distribute that out to other entities like, hey, here are some best practices that we recommend. These are the things that happen to entities that have been affected by similar attacks, and kind of gives us a two-pronged approach, like we can help before and can help after with the after action. And there's also the stopransomware.gov website that kind of serves as the one-stop shop for resources with respect to ransomware.
Awesome. That was actually going to be my question. One of my day jobs is I'm an assessor for direct trust, and I work with all different size organizations, all different kinds of entities, mostly business associates, but often others and covered entities. And I'll say to them, where can you go? Or where do you go? Or I'll have them ask me that question. So your stopransomware.gov is where you would suggest they go for all a kind of a blanket area for resources?
Well, for ransomware specifically, I've got another website that CISA has that we'll get into later, like kind of run too.
Awesome. Thank you so much. We will definitely come back to that. Charlie Hess, thank you so much for joining us. I did go ahead and read off your title a few minutes ago. I'm glad you were able to get in successfully. We can see and hear you beautifully now, so thank you.
Right.
Would you like to just kind of introduce yourself and what you do in the cybersecurity space, and then we'll bring you in on some of the questions as well?
Sure. And I apologize for being late. Kind of maybe perfectly, there is a cyber incident going on at the moment, and I was running back from a leadership office and dealing with that. And I'm sure we'll get more into that, but just as Charles said, it is a ransomware attack. So certainly seeing that throughout the healthcare and public health sector. To introduce myself, my name is Charlie Hess. I do work here at the Department of Health and Human Services for the Administration for Strategic Preparedness and Response, kind of lovingly called ASPR. And I am the director of the Healthcare and Public Health Cybersecurity Division. And really what our focus is and what my team's focus is on helping the sector prepare for and respond to cyber incidents. Healthcare is one of the most targeted sectors for cyber attacks and ransomware. And so we need to do a lot of work to bolster our resiliency. And so my little team here is really trying to work with everyone where they are to make sure that they're ready to mitigate the vulnerabilities and to respond. So Charles and I actually work a lot together in his role at CISA, of course. And CISA is a great partner of ours here at Health and Human Services, along with some of our other federal agencies and industry. And so my role is really working with all of those folks to help protect our nation's healthcare system.
Awesome. Thank you so much. So the first question that I had asked was related to all the cybersecurity bills and the fact that, remember, we're thinking from a healthcare industry perspective and oftentimes thinking about smaller providers and employer group health plans and other types of smaller entities. We're looking at all these, it's really hard to understand.
Hey, Leslie, you might want to turn off your camera. You're having some connectivity issues. Right. Seems like we're having a bit of a technical issue here. Let me try to.
He gave me the questions ahead of time, so I can go ahead and answer it.
Go ahead
if
and
you'd
answer
like.
that one. I will pick it up from there.
Okay, spoiler alert. I knew the question. So again, right here at HHS, we want to champion adoption of cybersecurity best practices within the healthcare sector, really focused on patient safety and protecting that sensitive healthcare information. That's one of the reasons our sector is so valuable to threat actors, is that we have really valuable information, and that when, organizations in our sector, even if they're really small, get hit by a cyber attack, it makes for a really bad day for a lot of people, and it impacts patient care. And that really just drives up the interests of threat actors, right? If you're thinking about ransomware, they're trying to get a lot of money, and the bigger the disturbance and the more kind of secret or valuable the data, like healthcare data, the more valuable it is to them, which is why we all have to kind of work together to really address that. And so with our partners, we are working, she mentioned some of the kind of the proposed laws that are out there. But we really want to focus on some of those voluntary standards. We have worked on the healthcare and public health cybersecurity performance goals, and that really gives all organizations, wherever they are, those steps to implement cybersecurity. Sometimes you think about cybersecurity and it feels really daunting. It's not like you can go in and just do cybersecurity. It's a lot of steps. And for smaller organizations that maybe don't have dedicated cybersecurity professionals, and they don't have all the tools that some of the bigger guys have, we are trying to give them the tools they need with those cybersecurity performance goals, and say, okay, here's where you can start taking those first bites. Here's where you can make some smaller changes and have a bigger, a really big impact on your resiliency, and, really hardening your systems without it being overwhelming. So we really want to talk about those voluntary standards and how we can all kind of get around those. And what the CPGs do, those cybersecurity performance goals, is they kind of graduate with you, where you can start on some of the more accessible ones, and then the bigger organizations can be working on those harder or advanced goals. So we do want to make sure we're making it really approachable for everyone in the sector, whether you're a small software provider or a single provider, a healthcare provider. You think about your single, dentist office or your single psychiatry office. We want to make sure that they have these tools, as well as, big companies and everyone in between. So we're really focused on those voluntary standards to kind of get everyone to be, a cybersecurity have instead of a cybersecurity have not. And we have, much like Charles mentioned about their websites, we have web resources too. And we have some through our 405D program that are specifically targeted to smaller organizations. We have in healthcare organizations, where at HHS, our focus is always on healthcare organizations. So we have some of those, even some trainings and videos you can share with your staff to help them think about cybersecurity and do some of those kind of good cyber hygiene practices. Things as simple as like posters you can hang up in the break room we have available, really to kind of meet people where they are and start those cyber conversations.
Thank you. And that's really important to us. We spend a lot of time focusing on the smaller entities, and we often refer to the 405D work. It's very practical and very helpful and very timely. Last question, then I'll catch you both up into the next question. Charles had responded about the biggest risks going into the ransomware area. Do you agree? Are there other things you'd like to comment on? And then especially thinking about those smaller entities, is the answer the same?
Gosh, yes, ransomware, right? Like I said, I just ran back to my desk because there's one going on right now, and it's safe to say there's one going on all of the time, just of varying degrees. And if you get hit by a ransomware attack, it doesn't matter what size you are. It is a very bad day for you and your patients, or your clients, or however you see that. Whether you're a provider or part of industry, right? There's it can hit anywhere. We see it every day. I feel like every day in this job, I see a new one. I'm like, oh my gosh, I never even thought of them. Last year we had, it's a big one, right? We had Change Healthcare. It was like the largest cyber attack we've seen in healthcare's history. But not everyone really knew what Change Healthcare was, right? We didn't understand the impacts. There's just so many places. There are so many opportunities for vulnerability throughout our healthcare system. There's so much technology and so many providers that it just opens us up to, being vulnerable in so many places. And that's why it's really on everyone to help address that. We've seen huge upticks in ransomware. I think there was a report out recently that, AI is now a concern because it's being used in, everywhere, including the bad guys have access to it. So, we want to make sure that we're, looking at all of the angles, not just ransomware. We see a lot of denial of service attacks. But I agree with Charles. Ransomware is by far the biggest one we see. And so we do want to take those steps to have people think about social engineering and how that might impact your organization, and phishing, and how some of those really basic things that you can have trainings on and talk about in small organizations. It's not just big organizations. You can do those fairly easily, and it makes a big difference. If you take a look at the ransomware attacks, it is often not that sophisticated how they get in. You can look at it like, talk about multi-factor authentication and talk about phishing. There are often ways where you're like, oh no, they could have done this basic thing and protected themselves. So I don't want anyone to feel like, oh, my organization is too small, I can't keep up. You can really do small things that have a big impact on your resilience.
Excellent, thank you. Since you did it, I'm going to move around a little bit in the questions. You added artificial intelligence to the mix today.
Sorry.
So one of the things we talk about often in the privacy and security work group is how you continue to see in the OCR corrective action plans. Did you do a risk analysis? Did you do a risk management? Do you do risk management on an ongoing basis? It just seems so natural to say, it doesn't matter to me what you add to your system or process. You need to analyze how it's impacting the data that you are protecting and moving through your systems, et cetera. But it's really hard to find that balance between leveraging innovation and ensuring cybersecurity measures are strong enough. So, Charlie, I'll go to you first. Thoughts about that?
Yeah, so it's really, I think you have a lot of kind of good points there baked in, because you want the innovation, right? We want to be able to use these tools. And throughout our healthcare system, you see where innovation really helps patients. It does a good thing. So you don't want to get afraid of advancements in technology, right? If you think about all the accessibility that something is, as what now seems so basic, telemedicine, right? It seems so basic now. And it gets access to people who wouldn't normally have it. If you think about rural areas, they can see specialists without having to drive 8 hours, and just it does so many good things. And then we have the flip side of that, right? Where not all of the people who are using these things are doing it for good. So we do want to make sure that we're implementing good risk management frameworks tailored specifically to AI vulnerabilities, right? Ensuring HIPAA compliance is crucial, no matter kind of what system you're using. But detailed risk assessments will help kind of safeguard that PHI, the public health information, or the protected health information, excuse me. And we'll be able to deal with those inherent risks and misconfigurations. So we want to take a look at all of that when we're thinking about AI. Again, back to those cybersecurity performance goals, those same principles apply when you're looking at artificial intelligence. We also have the health industry cybersecurity practices. Those also have some of those basic cybersecurity things you should do. If you're familiar with the 405D program, they came out of there. again, it works right along with AI too. So integrating AI into security information, event management systems, helping to prioritize genuine threats and reduce those false positives that we see is like the good side, right? You can use AI to really bolster your cybersecurity as long as you're making sure you're building in the protections that you need to with any system. So I think we see that throughout the systems that we're looking at.
Thank you. Just a quick plug for everybody. The current proposed latest privacy framework from NIST includes a little blurb in there as well about some questions on AI. Charles, would you like to tackle the AI question?
So just to kind of piggyback on what Charlie was, I don't have too much more to add, but the president did release a executive order related to AI back in January. And I just put the URL for that in the chat. And currently, CISA is working on implementing that executive order. So.
Awesome. Thank you very much. I'm going to divert for just a moment from our questions. My co-chair from Privacy Security, Tan Tien from Kaiser Permanente, has asked if we could ask for you to please answer if you have any information on the status of CIRCIA, CIA, the Incident Reporting Requirements Regulation. She mentioned there was an RFI last year with great response from the public and critical infrastructure industries. We understand it's the CIRCIA Act of 2022 requires formalized regs within 18 to 24 months of the RFI, we believe. Do you know where this stands? Perhaps is there any update or holding back based on our administrative changes?
I can talk a little bit about that one. So the last I spoke with the CIRCIA team, they were still like pulling together all of the feedback that they got from all of the partners that had a chance to look at that. And it's going to take however many more months. But as soon as all that is together, they should be releasing something.
Awesome. Thank you very much. Okay, so I'm going to go back and just reinforce an area, Charles, you kind of talked about a little bit before, but we're continuing, all of us, to promote this public-private effort and the communication. You talked earlier about how important it is for somebody to say, hey, I think something funny is going on here. Let's look at it together. You know, that is such a cultural change for us. I still work with so many organizations that I say, you need to report it if you see something, and someone will say, I'm not going to get in trouble. I don't want to be the one who says it. And we have to change that from every one of us through all the way to all of you overseeing us. Thoughts about ways we can improve communication efforts?
Well, I know at least from like CISA does a lot of collaboration with HHS and also with the Healthcare and Public Health Sector Coordinating Council. And they are a group of private sector entities that kind of serve as the voice for the private sector. And we collaborate a lot with them as far as like concerns or working on new deliverables and things like that. And they also contribute to some of the resources that we have available as well. Additionally, CISA has field personnel that work out, and like the country is split into like 10 different regions, and there are physical security advisors that kind of focus on the physical aspect. There's PSAs, and we have cybersecurity advisors or CSAs that kind of focus on the cyber aspect. And each of the 10 regions of the country has those personnel that are assigned to specifically work on that. And I have contact information for those as far, and also with the way that the regions are divided up, and I can send that out afterwards too. But they can certainly help with like questions. They can help during like incidents with outreach. They can help you kind of set things up. Like CISA also has like an exercises team that can help with tabletop exercises. They have like off the shelf tabletop exercises they can pull off. They can like coordinate with you if you have a specific thing that you want to try to do a TTX on. They can work with that. They can also pull in external agencies like, you know, HHS can get pulled in, or FBI, and, you know, you can kind of collaborate on like a tabletop exercise to kind of, you know, try to see how you can improve things.
Excellent, thank you. I know in working with some other organizations, we've seen full communities now participating together with all different sectors and different areas of the industry coordinating on these tabletop exercises. It's been really a wonderful benefit for all of us. Charlie, thoughts about communication?
Yeah, so you can, I'm going to drop it in the chat. You can always contact us here at HHS at HHS Cyber at hhs.gov. We're not very inventive on our naming structure there. And we will get you to the right place at HHS, regardless of what you're looking for. And Charles may have said it before I hopped on, but when you contact CISA or you contact HHS Cyber, it's like contacting all of us, right? We make sure that we are well connected to get you to the right resources you need, particularly if there's an incident happening and you're looking, for help in the immediate aftermath. We really do a great job of rallying together. It doesn't matter kind of who you contact. We do get some, I call it regulator fear. I'm not coming after you, right? You can contact me. We can have that conversation. We firewall off our OCR work from our response work here in ASPR. So I know I've had several folks say, well, I'm going to tell you this, but like, don't tell it. I'm never going to tell them. It's okay. We really are here on my team to make sure that patients are getting the care they need. We are not regulatory in the ASPR cyber world.
I think it'd be your website that says cybersecurity is patient safety. Is that one I've seen? Yeah. Sorry.
Yes, we use that a lot. No, we love that line. It's great. We also have several ways for people to kind of be more active with cybersecurity here at HHS. Charles mentioned the Healthcare Sector Coordinating Council. That working group has over 400 healthcare organizations as part of it, and I think it has something like 11 subgroups at this point, or task groups. It's an amazing industry group. I've not seen anything as robust in other sectors. It is something really the healthcare and public health sector has to be proud of. They've really organized themselves in an amazing way. And then we have the Government Coordinating Council to kind of go along with that, and a cyber working group for that, which is just the same thing, but the government people. We are not organized quite as well, but we do our best. And together we have the joint cyber working group. So we really do a lot of our work jointly and together, which really makes for amazing products. I know Charles mentioned some of that work. But if you have the opportunity to engage with that group, I highly recommend it. It's so well run, and they really are looking out for the best interests of the sector. Here at ASPR, we also put out weekly cyber bulletins that comes out of my office, making sure that folks know about the latest vulnerabilities, the latest news in healthcare cybersecurity. And so you can sign up for those on the ASPR webpage. If anyone needs the link, we can get that for you. And that's just a way, right, that we make sure we're communicating with the sector. And then we have our HHS Cybersecurity Gateway, which is a website where we're building it out. We're getting better. We're trying to make sure all of HHS cyber resources are kind of coming through that gateway. So you'll see that kind of evolve here over the next few months. But it really is the idea of we're making this one place for our external partners to come and easily get that information. The same idea with that email address. You don't have to be coming to ASPR to use that email address. You come to us and we will get you to the FDA or CMS or wherever you need to go within HHS. We're really trying to take the burden off of all of you of figuring out a bureaucratic structure and just getting you to the information you need quickly.
Awesome. Thank you very much. So we talked a little bit about what we think the biggest threats are. Now, thinking about our healthcare industry, and maybe even the smaller providers and smaller organizations, what do you see as being the biggest blind spots or mistakes that they make? Charles, let's go to you first.
Sure. So there's a handful of tips that I usually give out when it comes to, trying to stay safe online. And so the first one is, making sure that you avoid phishing attempts, right? So if you get an email, you didn't win a trip to Tahiti, please don't click on shady, things, because that one click may be enough to, have somebody in your system, and then now you have ransomware attack, and now you're in the news. And so, that's one thing. Another thing is, having strong passwords on your devices that require passwords. So password 1 is not a good idea. Leaving whatever the default password is not a good idea, because they're usually the same. So somebody can jump online and look, okay, for this router, what's the default password? Oh, it's admin123. Okay. And then they're in. So making sure that you have strong passwords. Another thing is multi-factor authentication. So that if somebody else is trying to get in there, it may say, we're going to send a message to your email or your phone or something like that. And if they don't have that second authentication, they can't get in. And the fourth thing to do would be to, update business software as you can. Whenever you have updates, I'm sure you probably heard like Patch Tuesday, but whenever your software that you're using, has an update available, go ahead and do that, because a lot of those updates are like security patches that are trying to fix things that happen. And, threat actors will intentionally target like older versions of software to see like, okay, well, if they don't have, the patch, we can definitely get in here. And so those are kind of the things that I think about when it comes to tips and avoiding blind spots.
Thank you. Charlie, you want to add to that?
Yeah, Charles did a great job covering those basic ones. I think a lot of organizations underestimate the kind of the threat from insider actions, whether they're accidental or malicious. We see that organizations don't necessarily think about, oh, my staff would never click that link, right? Not my staff. Or things like that. So it's really important to, keep an eye on that. One of the things that we're working on with that working group I just told you about is third-party risk. Really taking a look at what you're connected to, because you think about your system, but you also have to think about everything you're connected to. And you have to think about the vendors you're using, because they all touch your system and they can have these big impacts. So I think that's one of those blind spots that even I think we have to some extent, and we're working on that. We have some efforts, like I said, with that working group to really think through each piece of your system and say, well, am I solely reliant on this? What happens if this vendor or this product gets hit? Do I have an alternative? And I think you'll find that you don't always have an easy alternative based on how kind of the healthcare economy works. We get companies that have very large market shares in particular areas. And I think you could probably not think too hard to think of a few good examples of that where you're like, oh, everybody uses this one or that one. Well, what happens when you can't, right? Do you have a plan in place? And I think just knowing where those are is most of that battle, because then okay, I will think through where I go to replace that or how I work around without that. So I would think that that is also one of those blind spots that folks don't always have. I think they think about their own systems and don't always think about those third-party risks, what vendors they're connected to. And I think Charles talked about taking some of those proactive steps to mitigating the vulnerabilities with that, and patch management and multi-factor authentication and all of those things. So I won't revisit those, but yeah, I think those are the risks that I see where I'm like, oh, I don't know that everybody's thought about that.
Some of the things that we're also starting to see, and I get to see as an assessor, is I'm seeing organizations definitely step up that third-party communication and vetting, if you will. And then also that there are basically firewalling on both sides of the sending and the receiving on the partnerships. And we're starting to see organizations starting to build systems where they can more easily identify, isolate, and basically move forward the whole process to eradicate kind of smaller systems, if you will, or smaller components versus large platforms. We're seeing faster, smaller, more agile kinds of processes. That kind of takes us to the future of cybersecurity in healthcare. So you're on an elevator, you have less than 30 seconds. What is your advice for future healthcare leaders in cybersecurity navigating today's threats? Charles?
Sure. So, CISA plans to continue collaborating with, Department of Health and Human Services and also the private sector. But one way to look at it is like, cybersecurity is not a light switch. You can't just flip it on and it's all fixed. But what you can do is you can view cybersecurity as kind of like a hallway that has a bunch of dimmer switches on there. All of the preventative efforts that you're doing is essentially kind of like you walk by one and you edge one up, and if you edge them all up a little bit every day, eventually you'll get there. And so that's kind of the way that we kind of look at like our collaborative efforts between the public and private sector.
Great analogy. Charlie?
Yeah, I think that's a great one, Charles. To his point, our partnerships are really important. We all have to work together, not only because of we have third-party risks, we're all connected, but it is so big. You can't go in and flip the light switch like Charles said, and we can all help each other kind of turn the dimmers and get more secure. So I think that's really important. We will continue to work on those good cybersecurity resources. We want to work with industry and our partners to make sure that they're valuable for you, right? We don't want to be spending time on things that aren't valuable. So we really relish in the feedback that we get from all of you on what's helpful. What are you seeing out there? What do you need? What are your biggest concerns? That two-way conversation is really important for us to be able to hit those spots that are most concerning. And so we don't have to keep running downstairs because there was another cyber incident, right? We want to make sure that we're doing those things together to build resiliency. We don't want you to have to make 8 calls to find the resources. We want you to be able to get them all easily and handily, know where they are, know what is happening, know what to do if you have an incident. So, for future cyber leaders, I would just kind of say, get in the game, right? We want them to pay attention to cybersecurity. We want them to understand how important it is, what impacts it will have on their bottom line if they don't do it versus if they do it. We know that, if you get hit by a ransomware attack, it's expensive either way, whether you pay the ransom or you rebuild your system. It is a very expensive situation. So we want folks to kind of be thinking about it, take a proactive risk-based approach. But I think it really is about getting in the game. Once you're aware, you've made a big first step.
Charles, we talked a little about the CIRCIA, and you talked about the executive order for AI. Any other just general thoughts or things that you could share with respect to the change in our federal administration and how it impacts on cybersecurity?
So with respect to administrative changes, CISA has several different major steps that we're working on. First of those is kind of focusing on federal civilian network defense. Second is supporting small and medium businesses. Third is supporting critical infrastructure across the country. Fourth is delivering services to state and local governments. And the fifth is sharing threat information and mitigation guidance more directly. So that's kind of what we see as our vision moving forward.
And that hasn't really changed, or is that new or crystallized more so in the last few months?
It's more a continuation of what we've been doing.
Good to hear. Charlie?
Yeah, it's the same, right? Cybersecurity is has a fundamental mission. We're protecting patient data and healthcare operations, and that's going to remain important. We continue to adapt our programs and resources to align with the administration's cyber strategy and support the healthcare sector to meet all of the kind of evolving challenges and threat actor changes and all of the things that evolve throughout cybersecurity. But luckily, Charles and I are in a good position where cybersecurity is such an important issue to everyone that it's an easy sell. It's an easy sell to talk to you all, talk to the administration, talk to anyone about the importance of cybersecurity.
I'm going to throw another question out there. I think we have time for one more. So you had mentioned one of our largest breach so far last year. And every time we have these breaches and related issues, it erodes trust in the system, I think, for everybody, all the stakeholders, everybody who participates, certainly the patients. We have to constantly struggle with building trust back. I'm from Direct Trust. We're a not-for-profit organization that tries to promote meeting certain bars, certain standards for privacy, security, cybersecurity. You've heard, obviously, HITRUST and others. What are your thoughts about the use of independent third parties to help promote trust across the organizations as a way for organizations? You mentioned how third parties struggle. We struggle to be able to vet each other and trust. Thoughts? Charlie?
Sure. So I think, it's important to vet any organization you're working with. I think that, a lot of times, right, smaller providers can kind of group together to take advantage of shared services. And that's one of those areas where, right, if you can kind of coalesce, you can realize a lot of value out of that. by not necessarily having all of that expertise in-house, which is not practical, particularly for smaller entities, right? So I think that has to be a part of the conversation. Now, where you choose to get consultants or a third party or do those different things is really something you have to look at your own organization and what makes sense and where, what risks you're taking on or you're trading off. But I think those are important conversations and certainly have a place in the ecosystem, right? Where again, we're all kind of those Legos building this stronger system. And so everyone has a role in that.
They work together. Charles, anything to add there?
Sure. So to kind of piggyback on what Charlie was saying, while we can't, endorse one organization or over another, what we can do is, like what I mentioned before with the Center Coordinating Council. So they have a lot of collaborations, even just in the private sector. So it's easy for the private sector to kind of talk amongst themselves and kind of recommend hey, we've tried this works, or if you're looking at, X, Y, and Z, this is what's in your budget. We recommend that you go with these people. And so that is one resource that definitely recommend that private sector entities reach out and take advantage of.
So just really the networking opportunity for everybody as well. Great. Well, we have about 3 minutes. Would you like to say anything else to the audience? Charles, I'll go back to you first.
Sure. So mentioned that resources earlier. So we've got one cache of free resources is the Healthcare and Public Health Cybersecurity Toolkit, and you can find that at CISA.gov/healthcare. And what that is, it serves as a repository for resources that CISA has. We have resources from HHS on there and also from the Center Coordinating Council. And that includes things like CISA's cyber hygiene vulnerability scanning, HHS's landscape analysis document is on there. The Healthcare and Public Health Sector Risk and Vulnerability Assessment is on there. The 405D programs, health industry cybersecurity practices documents on there. And so it's just kind of like an easy place to find resources that are available.
Awesome. Thank you. And I know for those that are looking for resources for your small providers, the 405D also has policies and procedure samplets in some areas also. Anything else, Charlie, you want to point out?
Yeah, I'm glad you guys are using the 405D program. It's heartwarming. We spend a lot of time working on those resources, and with the sector, lots of volunteers from the private sector have helped us with those too. So glad that they're being used. Just like CISA has their main website, we have our HHS Cyber Gateway. Again, to get you to those resources, I listed the email address. There's so many resources at these websites that we cannot possibly list them all. So I really do encourage you to go and click around and click through them to see if there's something you can use. Don't reinvent the wheel. I think there's some good stuff in there that you can implement in your own organizations or have thought through kind of the challenges that you're thinking through now and may kind of prompt your thinking on that. So I think there's a lot of good stuff to be had. And if you don't see something, you're like, hey, we really need this, let us know, because we want to hear that too.
Beautiful. Thank you so much. Thank you both for your contributions today and your attendance with us at WEDI, and also the great work that both of your organizations do for us as an industry.
Thank you so much for having us. It's been great.
I think this goes back to Michael.
Yes, thank you, Leslie. And thank you, Charles. Thank you, Charlie. And as I mentioned in the chat, we hope to have you in July for our federal perspective on healthcare cybersecurity. That event is free. You can register now. We will have the FBI, hopefully ASPR, NIST, and HC3 is actually going to be there as well. So another fantastic cybersecurity related event. I'm sure Leslie and Tantien will be there as well, helping me moderate. Now let's move on to our next session here. There we go. Redefining critical authorization through interoperability and automation. This session presented by MCG Health's prior authorization automation interoperability expert and HL7 Da Vinci Project 2023 community champion, Daniel Kaywood. Danny, I hope they gave you a belt for that or something, a championship belt, explores how HL7 Da Vinci FHIR standards enhance connections between payers, providers, and EHR vendors, transforming clinical authorizations. It highlights how stakeholders are reducing processing times while improving efficiency and accuracy in clinical documentation. Key insights will cover real-world implementations of the DTR use case, enabling a stronger focus on patient care and improving health outcomes. From MCG, it's my pleasure to introduce Danny Kaywood.
Thank you, Michael. Good to see some familiar faces on this group again. I will go through as we go and talk a little bit about what Michael talked about. I have a few slides to run through, and then as always, feel free to drop your questions into the chat. I will be doing my best to moderate or monitor that as we go. And Michael is going to help me out towards the end, I think, for the ones that I miss. But I'll try to work in your questions as we go. So feel free to send them in. Let me go ahead and share my screen. All right, Michael, can you help me out and tell me if you can see that or not?
Picture perfect.
All right. All right. So, as Michael kind of said, we're going to go through a couple of different slides today. I'm going to talk a very brief overview of the HL7 Da Vinci FHIR standards for prior authorization. I think a lot of us on this call know a lot of those and can speak to a lot of those. So I won't spend too much time there. I'm going to spend more time on the second part and the third part here in terms of what is some of the value pieces that we've seen, as well as some real world implementation, talk through a couple of client case studies that we have and some deployment experiences. And then I have a call to action at the end for all of us here as well. So very quickly, I'm going to talk through the overview of what this sort of looks like from a health plan perspective. And this isn't just about the specifications. I think that's one of the themes that you're going to see from me as we go through these presentation is it's not just about setting up these APIs from CMS. It's also how do those things interact with what's already there. So for example, for the prior auth piece, the EHR is sort of what we're adding for many health plans and many providers as a part of all this prior auth API stuff, but there's also a portal that's still there. As much as we would like them not to, I have a very strong feeling that there will be some providers who continue to fax for a variety of valid business reasons that they might do so. We have some health plans that MCG works with that are still exclusively accepting authorizations over the phone. So I think there's a wide variety of ways to interact with the prior authorization process from a provider perspective. And so as we implement those FHIR specifications on the prior authorization API, with coverage requirements, discovery, documentation, templates, and rules, and prior authorization support, we have to, the group has to keep in mind sort of what's already there and making sure that as we open up this new channel, all of the other channels sort of work the right way, and that this one doesn't work some weird and different way, because that will lead to a very odd provider experience. So a little bit about MCG as well as our experience here. So I don't have my usual introduce MCG slides on this deck. I think they fell out in a copy edit. But for those of you who don't know MCG, you may know us by from the times when MCG used to stand for Milliman Care Guidelines. So we are an evidence-based medicine company. We are very fortunate to count over 3/4 of the health plans in the United States, as well as a little over half of the hospital systems in the United States as our customers. We write a lot of the evidence-based medicine criteria and the medical necessity criteria that gets used for prior authorization for providers and for health plans. And we work across the continuum of care from a care perspective, from inpatient procedures to recovery facilities to home care to also outpatient ambulatory procedures and behavioral health. So we have a lot of criteria. We're very fortunate to have a lot of customers, and we've been very involved in the implementation of some of these interoperability pieces and connecting payers and providers. And we've, as part of this, we've connected 3 payers and 4 different providers. Implementation time has been very varied, which will probably surprise none of you. It just depends on readiness for some of the systems that need to be, not just these APIs, but readiness for some of the systems that are going to sit behind them. And then we've done both, FHIR as well as X12 implementations of this. From our perspective, FHIR is the better path. However, not all systems are ready to be FHIR compliant. That has changed even in the last year. I think there's a lot more systems who are ready, and and I still don't even think it's over half at this point. And then the last piece here from a high level perspective is provider EHR support, and scaling and making sure that we can add providers quickly to this has been a challenge for us, and I'll talk a little bit about that as we go through. So as we think about the why, right? I think one of the things that we always think through is, why are we doing this in the first place, right? CMS in the rule, and a lot of presentations since that rule came out, and even before that, have been about burden reduction, right? Administrative burden reduction. There is a tremendous amount of burden here, and as we think through that, it's not let's throw the entire process that, from our perspective, it's not let's throw the entire process that we have today out the window and start over, because as we do that, all the problems that we've solved and reduced burden with over the last 10, 15, 20 years as an industry, we're going to have to resolve. And what we're not trying to do with this is introduce new burdens based off of the way that some of these implementation guides are asking us to work. There are some practical challenges that both payers and providers are having to overcome. And so when we think through this, right, one of the big things that we are trying to do is get patients. We talk a lot about payers, we talk a lot about providers, but ultimately at the end of this, there is a patient's answer as to whether they can get the service or the procedure or the drug or whatever it happens to be that their doctor ordered. And reducing the processing times from our perspective is a critical point here. So if we think about that very first step, coverage requirements discovery, and is an auth required in general, there's a lot of value that can be gained here. MCG has co-presented with several of our health plans in the past, even here at WEDI, and I think one of the things that we've shared in the past is implementing this the right way. So coverage requirements discovery is, from my perspective, one of the more challenging of these three use cases for health plans to implement, because it touches so many different legacy systems. But doing this the right way, basic automation, static rules, can get us 83% of these decisions that providers are trying to submit. 83% of those cases are no authorization required, right? So that very first bullet, you can give providers and patients a decision. It's not an automated approval to an authorization, but it's ultimately the same thing. No authorization is required. That patient can move forward with their treatment plan 83% of the time. Providers don't need to pursue the rest of those auths. They don't need to check the status of those auths. You don't eventually need to void them out, and in some states, send a letter as to why you voided them out. There's a tremendous amount of value just from basic automation. It's hard work. Basic automation makes it seem easy. That's more talking about just static rules. That's why we're saying it's basic. It's not something necessarily fancy. It's not a bunch of machine learning algorithms from our perspective. It's still hard work, even though we call it basic automation. But if you can do it the right way, there's a tremendous amount of value that can be unlocked just with doing that piece the right way. It's not the rules engines and basic automation, those types of things, and digging into some of the rules that are in your claims engine, some of the rules that are in your provider portal, some of the rules that are all over the place within your organizations. It's not the sexiest work to talk about necessarily, and it's not always fun. It's very hard. Sometimes it's very hard. However, there's so much value just there. And then I think the other thing that MCG is looking at with a couple of customers is using AI-driven insights from historical data to improve accuracy and efficiency. So an example of this would be looking at a provider is reaching out, asking for a specific type of, call it durable medical equipment, right? A provider says the patient needs this DME, and there's not really a clinical per se policy for when does that become medically necessary, but there might be more of a reimbursement driven policy that says we'll approve this durable medical equipment so long as you have received one of these procedures in the past 6 months. And so that's something where at the CRD level, we don't need to, from MCG's perspective, we might all not need to go through the full CRD DTR PAS workflow. If we can look into something like claims and say, yep, it looks like they got one of those procedures. There's the code there, there's a date there. We can just move that along right here from the is auth required. Yes, and it's approved. And I think those are some of the things that we are looking at. Like I said, so at the first bullet was about a lot of things just don't require an auth in the first place. The second piece is about for the ones that do, is there an opportunity to enhance like the front level decision support? And scenarios like I just said are one example. There's a couple of others that if anybody's interested, we can probably talk to you after this. And then the second piece here is advancing the authorization and documentation processes. So seamlessly sharing criteria, helping providers sort of understand, there's a lot of talk about should we share criteria, what type of criteria, what should that criteria look like? Ultimately, what we're trying to do is give providers who are requesting this a understanding of how the approval process is going to go from a medical necessity perspective for these cases. It's obviously MCG's perspective. We are a medical necessity company, but how is this approval process going to go? Providing the criteria that you're going to use gives your providers some sense of this is the type of data I'm going to need to submit. I might, as a provider, think I'm going to submit most of the stuff that is in the patient's encounter in my EHR as part of this, including my notes. I think that should be good, right? And sending that in and then getting back and saying, no, we need more information. If you give them the criteria and you say, we are looking for evidence of what they've tried to do in the past before receiving this procedure. So we might be looking, if it's a total knee replacement, we might be looking from an approval perspective to see, did they try some less invasive, less risky procedures like physical therapy or like activity modification or like weight loss, right? If you give that criteria and this is one of the criteria that we are going to be looking at when we make our decision, you signal to that provider, there's something else here besides maybe what's even in the patient's encounter in my EHR. There might be some other pieces that need to go with this. And it may be that those pieces are not with that provider and they actually need to reach out to somebody else, a nutritionist, a physical therapist, and get some more information from them. Bundled clinical documentation. So making sure that we can align some of those criterion for medical necessity with what's going in. Again, getting all the right data that comes with it. And then if we can, right, delivering faster, more informed approvals directly within the EHR. This is another example. So in the cases where we can't do what I was saying before, where when they say, is an auth required? Yes, one is, and here's the approval. For this piece, it's based off of maybe provider attestation to the criteria. There are some procedures that we, as a health plan, might be willing to move forward with. If we see evidence of certain things in the record using AI or some other technology, maybe those are ones that we're willing to move forward with. And so figuring out, again, this kind of gets to the why are we doing all of this, and really cutting down on processing times. It's not, you can't auto approve every single request. I personally don't think, and MCG doesn't think that there will be a time where every single request gets an automated decision. This is medicine. We're not necessarily, we're not balancing bank accounts or what have you. This is medicine and these are complicated decisions, but there are opportunities and there are probably quite a few opportunities to deliver automated decisions. I think that starts with better data, and that's what we're talking about from a interoperability perspective. So I do want to talk a little bit about some of the things that we've seen here with a couple of different health plans with this. So This is one of our health plans who's implemented sort of EHR to payer direct connectivity with with MCG and a couple of other vendors. And I want to point out a couple of things on this. So I'll start actually from the bottom and I'll go to the top. So the first one, that red line right there on the very bottom, that's the auto approvals. You'll notice it's not very high. It's actually not zero. I probably need to zoom this chart in a little bit. It's not zero, but it's not very high. This customer is sitting at about 5% auto approvals right now. This next orange line is actually the number of authorizations. So the actual authorizations, the actual procedures that would get billed from a claims perspective later is the orange line. The yellow line is transactions, and this is some of the back and forth between payer and provider. So for example, when I'm a provider and I click submit, there's an authorization there, but there's also a transaction. When the payer reaches back and acknowledges receipt, that's another transaction, but on the same authorization. Then if the payer says, I don't have all the clinical information I need, they reach back out, that's a transaction. When I give that clinical information back, that's a transaction. So one of the things that we've seen here over time with this particular customer, and this was, I think this is as of September of last year. What we've seen over time is the number of transactions per authorization is going down. So the orange is staying relatively steady. There was a drop off in authorization submitted, before January on this to the left of this chart, but that's staying relatively steady. What's going down is the amount of back and forth, that yellow line on the top between payers and providers. This is one of the pieces that, again, there's different ways to do this. So Rob Tennant from a questions perspective asked, are we able to access claims? I think, MCG, in some cases where we're given access, we are able to access claims. I think as we look towards some of these other interoperability APIs, there will be more opportunities to do that. But we can, those are some things that there's some vendors, including MCG, that have done some work around looking at that. So that's one way to decrease those transactions per auth. The other way is, again, providers sort of submitting what's needed up front is another critical way to sort of decrease these. And that's been, for this particular chart, the answer. With exactly how this has happened is those requests for additional clinical documentation have gone down for this particular customer over time, and they've continued to go down since September when we've done this. Here's another customer. This is a different customer, and this is sort of from the time they went live. What has been submitted via these EHR and interoperable connections versus what was being submitted other methods, portal, phone, fax before. And so what we'll see here is, as authorizations went up, so too, it's the same pieces. So red is auto approvals, orange is the number of authorizations, and yellow is the total number of transactions. So what we've seen is most of the providers who've adopted this are now submitting, 97, 98% of their authorizations through this system. They're not faxing them. They're not using the portal. They are doing it through the system. And we sort of see right away there was a high number of transactions per authorization, and those have gone down. The other thing that's helped this particular customer code have those transactions go down is they're not doing separate transactions for approvals. These are automated approvals. So they're saying, we got what we need. We're giving you an approval at the time that we're acknowledging receipt of the authorization within, call it 10 to 20 seconds. So that's another way to cut down on these. This customer over time has sort of built up their auto approvals. Another thing, again, kind of getting into the practical side of some of this, as well, kind of coming back to that, and I'll keep coming back to that as we go. Another thing you're seeing with some of these auto approvals is there was a staffing shortage, that the staffing is not consistent, right? From a health plan perspective, you don't always have the same exact number of nurses at any given time to review some of these cases. So what you're seeing is there was a staffing shortage here for this particular customer in late June, early July. And so what they did is, in order to hit their turnaround time requirements, they used some of the tools that they have from MCG and other vendors to increase the number of auto approvals without really changing their process. They just said there's now more services subject to auto approval, and we have to do it in order to meet our turnaround times, and it's a better experience for providers. And so again, that kind of goes into the practical part of all of this. You know, if you have a CTO who's asking you, why would we invest in interoperability? What's the point beyond compliance? It's giving your organization some flexibility. It's giving your organization some flexibility to impact some of your operational metrics at times when you might need to, like at times of staffing shortages. This is an opportunity. This is a lever that you can pull in order to get where you want to go. So at the beginning, Michael kind of talked about, we'll go through some learnings. I did want to touch on value and sort of why we're doing this, but let's talk about some of the learnings with some of these use cases. So I'm going to start, and I'm just going to go in order. So I'm going to start with coverage requirements discovery. And I'll talk through one of our learnings that we've had as we've gone down this. And I said I'd mention it a little bit later. On the health plan side, legacy business systems with locked data. So health plans, when you're trying to think through, is an authorization required? There's a lot of questions that sit underneath that. There's a lot of checks that happen in a prior auth submission before you actually figure out whether you need one. And the first one is this our member? Eligibility can kind of help you solve that particular problem. Is this our member at all? Is the provider reaching out to the right payer asking for an authorization? Is this provider gold carded, or are they on, are they in network? Are they out of network? But all of those impact whether an authorization may or may not be required. Again, gold carding is an example of a place where you could, from this coverage requirements discovery perspective, auto approve those authorizations. Yes, an auth is required, and it's approved because you're gold carded. So that is something to look at. Benefits, is the service that's being ordered a covered benefit? Most health plans are quite against the idea of approving authorizations as medically necessary for things that are not a covered benefit. Many of those systems, many of the data that you're looking at here, provider data management systems, benefits often comes from claims, eligibility. Many organizations have 270, 271 services, but some of these systems are very hard to access and interact with via real-time APIs. You know, I think a lot of you know Raj. Raj and I work together. We talk to a lot of customers, and we hear a lot about, this is a batch process, right? These are all resolved as part of a batch process. That makes some of this real time, the presence of that, just having that there makes the presence of some of this real time API interaction between payer and provider extremely difficult. There are service level agreements that are called out in some of these implementation guides. I don't see one of our friends who frequently talks about, is it realistic that CRD resolves in the time that is in the implementation guide? But that is a valid concern. Like, there are a lot of systems that need to be touched on the health plan side in order to make this an accurate answer. And again, doing this the right way, there's so much value in here doing it the right way. But we are working with health plans who are completely redoing some of their back-end business systems as a part of the investment around doing this interoperability piece for the CMS 0057. The other thing that we've run into is organizational silos around other initiatives. So there's been several health plans that we've talked to that have an ongoing work stream for prior auth transformation, quote unquote, or utilization management transformation, or what have you. And the interoperability piece for CRD, DTR, and PAS is being pursued by the Office of the CTO or the Compliance Officer Office. Those things should be together, right? That's another challenge that we've seen just overall as we've looked at, and this isn't really specific to CRD, but it's probably most pertinent in CRD as an organization might be completely redoing their benefit structure as part of a totally different work stream. That's impactful for this. These things need to be brought together. And it's often left to a very small group of enterprise architects within a health plan organization to try to pull all of these different things together. We don't envy you. It's not easy work to do so, but I think this is another challenge that we've seen with CRD. Dan, you asked time to decision for the two organizations. Yes. So we track time to decision. So Dan was asking about these two customers that we had charts up for, and asking, did we track time to decision for peer transactions? We did track time to decisions. I think we tracked it more on a global level. So the average time to decision. And what we've seen with both of these is that for the authorizations that are getting submitted via this workflow, the time to decision is much lower than those that are getting submitted via other workflows. So hopefully that helps, Dan. I think we've also seen, the more authorizations you can push electronically, it helps your entire authorization volume, whether it's electronic or not, move down in its average time to decision, because these are available to make decisions on so much faster frequently, with so much less error than things that are faxed or phoned in. So if you can make more of these electronic in general, what we see is a decrease in your overall time to decision for all authorizations, not just the electronic ones, because these are so much more available to make decisions on in real time. Hopefully that helps, Dan. It does. So Mary Lee, does the auth decision tracking include no auth required in Gold Card? Absolutely. And very frequently it's because of some of the things that I said, because that's another way to decrease your overall time per case across your cases, is not looking at some of them. That's where some of those auto approvals pieces come in as well. But saying that certain ones we're going to go ahead and automate based off of a variety of different things. Gold carding, no auth required is a very easy one, but you're also not having to generate. So there's many states that even if the provider submits the case, it's a no auth required, you have to void it and you have to send a letter as to why you did so. And so Mary Lee, I think that's why we do include some of those things, because there are real tasks that you can avoid by doing some of those pieces. Good questions. Keep them coming. So I talked about CRD. Let me talk, Michael kind of said, we're going to focus on DTR, and we are. So I have a few slides for DTR. One of the things that has been a challenge, and I'm talking a lot about challenges. There are a lot of successes, but I think a lot of folks, I think this audience is very well attuned to the successes and some of the successes that are possible. I am talking through some of the challenges because I think it's more valuable for this group. But each payer has unique questionnaire formats, unique criteria. CQL, because the criteria is different, CQL is extremely challenging across different health plans. So some of this has been hard to scale, and finding a rinse and repeat approach, which MCG can certainly help you with as a criteria vendor. DTR is sort of our bread and butter. This is something that we could help you with. There are other criteria vendors out there that can help you with it as well. But go to your criteria vendors to talk through, how do we actually do this at some degree of scale? Another issue that we've had is limited EHR data accessibility. So Charlie, on the last, when I'm talking about cybersecurity, there are good reasons for this. It's not all the data is always available to these interoperability APIs at the time when it needs to be done. There are good reasons for that. It also makes, there's good reasons for it. It also makes this implementation challenging. Like, both things can be true. And so there's something there that we as an industry have to look at as well. And not all of this is just based off of, the data is being locked off from these. Some of the time the data is not there. I talk frequently about the physician workflow of signing an order, that order starting to go through based off of some of these IGs, that should start already automatically processing in the background. But they might not have signed their notes yet. They might not do that until 7 o'clock that night. And so there is just a natural gap in some of these pieces. Again, the practicality of this, as opposed to sort of the implementation guides of how the world should work, there's a practicality element here that we have to always keep in mind as we're doing this. And then delegation is another piece here. So who is going to do the review? So any providers out there will probably can think of some scenarios where you got halfway through an authorization on some health plans portal, and when you click next, you got a pop-up that said, we actually delegate all musculoskeletal surgeries to Evacor or Carelon or Magellan or whoever. That is a frustration for providers. That is a challenge as we implement some of these interop APIs as well. What are we going to do with those? So those are things to keep in mind as we go. Codification of medical criteria. So a lot of medical policy sits in PDFs right now. We need to digitize that and put it into the form of a decision tree. And I'll show you a visual of what that looks like right now. Clinical decision rules engine, you can base it off of that decision tree. And let me actually pull that up, and I'll jump back here and say, this is one of MCG's guidelines, but taking this from on the left-hand side, this is just a bulleted format. This is HTML. Many of these are PDFs, and actually turning it into a decision tree format, which we have here on the right-hand side, where it's actually interactive. It becomes more of a questionnaire, if you will, that you can start responding to. And that is the point of doing that. There it is so that once you start documenting against it, you're starting to generate rules. You're starting to say, yes, because the patient had complicated pleural effusions, overall, this admission for this particular service might be medically necessary. Now, you don't have to make decisions based off of this, but in some cases you can. It's putting tools, the way we talk about it is it's putting tools in your toolbox. From a health plan perspective for automation. It's not necessarily saying that you have to automate everything. This is bringing another tool to the table. So this is what we're talking about when we talk about digitizing things. And then when you actually want to look through, the supporting clinical documentation from the EHR and this criteria and compare them to each other, there's some different tools to do so. From our perspective, this is where large language models come in. This is MCG's approach to actually reasoning. We call it clinical reasoning, and actually trying to assist in doing the review itself. CQL is certainly a tool here, certainly called out in many different places in the DTR implementation guide. It's, as I mentioned on the last slide, it is hard to scale. It is meaningfully hard to scale. Looking at just this one criteria that I had up here, there are 20 different questions. Several of them are so any engineers out there, can you write me a CQL statement of presence of risk factor for poor outcome? We have some examples there. So there are some problems that you can write, but we all know problems lists are a little bit challenging as well. So this CQL is challenging to work through, and then a lot of the answers that it's looking for are still locked in non-structured data anyways. They're still locked in physician's notes. And so this is where MCG is, like I said, we have focused on large language models and AI to sort of help with the actual doing of the review itself. We focused on CQL more as a tool to bring data over into the health plan's environment and then do some of the reasoning pieces there. Again, ultimately for this one, the point is, the why is, can we reduce the amount of time clinicians are spending doing these reviews? Maybe not eliminating them from the loop right now. That's not really our approach, but assisting them, taking a review from 15 minutes to 4 minutes on average is a incredible value add for health plan organizations. The last one, and now I'm running out of time, but the last one here, I'm still monitoring for questions. If anybody has them, feel free to throw them in there. PAS, there's unique IDs for various objects between payers and providers don't usually match. This is a software engineering problem by and large. But it is something to keep in mind, and like dates and date ranges, and testing. These pieces make PAS testing difficult. And then one of the other challenges that we've run into is many of the EHRs we've worked with haven't made writing the actual decision for the auth back into the platform available via any other mechanism than 278. And so this negatively impacts the provider value for adoption of this if they still have to, say, launch a Smart on FHIR app to get the decision and enter it themselves. All of this is about burn reduction, right? And so some of those things, some of those permissions and some of that, I know that a lot of the EHRs are working on it, and I'm not here to say, what are they doing? It's more so this is an incremental progress. This is not everything everywhere all at once, if you will. There's a lot of incremental progress, and so figuring out what else might be in it for providers until something like this might be available. The last piece I want to talk to you about before call to action, takeaways from our perspective. Trust is at a premium. So they said it actually in the last panel about cybersecurity as well. Trust is at a premium. Payer and provider trust is still pretty low. There is still meaningful concerns on both sides about sharing a lot of data back and forth. Clinician trust in technology is still low, especially when we talk about something like generative AI and large language models and ChatGPT and Gemini. It is low, and there are reasons for that. We see a lot of press about generating negative, false misinformation, and how fast AI can do that. For something like prior authorization, that scares people, and it should. And then trust and automation as a concept is still low. And so I think from our perspective, testing, transparently showing your results and testing again and showing improvement is the other piece that's not here, is one of the critical points from our perspective. Show your results even if they're not good. The industry begs of you as you're testing these, as you're implementing this stuff, even if it's not good, show your results. Tell us what you've learned. Tell us what you're doing about it. And then once you've implemented it, test again and show us improvement. This is how you build trust between payers and providers. This is how you build clinician trust in technology and overall organizational trust in automation. This is how you do it. MCG has done this multiple times with multiple different types of tools, not just interoperability, not just AI, but even rules engines, saying, here's a group of authorization decisions that we know the answer to. We know the answer to. These have been made by humans, and we've gone back and audited them, and we think that these are the gold standard. Let's run them through our authorizations or our automation system and see how many of them have the same answer that we came up with. And if those numbers are not good, that's okay, as long as you've done a good enough job from a process engineering perspective to figure out exactly why, and so you can go back and fix it and do it again, and just continue to show that you're moving in the right direction, obviously, for those of you who are data scientists, without overfitting anything in your models. So the last piece, I've talked about this at WEDI in the past, the last piece for everyone here is a call to action. Keep in mind all the people who are not here. Keep in mind all the people who are not involved with work groups like WEDI, who are not involved with work groups like CAQH Core, who are not involved with work groups like HL7 Da Vinci burden reduction. Let's not drown all of those people in jargon. Help bring people along who are not here. Help bring people along who are not involved in some of these different industry initiatives and work groups. And don't make them feel like this. Don't make them feel like someone who is drowning in a sea of jargon. Help people come up with, ultimately, CRD, call it coverage requirements discovery, talk about capability statements and CDS hooks and all this stuff. This is a prior auth check for 95% of people who work in healthcare. It's just a prior auth check, right? There's a lot of different ways how we're doing it, but ultimately the concept is prior auth check. DTR. This is just policy guidance for providers. We've integrated it to portals for years. We have transparency solutions that many states and CMS ask us for. This is policy guidance for providers at the time in their workflow when they need it. Prior authorization support is create the case and what's the status of my auth. So help people come up with the conceptual maps in their heads for what some of these things mean, and start thinking about thinking about your audience when you're talking about what we're trying to do here from an interoperability perspective, do we need to use these words, or should we find others to speak to the audiences that we're speaking to who don't do this day in and day out, like many of us who are here? With that, I am very close to the end of my time. I think I've got maybe 4 minutes left, Michael. Any other questions? I don't see any in the chat. If not, I can probably give folks a few minutes back, but if so, feel free to throw them in there now.
Yep. Any other questions?
All right.
All right. That's awesome. Thank you so much. That was a great presentation, Danny. I really enjoyed it personally. I learned a lot. And with that, we are going to transition to our next session if Mike Patwell is with us.
I am.
All right.
Thank
I'll
you,
hand
Mary
it
Lee.
over to you.
All
Thank
right,
you.
Terrific. Well, welcome again. I'm not going to introduce myself since I did that earlier, so we'll skip that here and introduce everyone to Shane McMillan. I've been working with Shane for just over 9 years now. I gotta keep counting. And I can guarantee this will be an entertaining closer session for today. So just a little bit about Shane. He is our payer and public sector practice lead here at EdFX, now Cotiviti. Having served in various roles throughout his career, Shane has been very instrumental in driving initiatives that enhance data exchange and streamlining the healthcare processes. He focuses on leveraging technology to address these complex challenges faced by our clients, our commercial plans, our state Medicaid agencies. But Shane's expertise and his leadership has been very pivotal. I've watched him again almost a decade, and he helps our clients navigate and evolve with the landscape with regulatory and technology. So the topic for today's session is a modular approach for incremental and holistic value. Shane, are you out there?
I'm blushing out here. Thank you, Mr. Patwell.
You're amazing, Shane. You're amazing.
Oh, geez. Yes, thanks so much. I am out here. Yes, I assume you can hear me loud and clear?
Yes, sir.
Okay. Very good. So let me go ahead and share my screen. And I'm glad we're starting a couple minutes early just in case there's any issues with doing so. Give me a second here. I see the video. Let's see. Whiteboard. Ah, here it is. Okay. Yes, I can see it. All right. Let's see. And for the sake of ease of navigation, I'll go ahead and share my entirety of the screen. Just give me a second.
Okay.
Okay. And it should be coming up right now.
We see it now, Shane.
Very good. And again, thank you for the warm welcome. So yeah, Mr. Patwell and the rest of the team, I really appreciate your time. I'm assuming there's some folks that probably has talked briefly about this, but and myself and Mike are originally part of EdFX. So I've been with EdFX for the past 11 years, and now part of Cotiviti. So very excited to be part of the broader team. In case the folks in the on the call and in the room here aren't aware of that. Okay, so let's kind of talk about today. And I really appreciate that it's the end of the day for a lot of folks. And this will be, I would say, a pretty fast-paced kind of view into the world of what we're going to be taking a look at today, which is the goal of this session is to focus on how EdFX is solving for 57F. And in so doing, we'll also, just by nature of talking about it, we'll also kind of talk about the broader interoperability landscape and what we're seeing, and I'll share some sort of anecdotes along the way. What I'll do as part of this, yes, I have a collection of slides that we'll walk through, but I'm also kind of taking I don't know, maybe I haven't learned the brave approach of actually showing some live demonstration. Nothing too crazy, but just to help, isolate and back up some of the points that we'll be talking about. Okay, so with that, let's kind of lay the land here and sort of think about why we are talking about this in the first place. And I promise this is not hey, let me educate you on what the legalese and the regulation is. Everybody in the room, I'm sure, knows about this, but it's kind of important to set the stage. But anyway, essentially, a key reason why we're here is it started with the build phase of interoperability, with the hope that patients have better stewardship and better access of their member data. So building out the technological infrastructure, the standards to provide access to the variety of different APIs that fell underneath 9115. And then fast forward to what, 2024-ish timeframe, along with going forward through the end of 2026, is really focusing on or operationalizing that infrastructure that essentially was built out in the first quote unquote phase, the build phase, with the focus of reducing provider burden, right? We kind of, that's kind of the key focus, but also reducing burdensome processes like the prioritization, the kind of the manual nature of the prioritization, through a variety of different APIs, either updates to existing APIs that were introduced in the 9115 days, or the introduction of novel APIs to help promote better exchange of information. And then now is the sort of the future. It's kind of crazy that we're already thinking about this, because it's not a matter of, if change will happen, and especially in terms of regulations, but it's a matter of when. So much so, CMS released an RFI, a few weeks ago. And let me just kind of read you an excerpt from that. I'm paraphrasing, but they're kind of talking about the goal of the focus of the RFI. So continue to build on the existing policy framework to drive large-scale adoption of health management and care navigation applications. So just with that single kind of mantra, you can really identify that they're double downing on the quadruple aim. Better patient access, outcomes, access to care, so on and so forth. So essentially, the key point there is regulation is not going to change. Mandates are not going to change. They will continue to evolve. So that's one aspect of the quote unquote future. The other aspect of it is kind of what we are hearing, working with our payer and our partners in the ecosystem. So my role has predominantly been working with what we refer to as our public side of the business. So working with federal agencies like CMS on other focus areas, the VA, or areas within the state Medicaid world, and also seeing working with the commercial side as well. So there's some interesting use cases that have come up. So thinking about how can we utilize this framework that we've implemented to address novel things that we're seeing. So one of the things that we are implementing and have implemented for a couple of different payers is clinical data acquisition. So in this specific scenario, there are a collection of HIEs that interact and have member data. So the payer wanted to be able to pull that information in, acquire that clinical data using standards, and then create a golden record to support care management use cases, better care management within the payer. So being able to collect that clinical data. So that's one scenario. Other scenarios evolve around risk adjustment and VBC. So identifying gaps in care or sharing those gaps where they're being coding gaps or gaps in care back with the payer or even the provider. So things around risk adjustment and value-based contracts. And also just looking at what customers are doing. They're being creative. They're creating their own FHIR-based interactions to support their use cases and their business. We're working with one federal agency that their backend system is FHIR enabled, but their provider ecosystem can only support X12, like 278. So they need a way to make that bridge happen between the quote unquote legacy world and more of the the FHIR-based interaction world. So those are the things that we are seeing. That's a backdrop essentially that sort of invites us to understand how are we solving for this? How are we solving for 57F and beyond? And I'll say the kind of the key goal of that, of what we're solving for, our solution is focused on, is really twofold. One is to provide complete coverage for the mandates. So that includes, the 9115, 57F and beyond, so the future, but also extensible to support these either custom use cases or future use cases that come down the pike. And we support that through, I would say, three core pillars of our solution. Now, there's surrounding capabilities and infrastructure around these three different pillars, but if we want to break it down into these three areas, this is what it's comprised of. So basically the FHIR gateway, a FHIR repository, and consent management. So what FHIR gateway provides, it serves as the central access point for exchanging the healthcare data using standards, right? Using standards such as FHIR and the variety of the implementation guides from, let's say, Da Vinci or ONC or a collection thereof to support these use cases that I'm talking about, like automating prior authorization. But also, I think a very key aspect of this is the being able to adapt to the evolving standards like TEFCA, FAST, and USCDI. Many times, I think this is pretty noteworthy. Many times we're working with organizations is that the speed at which change happens is very, I would say, causes a lot of friction for backend systems, whether they be utilization management systems, care management applications, what have you, eligibility systems. So being able to isolate those changes and adapt to those changes in a centralized way is a core goal to be able to future-proof as those changes come to bear. And that's a focus of what the FHIR gateway is providing. And then the FHIR repository, exactly what it sounds like, being able to aggregate member/healthcare data in a centralized data store via collectors, and then be able to access or interact with that data based upon standard APIs. And then finally, rounding out that three-legged stool, so to speak, thinking about the nature of what's happening. The nature of what's happening is we're making this member data very fluid or liquid. Use the term that you're comfortable with, but allowing that data to be accessible through the ecosystem. Well, what does that sort of entail? That entails that members and or payers, the stewards of the data, need a centralized way to administer who has access to that data, the so-called consent. And being able to configure those policies and the consent rules associated with those consents, and then be able to enforce those consents at runtime when that data is being accessed. So the FHIR gateway, FHIR repository, and consent management round out sort of the ecosystem of our solution. So let's kind of dovetail into more detail about what's inside of each one of these areas. So let's kind of start with the FHIR gateway. Essentially, what the focus of the FHIR gateway is, what's it's seated with, and you'll notice that what we're sort of focusing on here is definitely more of a FHIR-based implementation and looking at how we address the very specific elements within 9115 and 57F, as well as the supporting capabilities that provide the infrastructure and the runtime and the visibility into the execution of the APIs within the ecosystem. But it's meant to be an understanding that the FHIR Gateway houses its information, but also provides the ability to connect to a variety of different, let's say, backend systems and make that interaction happen. Sort of tangential to that, one of the things that we are seeing that is part of the FHIR Gateway environment is the need to provide better visibility of what's happening. So the idea to be able to provide CMS reporting and capturing the appropriate metrics, provide things like life cycle tracking and audit events, but also being able to provide self-service tools through cloud portals, whether it's, let's say a provider facing applications such as, helping out with the prior auth process in case there's not a native, smart on FHIR application, being able to allow payers to self-service, onboarding providers, things of that nature. So we're coupling the FHIR Gateway environment with a so-called healthcare cloud to make both the monitoring of that, but also the operation of that environment as frictionless and seamless as possible. Okay, so let's kind of take a look at what that might look like from an operational standpoint. So let me share you with a quick demonstration. And pardon me while I navigate to the, there we go, to the appropriate screen here. So we have a executive dashboard that allows you to monitor these APIs that you saw on the previous screen. So I think one of the kind of key points from the previous session was very spot on, is that, people don't really understand, the whole idea of the inner workings of the API. What they care about are things like, from an IT operations standpoint of, like, let's say, I just want to know, are things working? And if they're not working, if data's not flowing, where do I need to focus my attention? So in this particular executive dashboard that we have, we can quickly highlight things like, red light and green light. So in this case, I can click on this sort of critical area and get my IT operations staff as close to the root cause as possible, as well as being able to identify, let's say there's either volume issues or then maybe there's certain errors and conditions that we need to be aware of from an IT perspective. Similarly, there's other personas that this is meant to support. So think about, like, from a plan perspective, there might be a senior business analyst who is responsible for making sure that that the environment is aligning with the CMS regulation, namely the reporting, as well as maybe there's somebody from the utilization management team who is also responsible for improving the process of prior auths. So a couple of examples that we highlight here is what we capture around, in the case of the patient access API. We capture unique members accessing the API, or unique members accessing it more than one time, and breaking that down based upon line of business. We also can highlight things like, where are data quality issues rearing their ugly head, and so how do I identify that? Where can I identify things like maybe trading partners are submitting who's submitting the most denials, broken down based upon practice. And by looking at these metrics, I can quickly, highlight and identify the things that are falling through the cracks, and then be able to take corrective action. So again, the idea is that collectively we are, operating the APIs, but we're also providing visibility to improve upon the execution from an IT perspective, but also from a business standpoint as well. Okay, so moving along here. So let's kind of talk about, what's inside of one of these APIs, the anatomy of the API. So thinking about, the ecosystem of interacting with the let's say in this case, I'm clicking on the one of prior auth. So the collection of prior auth APIs. So we have external FHIR clients, on the left-hand side, and we have customer business systems and partners on the right-hand side. Within the middle is the so-called FHIR gateway that we've been talking about. And around the edges, what we have that's part of our core infrastructure is the ability to manage the access. So we have an API management layer and the ability to meter and monitoring and provide secure access to the APIs, as well as the visibility services that I just showcased before. And in the middle are two core capabilities. One is the sort of the out-of-the-box pre-built orchestration and runtime infrastructure that implements the APIs. So in this case, the so-called the CRD, and DTR, and PAS. Yes, I'm using the jargon, even though we were told not to in the previous session. So the prior auth APIs, and then the harness that surrounds that, as well as the ability to provide customer specific configuration without breaking the seal of the actual out-of-the-box capabilities. And then also the ability to encompass business integration service. So why do we have this? So we have this capability precisely for the reason that I mentioned before, is that these backend systems are all different. If you've seen one core application portfolio, you've seen one core application portfolio, especially as it surrounds the prior auth process. Oftentimes there's no, a digital heartbeat or an API that's based upon standards. So being able to isolate how we integrate or make that handshake happen between the front door and the back door is where we do that within the integration service. So this becomes implementation specific. And essentially what this allows us to do is two things. One, lower the maintenance, the ongoing maintenance going forward as things change within the backend environment. But also as industry standards evolve, like, for instance, USCDI or formats, or just new versions of the implementation guides, that can be isolated here, updated here without breaking the handshake between this service and the backend systems. Okay, so let's kind of take that, sort of thinking and then see what that would look like in a sort of a real world action. So for this, let me look at a real scenario, and let's pretend that, I'm a provider and I'm working with an EMR application. It could, pick your EMR application. And Laura comes into my office, and Laura has maybe some clinical, healthcare data that I have access to through the provider access. I click on that. I gain access to that API through the payer or the payer's provider access API. So I can see all that information based upon Laura. And based upon that, kind of that clinical encounter with Laura, I've designated that, this patient, Laura, might need, has some particular service requirements. So in this, we have the ability to issue a new order. And for the new order, we can, for this purpose, we'll specifying the code system as well as the code, but it could be, based upon the EMR's application. And do basically to check that thumbs up, thumbs down, is a prior auth required? And so essentially what we did there, we sent that information to the backend system, and it came back with, oh, you know what? It does not require a prior auth. Go ahead, obviously take the necessary action to do what you need to do to facilitate proper care for Laura. Okay, so that's good. That's all nice. Nice nice within the sort of the workflow. It speeds up the process. But now let's look at a scenario where maybe a prior auth is required. So for this, let's choose a different type of service. It's a 3D echo. And let's go and do that same sort of that order select, order submission, and then check to see if a prior auth is required. And it is, in fact, it is required. We see that. And then we also have the ability to, if we want to, assign the order. So for our purposes, let's go ahead and sign the order. And by signing the order, we also gain access to those additional kind of, back-end business systems, such as in this case, the medical policy system, providing that link that was the response from that interaction. So we can see, maybe there's some supporting information based upon the type of service that I want to perform for Laura. And based upon that, there could potentially, based upon that particular service, there might be some additional information that is required to submit along with this prior auth. So for the purpose of this, I just clicked on the autofill, and the autofill emulates the idea that this can be pulled directly from the EHR. That being the idea, or it can be automated. It depends upon the EHR as well as what is returned back from the backend system. And then we submit the prior auth. So we've done the submission of prior auth. We can refresh it, and then we can see that it's pended. Wait a couple of seconds, wait for the folks to do their work. They've done their work, and it's approved. And then we can finally, view the results of that prior auth. So yes, it's been submitted, it's been accepted, so we've inquired about it. We can also look at the details as part of that submitted package, including the order, who did it, and then of course the supporting data that was submitted along. But thinking about that, we can go through a lot of other scenarios where requests for additional information is required or denials, but the pattern still holds. You're still interacting, via the workflow versus obviously, more of a manual approach and fax-based approach or whatever, or even portals for that matter, or having to pick up the phone and validate. But that's essentially, the underpinnings of how the FHIR gateway along with the prior auth API is being leveraged within the context of an EHR workflow. Okay, so continuing on with my fast and furious conversation here, what I want to end with is consent. So kind of the three-legged stool. We talked about FHIR gateway, the data. Now let's talk about consent. The typical sort of the idea around consent is that this consent, when you look at a member, it's handled and managed across the board in a more of a disjointed manner. So access to PHI is done duplicative. It is done in a very non-standard way, depending upon where a member is engaging. So it's an issue. And then compounding that complexity are the ongoing laws that are associated with making sure that plans or whoever the steward of that data is not sharing that data where it should not be shared. There are state laws such as within California, family planning based or gender affirming care, or even Part 2 federal laws that should be taken consideration. And then evolving laws, thinking about 9115, the patient access API, and then application level consent, but also more granular level consent, specifically around provider, access API, and giving the members the ability to opt out of sharing the data with providers. So thinking about that, how do we accommodate for that? Well, enter stage left. Sort of the kind of the current state, and where we fit in this ecosystem is we provide a two-pronged approach for providing this enterprise level consent. It's not just simply checking the box for opt-in or opt-out, but it's focusing on two aspects. One is the ability to administer the consent in such a way where we are centralizing the capture, like if a member needs to capture certain consent policies and enforce consent for a given, let's say, guardian relationship or provider relationship, they can do so through self-service capabilities or through a existing member portal. And then the other aspect of this is enforcing the consent at runtime. So based upon those rules and based upon that consent, I, as the facilitator of the data, let's say the FHIR data coming into here, sending that information to the consent environment, and then only sending back to the calling environment what has been consented to. So as an example could be like, let's say Laura goes into her ENT, and let's say that she has behavioral health conditions that she does not want to share with her ENT, but that provider has access to her data. With consent management, you have the ability to capture what Laura wants to consent to and then enforce that at runtime, and being able to only allow and share information that she grants and that she warrants for her given care. And by the way, that can be based upon existing FHIR resources, or it can be other infrastructure that's non-FHIR. There's a whole demonstration associated with that, but I'm looking at the clock here, and we're approaching time. But at any time you want to sort of kind of think about that or get access to that, just let me know. We can do more of a deep dive. And the last thing I'll leave you with is it's definitely doesn't fall on deaf ears. This is something that's very critical, is kind of revisiting the same screen or the same chart we saw before. There's a whole host of interactions that's happening. So kind of thinking about the payer environment and all these different, awesome data exchanges, the promise of these. Well, how do we empower the ecosystem? How do we empower the providers, the payers, and obviously the members to gain access to that data and to discover these APIs and be onboarded effectively? And that's where our vision is to provide an exchange hub, utilizing standards like TEFCA and FAST, and incorporating ways to allow providers and payers to do more self-servicing, or they're not burdening the provider, thereby reducing friction and just creating the most seamless, interoperable environment as possible. But yeah, that's what I want to leave you with. I know we're coming up on time, but really appreciate the attention, and thank you for letting me ramble on. But Mike or whomever, I'll turn it back over to the team.
Thank you, Shane. So there's no questions in chat, but I do have one for you, if you don't mind, just to eat up this last few minutes. And thank you, everybody, to the WEDI membership has joined us today. But when you were talking about, the member consent, what happens when a member opts out? Is there a different workflow, or do you need to, address a member opt-out in some fashion?
Yeah, that's a question we get a lot. So thinking about, what happens, let's take the example of a patient access API, and I'll keep this brief because it's a very, very key question, is that with the patient access API, and I'll be a bit technical here, there's FHIR data that's returned. Within the FHIR data, there's resources that are part of that. And within the resources, there's certain types of code sets like LOINC or ICD-10 that are associated with sensitive data like behavioral health. So when a member opts out, they're basically specifying, hey, before you return this FHIR bundle, this package of FHIR data, I want to make sure that the attributed provider doesn't see that specific information that I have deemed as sensitive. So when they opt out at runtime, the data basically is redacted, and the redacted version is sent back over the wire to the provider. We're not changing the source record, mind you. We're just changing the data on the wire before we return it back to the calling entity. In this case, the provider.
Got it. Well, thank you, Shane. As I led off, you're very entertaining. You really bring the subject to the forefront. Thank you so much. And thank you to the WEDI membership for joining us today. I'm going to turn it back to Michael to close us out.
Thank you, Mike. And I will take that ball and hand it off to our Executive Director, Rob Tennant, who will close today's conference.
Thank you, Michael McNutt, and thank you, Michael and Shane. That was an excellent presentation. I especially liked the case studies and actually showing what the clinician will see in their workflow. I think that's very helpful because there's a lot of jargon, but it's nice to see that it actually works. So with that, we will close day one of our spring conference. We appreciate all of you attending and staying till the end. The action begins again bright and early tomorrow morning. We'll start off about 9:45. I did want to remind you that we are very excited for our first presentation at 10 a.m. It's going to be leading with impact strategies for women to thrive in health IT leadership. So you will not want to miss that. And with that, I'll say good evening and look forward to seeing you all tomorrow at the WEDI Spring Conference. Thank you.